colleagues start coming, but as always, we want to start in time. And also because as yesterday, we want also to finish in time and respect all breaks. That's very important for you. I mean, you see, that's not a very summerly morning. I mean, it's not very warm, but the weather is getting better, and everyone told me that after next Sunday the weather will be perfect. So, well, anyway, but today it will be better than yesterday. So, first of all, many thanks to you all. Thanks to Meneveau. Thanks to you all for. I think we had a very successful day yesterday, not only in terms of the content of the presentations of our faculty, of our young colleagues, whom I really wish to congratulate once more. It was two very professional sessions, excellent, and I'm sure that that today it will be the same, and then tomorrow we will have some small prizes, but all abstracts were very well presented. And today we will continue. And I kindly ask all faculty and, of course, all presenters later to please do not forget the time. If we exceed, we just eat up the time from the breaks, and that's not very fair, or from the next speakers, then we put pressure on the next ones. So today we will do it like yesterday. We do not have official moderators for the faculty sessions, for the seminars. So Cecilia and David, right, you have coordinated what you will say and how you will say it, and then we will have a discussion. The whole duration is 40 minutes, as you know, not 40 minutes each, but 40 minutes total. And then with Lilian and Michael, Lilian Meijboom and Michael Sproule. So Lilian is here, of course, and Michael will again be connected. Yesterday it worked very well. And then we have Nicolas, who will be talking about acute right heart failure. Then we have our break. And the second part will be, let's say, moderated first by Meneveau. We have Andrew Sharp and Marcel Levi. Welcome, Marcel. Thank you very much for being here. And we will only have moderators. So Karin and Nicolas will be the moderators of the abstract session. But we will come to that later. So no further speaking, and I hand over to Cecilia and to David.
Thank you, Stavros. Good morning, everyone. And first of all, I don't know whether Stavros made me a real gift to ask me to speak after the session of yesterday with Menno and Stefano concerning home treatment and low risk and so on. But now David and myself will make a good job, okay? So let's start, my friends, with the clinical case, because we have to see whether we know all what we have to do in the clinical management of a patient with acute PE. So we are physicians, first of all. So this is a male, he is 56 years old, and he is admitted to the emergency department for chest pain, lasting from about 6 hours, no fever, no cough. The pain is continuous and is pressing in the chest. So this is the hemodynamics, so blood pressure is fine, heart rate is 82 beats per minute, and oxygen saturation is fine in room air. But the patient has a medical history, and he had an ischemic heart disease some years ago, and he underwent a revascularization, so he is on beta blockers. So the first point for an emergency physician is to exclude a recurrence of coronary syndrome. So, you know, the goal is to have a 12 leads ECG in 10 minutes, and this is the ECG. No signs of the previous myocardial infarction, no signs of acute heart ischemia. And the second step is to get enzymes, so normal troponin. And this is the point, I don't know whether this physician was very lucky or very smart, because he also required the dimer assessment, and the dimer was increased. So the scenario changed a bit, and the patient underwent CT angiography of the chest, and this is the result. So as you can see, the patient had an embolus in the lower branches of pulmonary artery in the right lung, and some other defects, non-occlusive, in the left lung. So let's start with the point, because this is the point. So what to do in these patients? He has pulmonary embolism, he is hemodynamically stable, he has a good oxygen saturation in room air. So what would you do? Do you think that we need a clinical model? What do you do in your clinical practice every day? So do you use a clinical model for these patients? And I prepare some, let's say, some issues. Yes, because we use clinical models to identify low-risk patients. Yes, to identify high-risk patients. Or no, because this patient has a previous myocardial infarction, so I had to admit these patients because the risk of death is not low. Or, and this is the last possibility, you don't know, you want to check again the guidelines. So who is for the A answer? Please raise your hand. Okay, 15%. Who is for B? 5%. Who is for C? So the patient needs to be admitted because he has previous medical history. So someone is for C. Okay, let's see what happened. We have to, Stavros didn't answer. You want to check the guidelines? You want to check the guidelines? Okay, that's fine. So, clinical models. PZ and simplified PZ. I will not go through the story again because I know you know the story very well. PZ is more comprehensive, but is, let's say, a bit complicated to be reminded in everyday clinical practice. So David simplified the PZ score in order to make it feasible, to make it easier to remind in our everyday practice. And the simplified PZ score only includes 6 variables. These scores were externally validated, and a huge effort was performed in order to get definitive data on the accuracy of these scores. And what we know is that when you stratify a patient by means of the simplified PZ score and the patient is at low risk, so has no one of the items, then the expected risk of death at 30 days is 1%, about 1%, with an upper margin of the 95 confidence interval that is 2%, about 2%. So this means that the risk is not 0 anyway, but it's pretty low, 1% at 30 days of death. When you are at high risk, according to these scores, then the risk of death may be very high, up to 10%. So A and B, what is true? I have to say that if you use one of these scores, you may identify low-risk patients, but also patients that are at high risk, only based on a clinical ground. But you know, we always have an alternative. So the alternative is not a score, is let's say a set of, let's say, clinical criteria. The HESA criteria are pragmatic. It's not a scoring system, but this is just some clinical criteria. So does the patient need oxygen? Does the patient require thrombolysis? Is the patient hemodynamically unstable? So if the patient has none of these criteria, Meneveau says you can manage this patient at home. It's different from, say, it is at low risk, but the patient can be managed at home. And if you compare, what does it happen if you stratify your patients by means of PZ, simplified PZ, and HESA? These are retrospective data, but overall, you have to conclude that all these prediction rules, models, pragmatic criteria are really sensitive in order to identify those patients that will die in the short term. The sensitivity is up to 100% for simplified PZ and HESA, with a positive predictive value that is pretty low, as you can see. But what is really important is the negative predictive value. So if the patient is at low risk, based on one of these scores, be sure that he really is at low risk. Then, what should we do in our clinical practice? The HESA score, the simplified PZ, who is the winner? And this is a randomized clinical trial that has been run, that has been published recently. Hemodynamically stable patients were randomized to be triaged by means of Hestia or by means of the simplified PISI score. Overall, these trials include over 1,700 patients, so it's a large study. And if we look at what happened, the simplified PISI score was able to identify more patients as being at low risk. About 48% of the patients were identified as low risk based on the simplified PISI. The Hestia was more conservative. As you can see, 39% of the patients were deemed to be at low risk. This is important, in my view, to notice this 50%, because probably this population was really at low risk. Because, you know, when you try to apply the simplified PISI score to the overall VIII population, then you finish with 30% of the patients at low risk. In this case, you have almost 50%. So overall, this is a really hemodynamically stable population, really a good set of patients for potential home treatment. But then let's make a step forward. When physicians should decide whether to manage the patients at home or to admit the patient to the hospital, then there was no difference in the proportion of patients managed at home among those who were triaged by the Hestia model, or Hestia criteria, 38%, and those who were triaged by means of simplified PISI score, 36%. So something happened in the mind of physicians that anyway discouraged to send home about 12% of the patients that were anyway at low risk for death, according to the score. So it means, again, that probably we need a score because it's really, let's say, helping in clinical practice, but maybe that physicians also have additional criteria to select patients for home treatment, and maybe that these criteria are already included in the Hestia criteria, maybe. Let's think about, the care, the possibility of the patient to have adequate care at home. This is not included in the simplified PISI, but it is one of the points of the Hestia. And if we look at what happened in terms of clinical events, so death, recurrences, major bleeding, the rate was low for all patients included in the study, 3.8% in the patients triaged by Hestia and 3.6 in those patients triaged by simplified PISI. But overall, in those patients who were really managed at home, this proportion were as low as 1%. So overall, if you have a patient that is at low risk, and if you decide to treat this patient at home, the rate of, let's say, major events you have to expect is about 1% according to this specific flow. So the second point, as far as we know what we can get by the score. Do you think you want to assess right ventricle dysfunction anyway before discharging your patient? So this is the debate of yesterday in your, let's say, in your workshop. So after the session with Menno and Stefano, who is requiring an assessment of right ventricle dysfunction before sending the patient home? Please raise your hands. Menno, you didn't win. Okay? And who is for no, because it doesn't change my clinical practice? Okay? Okay. And who think that the patient anyway needs some heparin, so I want to admit the patient, make some, additional check? No one requires heparin. So this is another point. And Stavros will check the guidelines. Okay.
Presented their new ultrasound device, which is from the Netherlands, and which now with the tablet can check the right ventricle within 30 seconds. So
30 seconds.
A two-ton machine there and doing an echo. So that's just.
Yeah, I know that you can get in the pocket. I don't know. Yeah. So let's go and see what the guidelines say. The first row is the European Society of Cardiology, and these guidance say, okay, if you are sure that your patient is at low risk, then you should consider early discharge. You know, according to the ESC guidance, low risk means simplified PZ score, or anyway, low risk according to a score, and no signs of right ventricle dysfunction. But it's really interesting to look at another, let's say, an alternative, and the American Society of Hematology say, okay, if the patient is at low risk for complication, you can consider home treatment. But then there is a remark. Clinical prediction scores have, at best, a moderate ability to predict patient outcome and do not replace clinical judgment. So this is, I think, something that we should take in mind, because this is a remark. So, okay, you can use the scores, but please don't forget your clinical judgment. And this is maybe what Meneveau was saying when he raises his hand. So when we look at what happened in 900 patients with symptomatic, objectively confirmed PE, in terms of 30-day mortality, if you stratify these patients according to the ESC 2014 models, it means that low risk is identified only by means of simplified PZ. Well, I have to admit that the simplified PZ works very well, because again, mortality in this low-risk group was very low. Only one patient died. But what was intriguing is that these unique patients had RVD at CT and at echo. This is the reason why we decided to run an individual patient meta-analysis to go deeper inside this issue. So whether right ventricle dysfunction is really important for my patient after I stratify this patient as at low risk for death in the short term. So about 5,000 patients were included, 5,000 low-risk patients were included in this meta-analysis. Low risk was defined according to simplified PZ or PZ score. And then we went through the specific clinical value of RVD in order to predict short-term mortality. That means 30-day or in-hospital mortality. As you can see from this table, either you evaluate right ventricle dysfunction by reimaging, by biomarkers. All these findings are associated with an increased risk for death, about 4-fold increased risk for death in these low-risk patients. The only exception was CT scan. As you can see, this is the smaller group anyhow. But what is important in my mind is that even when the patient is at low risk according to the scores, still there is a residual opportunity to re-stratify. Is it just an elegant, let's say, publication, or is it something that may influence our clinical practice? So if we look at absolute rates, these patients anyhow have a low risk for death. Because you know that you can see that when you have right ventricle dysfunction by either imaging or biomarkers, then mortality is 1.5. When you don't have right ventricle dysfunction, then mortality is 0 point something. So mortality is low in both the groups. But what I get for my clinical practice is if that I want to send this patient home, I want to be sure, I want to be on the safety side. So I prefer to have this assessment before getting a decision. And the other point is whether we may have, let's say, combination, an addictive prognostic value of combining these different assessments, BMP, echocardiography. Overall, what we can conclude is that we can ultra stratify, so low risk by means of scores, the absence of echocardiography, still the presence, for example, of increased troponin is associated with an additional difference. If you have the patient without right ventricle dysfunction and imaging, but this patient has increased troponin, the risk for that is 2% in comparison to 0 point in case of normal troponin. So again, this is like, I don't know, like a joke. You can re-stratify. So the point is whether this is clinically important. And again, I should admit that before sending the patient home, I want to be sure. I want to be on the safety side. As Stavros was saying, now we have pocket echocardiographies, so we can do this kind of examination. I think that my young doctors, not the old doctors, but the young doctors, are all able to get a look to the right ventricle. We are not asking to make complicated examination, but just to see, to look at the signs of right ventricle overload. The last question, the last point, is whether we can make something more or whether we have all what we expect in order to re-stratify. Again, mortality is pretty low. We are talking about 1%, 1.5, so it's difficult to go to make better, okay? So one can say, okay, no, mortality is low, I cannot do better. Or you think, no, I don't want to do anything more because it doesn't change clinical practice. Or you want to reach risk of death, 0. So who is for A? Can we do even better than what we have? Even better than RVD, than the scores? Who is for A? No one. No. Stavros say, yes, we can do better. No. Okay. So who is for B? 5%. Who is for C? I think someone is still didn't wake up still, but anyway, there is someone for all of the questions. So one issue is to go further, because you know that when you use a score, you use a specific cutoff. And these cutoffs are derived from clinical studies, but anyway, you know you can rethink about these cutoffs because they are arbitrary anyway. And this is something we did with Mareike Lankate in Italian data, the first table, and the other one is our data from the VIII study. So you can change the threshold. You can decide to re-stratify based on some of the parameters of the score. So if you look at what happened in hemodynamically stable patients, when you change the cutoff level, and this is in hospital adverse outcome, then you can see that by increases the heart rate, the rate of clinical events increases. The other, let's say, point is that when you increase the heart rate, it is not, let's say, increasing at the same level the odds ratio, because mortality, you know, is a let's say a multi-level assessment. So you can do better by changing the threshold of heart rate. So we could rethink about this point. When we try to see whether after excluding high risk based on the score, after classifying RVD, we could add some other predictor of that, we were not able in our meta-analysis to identify further significant predictors. But you know, again, we are talking about subgroups, and the power of the analysis may be reduced, because if you look at the odds ratio, being older is associated with an increased odds ratio. Having higher heart rate is associated with an increased odds ratio. So maybe that in the time when we will be able to collect very large groups, we will be able also to re-stratify after assessment of the scores and of right ventricle dysfunction. Another point is the presence of deep vein thrombosis. This is another issue that is not included in any score. The localization of emboli, this is really something that we need to understand better, because as you can see, we have discordant data in the literature. So I'm not convinced this is the way to go, but anyway, I'm open to anyone that will show a different result. So in my opinion, localization of emboli is not the right parameter in this specific context. Other clinical predictors, renal function. Our colleagues recently have shown that also in those patients at low risk, according to the score, the presence of impaired renal function may be an addictive predictors, an addictive, let's say, parameter to re-stratify again. The last point, and this is my last slide, is whether we know exactly what right ventricle dysfunction is, so whether all parameters are the same, so whether we should think about this point. So echocardiography, all my young doctors may perform echocardiography. Is dilation the same of pulmonary hypertension, the same of TAPSI, the same of... Because you know, in clinical studies, the definition of RVD is really heterogeneous. So I hope that in the next months you will be able to read this meta-analysis of ours. So what we found out is that not all individual parameters are the same, but again, this is something that we should, let's say, validate in prospective studies. And the last is just to say that we have recently completed a registry, an Italian registry with 5,200 patients with acute PE, and I hope that something more will be possible to observe in these specific cohorts. Thank you very much for your attention.
So thank you very much. If you don't mind, I will go to my room and I will give this talk through a Zoom meeting. This is what I've been doing during the last year. If I can get my first slide. I'm going to present a second case because we, Cecilia and myself, agree that another gray zone for risk stratification of patients with acute symptomatic pulmonary embolism is identification of intermediate high-risk PE.
Is that it?
Perfect, thank you. So this is my patient, 76-year-old man with pleuritic chest pain and shortness of breath. At the time of hospital admission, you can see that heart rate was 116, systolic blood pressure was 99, and saturation while breathing room air was 93%. Creatinine clearance was 38, and I don't know why we perform. Well, I do know why we perform a D-dimer, because we perform D-dimer to 100% of patients in the emergency department. Was positive, 3,122. So we decided to perform a CT angiogram, no news on this. And you can see this big clot in both pulmonary arteries, with the so-called saddle pulmonary embolism. According to the clinical guidelines, you can see here another view, and according to the clinical guidelines, we should look at the right ventricle in the CT angiogram. And here is the right ventricle, which was much larger than the left ventricle in the CT scan. So if we go to the European Society of Cardiology guidelines for risk stratification of patients with acute symptomatic pulmonary embolism, this is a patient with a positive simplified PESI because of tachycardia and mild hypotension. There was right ventricular enlargement in the CT scan, so we should perform a troponin test. We were very obedient and we performed this troponin, which was positive, 0.3 nanograms per milliliter. I have to confess that we do not trust so much the CT-assessed enlargement of the right ventricle, particularly when we are considering the possibility of reperfusion therapies. And this is the reason why we perform an echocardiogram for this particular patient. You can see the D sign with a flattening of the interventricular septum and the famous McConnell sign with hypokinesis of the free wall of the right ventricle. So, this is a number of questions. First one, which is the short-term prognosis of this gentleman? According to the clinical practice guidelines, this is a patient with acute PE and intermediate high risk of short-term complications. Number two, would you recommend full-dose systemic thrombolytic therapy for this particular patient? If we follow the most recent guidelines, the European Society of Cardiology guidelines or CHEST 2021 guidelines, this patient should not receive full-dose systemic thrombolytic therapy. according to the Patho trial and according to different meta-analyses published so far. And finally, would you order additional prognostic tests for this patient? I would like to start by saying that it is important to risk stratify patients with acute symptomatic pulmonary embolism, and it is important to identify patients with intermediate high risk for short-term complications. And the reason is that these patients who are hemodynamically stable at the time of PE diagnosis might deteriorate soon after diagnosis and initiation of anticoagulant therapy. And these patients might benefit from monitoring or even for some type of reperfusion therapies. And this is my definition of intermediate high-risk pulmonary embolism, particularly if the aim of identification of these patients is to provide intervention therapies. Confirmed PE, normal blood pressure, and an increased risk of hemodynamic deterioration or PE-related mortality. Very close, very similar to patients with PE and cardiovascular instability, the so-called high-risk pulmonary embolism. And in my humble opinion, the combination of right ventricular dysfunction and myocardial injury is not enough to meet this definition for intermediate high-risk pulmonary embolism. Of course, that we know from many years that the combination of a positive troponin and right ventricular dysfunction is associated with an increased risk for short-term PE-related mortality when compared with each of these tests alone. This is a study by the Boston group. There were very similar studies by Stavros and his team showing that the combination of myocardial injury and right ventricular dysfunction is associated with worse prognosis. But for instance, this is the patient in the Patho trial according to the table 1 in the New England Journal of Medicine publication. 66-year-old, heart rate was 95 per minute, systolic blood pressure was 131. Moderate echocardiographic right ventricular dysfunction in half of the patients and a slight CT-assessed right ventricular enlargement. And patients with this tiny clot could be enrolled in the Patho trial. And in my opinion, this is the reason why the 30-day all-cause mortality in Patho was so low of 2.8%. But this patient is also a patient with intermediate high-risk pulmonary embolism. 71-year-old, heart rate 115, systolic blood pressure 93 millimeters of mercury, concomitant residual deep vein thrombosis, troponin 3.2, lactate 2.6, this huge clot in the CT angiogram, and this enlarged right ventricle in the CT angiogram. And what about if our patient had concomitant residual deep vein thrombosis? We know that this is associated with prognosis. We published this study many years ago along with Stavros, and we were able to demonstrate that the combination of concomitant deep vein thrombosis, right ventricular dysfunction, and myocardial injury was associated with a significantly increased risk for 30-day PE-related mortality. And we hypothesize that embolization of residual deep vein thrombosis might destabilize these marginally stable patients with acute symptomatic pulmonary embolism. And there is an additional concept, and it is the combination of markers, biomarkers, imaging testing, and clinical variables. This is the BOBA score, but the concept is identical for the FAST score and for other scores. And you can see it here that the combination of mild hypertension, tachycardia, right ventricular dysfunction, and myocardial injury was able to identify patients with a huge risk for short-term PE-related complication as compared to those patients who only had right ventricular dysfunction and myocardial injury. And in fact, this concept was nicely applied by Stefano Barco in this post-hoc analysis of the Catheter trial published in the European Respiratory Journal. And among this population of intermediate high-risk patients with acute symptomatic pulmonary embolism, they were able to demonstrate and to find additional risk factors for short-term complications. And these independent factors were systolic blood pressure less than 110, chronic heart failure, and respiratory rate more than 20 per minute. And in fact, this study was used to design the Catheter 3, which is now enrolling patients. I think that there are some gray areas in the identification of intermediate high-risk patients with acute symptomatic pulmonary embolism, and Cecilia touched on some of them. Number one, are tests interchangeable? I think that we still don't know if we can use CT scan versus echo versus BNP to identify right ventricular dysfunction. We don't know if we can use troponin or HFABP to identify myocardial injury. Number two, I think that we need I don't know if saying better, but a standardized definition of echocardiographic right ventricular dysfunction. As Cecilia said before, we had so many combinations of echocardiographic parameters to identify right ventricular dysfunction as studies that have been published. Number three, I completely agree with Cecilia that we need to modify our cutoffs according to what we want to do with the patients. To identify intermediate high-risk patients, we might modify our cutoffs for the heart rate, for the right ventricular enlargement, and so on. This is a very recent study from the Catheter trial, and the message of this study is very simple. Heart rate is associated with prognosis in pulmonary embolism, nothing new. But the important information is that this relationship is linear. It is not a U or a J relationship. In other words, if you have a heart rate of 120, that is worse than having a heart rate of 110. And if you have a heart rate of 130, that is worse of having a heart rate of 110. And finally, how to monitor response to anticoagulation. We recommend monitoring of patients with intermediate high-risk pulmonary embolism, but do we have to repeat echocardiography every day? We have to order troponin testing every day. It is enough to monitor for the heart rate and for the blood pressure. Though we have some information published last year, I think that we don't have a definite answer for this. So this is my final slide. I will say that intermediate high-risk pulmonary embolism is a spectrum of disease. And probably the accumulation of risk factors, heart rate, right ventricular dysfunction, myocardial injury, residual deep vein thrombosis, elevated lactate, syncope, respiratory insufficiency, and others, and the severity of risk factors might identify patients with a risk-benefit ratio for full-dose systemic thrombolytic therapy. We still don't know if this subgroup of patients is large, is small. There is no subgroup of patients who might benefit from full-dose systemic thrombolytic therapy. And we still don't know if other interventional therapies with a lower risk of bleeding, such as moderate dose systemic thrombolytic therapy or even local therapies, will modify this risk-benefit ratio. So I will stop here. Thank you very much for your attention.
Thank you very much, David and Cecilia. Maybe you would like both to come to the podium. We have very few minutes for a few questions. So my first remark is that these spring schools are becoming boring because, you know, we had fierce discussions about what is stratification, risk stratification of PE, and now I think we agree on most things. So this is this is the new post-democratic phase. So that is really great. However, as both Cecilia and David pointed out, of course there are gray zones that remain. This does not mean that everything has been resolved. And so please, we have a couple of minutes for some questions from your side? We also have the workshops, of course, where you are closer to our experts. No.
You thought that you all agreed, but no. So coming back to your meta-analyses, you know, they're beautiful, they're published. But tell me, do you really think that they are based on 1A evidence, or is it less evidence, and is it aggregate post hoc knowledge, which you did into a magician box and out came a very nice result? It's provocative, but nevertheless, both of you should answer.
Yeah, I start, Menno. May I? Okay, so I don't know whether it's 1A, 1B, or what else. I think that having individual patient data allowed us to look at combinations of markers and look at subgroups, okay? So obviously, we need a following step. Randomizing patient and see what happens if you treat in a way or in the other. What I think is that our meta-analysis is conclusive in defining the role of right ventricle dysfunction as predictor of prognosis, also in patients with low risk PE. So this is my point. Is it 1A? I don't know. Will it change clinical practice? From my side, yes. If I have to advise emergency physicians to discharge patients, I probably would say, before discharging, look at right ventricle.
Well, I agree with Mena that also for prognostic studies you have different levels of evidence, and level 1, if I remember right, means application of these prognostic models in management or in randomized controlled trials. So this is my point. We have this information, and this information is very useful to design trials to confirm our hypothesis.
I have also a brief comment here before handing over to Piotr. First of all, may I ask the audience, who of you has read Asterix? So quite a lot of people, so you know the beginning. So the Romans have conquered all of Gallia, not all, one small village resists. Irreductible. So what I want to say, very brief from the point of view of guidelines. So this village is now what is currently north of France, not France itself, but anyway. So what I want to say is, of course, I do not think the question is about 1A evidence here, and of course Menno is right. I mean, this is not that these studies, these are two different questions. I think we make a mistake, sometimes involuntarily, sometimes deliberately. We put as identical the risk stratification and the early discharge. This is not the same question. These are two questions that overlap, but it's not the same question. Of course, none of these studies, and no study has shown that these must be the criteria, otherwise people cannot be discharged, or this is, but it is evidence, it is growing evidence, and I believe we can agree that the importance of right ventricular function and dysfunction is here. It is important. Acute pulmonary embolism is an acute cardiovascular syndrome. So I hope that in the community this is known. And especially since Cecilia said now it is in all over Europe, and it will become, this is a fact, it will come in all over Europe. Those people who work in emergency departments and intensive care units will be obliged, will have to do a small ultrasound examination of the heart or of the chest to have a look at the right ventricle. This is the only rule to decide whether the patient will be discharged or not. Does it mean we have standardized or parameters? It doesn't. But I think we should agree that this is some information that we can no longer ignore, or I'll say does not exist. Piotr, you wanted to say something?
Thank you for the very excellent presentations. I have some questions. We can also... one question. We have echocardiographic abnormalities in patients with, let's say, normotension. There are two goals. One, to select patients at higher risk, and the second goal, to send home. Do you think that echocardiographic cutoffs of right ventricular dysfunction can be the same for both purposes? This is the question to
We don't know. It's a gray area.
This is a gray area.
From a theoretical point of view, I will say no. If we are chasing different objectives with the patient, one home therapy and the other one reperfusion therapies, I will tend to select different cutoffs. At least in my clinical practice, I rely on gross abnormalities in the right ventricle, in the echocardiographic right ventricular assessment before deciding reperfusion therapies. And on the other hand, what I look for in patients with low-risk pulmonary embolism is normal the right ventricle, normal troponin, normal BNP, everything in the same direction.
Thank you very much. Any other brief burning question? Then we will continue. Our experts are also here, as I said, at the break and also at our workshops, so that you can have more interaction. Thank you thank you both so much for this really very beautiful, very competent first session. So now we are getting a little bit more complicated, not complicated in terms of content, of course, sophisticated, but complicated technically. But I think we can manage it. We have shown it before. So we have Dr. Lilian Meijboom and Dr. Michael Sproule. So Lilian, will Michael begin? So how have you organized this? He's starting. Okay. Michael, can you hear us?
Yes, I can. You can hear me?
Perfect. So how is the weather in Glasgow?
It's a beautiful morning. A little bit dark.
So what's the temperature actually?
Oh, it's fine. It must be about 14 degrees. It's mild. It's nice.
So 2 to 3 degrees less than here. So okay. So perfect.
Okay. I know. I would like to be there. Anyway, I don't feel so bad about not being allowed to travel now, because as I said yesterday, I wouldn't have been able to get on the plane because of my daughter's COVID. So I don't feel so bad about it anyway.
So we hope you are well. And so Michael, you can start, and I remind you both that we have, we have 40 minutes total. So please start, and then Lilian will take over. Thank you.
Okay. So my wife's a pathologist, so I get to see some certain things that most people don't get to see. And I guess this is what we're trying to avoid, isn't it? Post-mortem specimens with acute pulmonary embolism, big thrombus here in the lower lobe pulmonary artery, and a big infarct. Right, so what I'm going to do is very, very briefly, one slide, look at the clinical problem with a kind of slant from a radiologist perspective. Then we'll have a look at the imaging modalities. Now we'll just touch on chest radiography and VQ scanning before really talking about CTPA. I won't talk about Doppler ultrasound because of time, and obviously conventional pulmonary angiography has been superseded. And then we'll finish off with a bit of discussion about CTPA and whether we think it's a good thing or a bad thing. Okay, clinical problem, just very briefly from a radiologist perspective and why I think we are where we are. Obviously, it's a very, very common condition. We're not sure about the exact morbidity and mortality, but we know it's certainly very, very high. We know that with effective therapy, we can avoid death. We also know that presentation can be subtle, and that the majority of preventable deaths are due to misdiagnosis rather than failure of treatment. Much more common scenario, though, of course, is that pulmonary embolism is suspected all too commonly, and because of that, it's investigated so commonly. And here's a thought that apparently venous thromboembolism is the single largest area of medical litigation, and that obviously makes all of us feel a little bit shifty. But for all of these reasons, there's a climate very much which encourages the over-investigation and over-diagnosis of venous pulmonary embolism with all the associated problems, including anticoagulant therapy and the complications of it. Okay, let's quickly start with chest radiography. So obviously we've been doing chest radiographs for a long time, and every patient that comes in with acute pulmonary embolism does get a chest radiograph. So is it of any value? Well, there are some relatively specific and non-specific abnormalities associated with them. And probably the most famous is this one here, the Westermarck sign. And if we come to the workshop this afternoon, we might discuss the Westermarck sign, but it's visible oligemia in a chest radiograph. And if you look very close at this radiograph, if you compare the vascular markings in the right upper zone with the right lower zone, you'll see there is quite a difference in them. Now, if you come to the workshop this afternoon, I'm actually not a believer that this sign exists in acute pulmonary embolism. I think it exists in chronic pulmonary embolism, but it's always quoted as one of the signs of chest radiography of acute PE, and it's passed down, this wisdom is passed down from generation to generation. But anyway, we can discuss that this afternoon. There's another rare presentation of acute pulmonary embolism. This is unilateral pulmonary embolism causing unilateral pulmonary edema. And over coffee, maybe you can discuss which lung the pulmonary embolism is in and why the patient gets pulmonary edema. The truth, of course, is that the chest radiograph is not useful in diagnosing pulmonary embolism, but it is useful in excluding other causes of acute chest pain and breathlessness. And I'll just show you one example here. This was a case that came in a couple of weeks ago, young woman with chest pain, query pulmonary embolism, and I think you can all see the pneumothorax here in the right lung. But for the radiology enthusiasts amongst you, you might notice that the lungs themselves don't look normal. There's a kind of coarse reticular shadow pattern there, and on the CT scan that was subsequently done, you can see the cystic lung disease there. So this is a case of lymphangioliomyomatosis. On to VQ scanning briefly. So it was the mainstay of diagnosis for about 30 years until about the mid-30s. It's obviously very useful if it's normal, highly, highly reliable. It's also highly reliable if it's high probability combined with high pre-test clinical probability. But you can get false positives, obviously, with chronic thromboembolic disease rather than acute thromboembolic disease, and also with a number of other rare conditions. So there's our nice normal scan. Perfusion at the top, ventilation at the bottom, and there's a patient with acute pulmonary embolism, obviously normal perfusion, and these big wedge-shaped defects in the perfusion scan. But as I say, you can get false positives, so this is a case where, again, looks very much from the point of view of reporting the VQ scan, you would just say it's high probability, there's a normal perfusion scan, and big wedge-shaped defects in the, normal ventilation scan, but big wedge-shaped defects in the perfusion scan. But here's the CT, and the patient has lymphadenopathy, they have a pleural effusion, and on the lung settings, they have these smooth interlobular septal lines. So this is not pulmonary embolism at all, this is pulmonary veno-occlusive disease. Because the main problem with VQ scanning is these large number of indeterminate or low probability scans. This, by the nuclear medicine physicians, will tell us that this is completely counteracted. This is a thing of the past because of the development of VQ SPECT. That allows a multiplanar tomographic imaging of the lungs. And instead of having the probabilistic report of, high probability, intermediate, low probability, we can now, apparently with VQ SPECT, I don't report these, of course, it allows us a diagnostic conclusion that is binary with respect to PE with very few non-diagnostic reports. That's from the recent guideline from the European Society of Nuclear Medicine. And these are the figures that are quoted for acute pulmonary embolism. I mean, absolutely, eye-watering figures of sensitivity and specificity and rates of non-diagnostic rates. So they're telling us that with SPECT VQ, you can get a binary report with respect to acute PE. This is your SPECT VQ scan. So these are obviously coronal, sagittal, axial images, and you can scroll through them on a nuclear medicine workstation. At the bottom, you have the quotient images, which really just match the ventilation and perfusion. And as long as they're matched, you get this nice uniform blue color. And here's a patient with acute pulmonary embolism. And where they're not matched, you get this red and yellow color. So you can see that there's mainly in the right lower lobe, but elsewhere as well, there are big perfusion defects. I think you need to have a big word of caution here. Although the guideline gave us these nice figures, in amongst it, in the small print, it was talking about VQ SPECT with holistic interpretation. I think those are kind of weaselly words for really talking about the best possible scenarios. So if you have experienced clinicians, you have all the clinical physiological information, you've got enough time to review all the imaging, then yeah, I'm sure you can get results with a very high sensitivity and specificity. But the reality of an acute department is that doesn't happen. I mean, we're doing somewhere in the region of 400 CTPAs a month. So in my experience, to improve sensitivity of SPECT VQ is at the expense of specificity. Okay, on to VQ scanning, which is obviously the main body of what we want to talk about. Okay, sorry. What we can say about VQ scanning is that there are relatively few inconclusive scans if they're rigorous case selection. We can say that it's safe. We know that it can be used when patients have allergy to contrast media. We know there's no issues with contrast nephropathy, and there's a low radiation dose. And that's not a small issue. I'm not an expert in medical radiation, but it is an ongoing issue, isn't it, that causes great concern. And in the context of CTPA, it's the dose, not to the patient overall, but to the female breast. And if you look at the figures for mammography versus VQ scanning versus multi-detector CT, then there's really talking about a sort of 50-fold increase between mammography and multi-detector CT, and enough fuss is made about the dose to the breast with mammograms. So in the case of pregnancy, the recommendations is that because the D-dimer is frequently positive, it's a lower limb ultrasound followed by a perfusion scan. Don't bother with the ventilation scan. And it's a trivial dose to the fetus, which doesn't matter, but it does spare the maternal breast. Now, here's an interesting point. This is a statement from the Fleischner Society in 2007, which has not been updated since, saying women of reproductive age, if the D-dimer assay is positive, VQ scanning plus or minus lower limb ultrasound are appropriate as the next imaging test. I don't think that happens very often. Right, on to CT pulmonary angiography. That wasn't yesterday. Okay, so it's fast, it's available, particularly out of hours. It's highly sensitive and specific. Crucially, it allows other diagnoses to be made, and we know that the vast majority of patients with query PE have alternative diagnoses. It allows visualization of small arteries, and it replaced conventional pulmonary angiography many years ago as the reference standard for acute PE. So radiology talk, so we'll have to quickly squiz through the findings that we see in acute PE on CTPA. This will just take us a minute or two. So that's the Pullman sign, so the central thrombus. We'll get different findings with acute pulmonary embolism, and obviously we'll see them shortly. More often though, the pulmonary embolism is eccentrically located within the vessel. So it's next to the vessel wall where it forms an acute angle. And if you see the thrombus in long axis, you get this tram track appearance. Acute pulmonary embolism, like acute DVT, causes the vessel to dilate because you get an enlarged vessel. So if you see complete filling of a vessel, but it's dilated in relation to its accompanying bronchus, then that's another sign of acute pulmonary embolism. Obviously got your saddle embolism, where it's straddling the bifurcation of the pulmonary artery. And you can see tiny pulmonary embolism, down to less than 1 millimeter. And obviously in axial dimensions, sometimes it can be very difficult to tease these out, but sometimes it can help if you've got able to reconstruct the images, where you can be more convinced, make a more reliable diagnosis. This is a pulmonary infarct, classic appearance of the pulmonary infarct, which is called the reverse halo sign or the atoll sign. So you have this peripheral consolidation with central ground glass. Now the doubting Thomases amongst you might think that I've just taken that from something else, because it's not unique to pulmonary embolism. It can occur in other conditions, such as mainly organizing pneumonia. But this is not a case of organizing pneumonia. These are the sagittal reconstructions showing the pulmonary infarct with that classic reverse halo sign with central thrombus. And obviously pleural effusion is another common finding with pulmonary embolism. So in addition to being able to diagnose pulmonary embolism with great sensitivity and specificity with CTPA, you can also make an estimation of the severity of the risk stratification. This is usually done by looking at right heart strain, and there are a number of parameters that we use. You can also quantify the thrombus burden, but I've never heard of that being done in clinical practice. So there's our flattened and displaced interventricular septum, obviously right ventricle large compared to the left. We've got an enlarged main pulmonary artery and reflux of contrast into the IVC. So these are all features of right heart strain in patients with acute pulmonary embolism. As I mentioned earlier, you can make alternative diagnoses, and you can also have a look at the deep veins. So we know most patients referred with query PE will have alternative diagnoses, and most of the time these will be revealed on CTPA, and there's a wide range of findings that we're able to make a positive diagnosis in. This was a case with a patient that had a gated study. So it's a so-called triple rule-out to exclude pulmonary embolism and coronary artery disease and aortic disease. There was no evidence of pulmonary embolism, but the right coronary artery didn't look too good on axial section there, and then we reconstruct it in a coronal section. You see the multiple stenoses and occlusions in that right coronary artery, and the patient went on to have a coronary angioplasty. This was another case, a great case from about a month or so ago. So in addition to lots of acute pulmonary embolism, it was in both lungs, and there were pulmonary infarcts as well. There's also that thrombus protruding into the left atrium. So this is a paradoxical embolus through the patent foramen ovale. And if we go a little bit lower, we can see that there was thrombus in the splenic artery, and there are splenic infarcts there. And if we go a little bit lower still, we can see the thrombus in the common femoral vein and the great saphenous vein. So CT is, unquestionably a very, very powerful and useful tool. But is it a problem? Well, you can make a case for it being a problem. The first thing is that great care needs to be taken in interpreting the result when there's discordance between the pre-test clinical probability and the CT result. And this is something which goes all the way back to 2006, the New England Journal, PIOPED-2 results, and it may be that the people in the room are fully cognizant of this, but I think the majority, it strikes me that an awful lot of people involved in acute medicine are surprised when I discuss these results with them. So it's a table obviously looking at the negative and positive predictive value of a negative and positive CTs in relation to clinical probability. Now, clearly, if you've got a low pretest clinical probability and a negative CT, then the negative predictive value is excellent, it's 96%. But if you've got a high pretest clinical probability and a negative CT, then the negative predictive value is pretty dismal at 60%. And conversely, if you have a high probability pretest probability, clinical probability with a positive CT, then the positive predictive value is very high at 96%. But if you have a low pretest clinical probability, then the positive CT has a very low positive predictive value of only 58%. So put another way, if your patient has a high pretest clinical probability and a negative CTPA, then there's a 40% chance of the CT being a false negative. And if the patient has a low clinical pretest probability and a positive CTPA, then there's a 42% chance that positive CTPA is a false positive. These are pretty frightening results that are there in plain view, and as far as I can see in clinical practice, it really hasn't been addressed. Anyway, next problem, is it too sensitive a test? Are we diagnosing pseudo-disease? Well, this is an article. There's been a few articles along these lines, but this was quite a good one from the British Medical Journal in 2013. And they looked at the drivers of the increased use of multi-sector CT, which is just the things that we've talked about. It's fast, it's available, it's sensitive, you can make alternative diagnoses. And it's obviously encouraged doctors to lower their threshold for looking for PE in order to miss the silent killer. There's commercial interests which have driven it. And all of this is this was 2014, I think this was published. It said it led to a 14-fold increase in the use of CTPA from 2001 to 2008 with a modest reduction in VQ scanning. And I can tell you that increase has continued. That graph has not slowed down. I know from audits that we've done here that we were doing about 50 CTPAs a month in 2015, and we're doing about 400 a month now. So the evidence for the overdiagnosis, well, the rising incidence of pulmonary embolism without an increase in major risk factors. The age-adjusted incidence of pulmonary embolism was stable for the 5 years prior to the introduction of multi-detector CT, and then increased by 80% over the next 8 years. All of this happened without a change in age-adjusted mortality. So the conclusion was we're diagnosing more pseudo-disease, that the normal function of the lungs is to act as a sieve to prevent small emboli from reaching the systemic circulation. Other problems, well, ionizing radiation, we've talked about that, and contrast nephropathy. Now, in fairness, these are maybe slightly less of a problem than they were. There's two images in front of you there. The one on the left, this is the same patient. They're about 2 years apart. The one on the left was the old scanner. The one on the right is the new scanner. The old scanner, there's nothing wrong with it, but the image is slightly grainy and there's some beam hardening artifact. New scanner, better images, and the new scanner is less radiation and less contrast. So radiation and contrast nephropathy are less of an issue, but they are still a significant issue. Pitfalls in technique and radiological error. This was diagnosed as acute pulmonary embolism. It's a fairly ghastly scan, but you can understand why the radiologist, who's not a chest radiologist, just diagnosed as acute PE. A clinician who is a respiratory physician asked me to look at it. I wasn't too happy, such an ugly scan. And when you reconstruct it on the coronal reconstructions and have a look at it on lung settings, you can see there's an enormous amount of motion artifact. Look at the hemidiaphragms moving there. So this is motion artifact. This is not a pulmonary embolism. Harm from treatment. Well, this ties in nicely with what we just talked about. So there's two issues here. First of all, there's a radiological error. This was diagnosed as an acute pulmonary embolism. It's not. It's something called interruption of the column of contrast. We don't have time to talk about why that is the case, but it is the case. So it was an overcall by the radiologist. And in addition, this was missed. I wouldn't call it a miss. It's an incredibly subtle abnormality in the intima. But anyway, as a result of this scan, the patient was anticoagulated. Chest pain got worse. Repeated the scan the next day, and you can see there's a huge intramural hematoma. And the list goes on in terms of problems for CTPA: psychological morbidity, inconvenience, cost, detection of the incidentalomas, and all the harm associated with them. So how can we do better? Well, we need to follow the published strategies. I'm reminded of something that Stavros said at another meeting that we were at a while back when he quoted the Hollywood movie with A Few Good Men with Jack Nicholson. Follow orders or men will die. Well, I think it's absolutely true. And specifically, we've got to apply the pre-test clinical score and interpret the imaging findings in light of this. And we haven't had time to discuss it, but I have done audits recently which show we're still pretty dismal at that. We should maybe consider other tests when it's a low pre-test clinical probability and patients are stable. And we haven't had time to talk about isolated subsegmental pulmonary embolism, but it is a big issue, and maybe we should be trying to not treat some patients. So I was thinking, what will we do with a conclusion? I think just one conclusion. It's a very, very powerful tool, but used indiscriminately, the balance between good and harm can be tilted in the wrong direction. Okay.
Thank you. Thank you very much, Michael.
Pleasure.
Immediately handing over to Lilian, and then we will have panel discussion. You stay with us, right? So.
Great. Yep. Yep.
Do I have a pointer?
I think what we can do is. That's yours, man.
Sorry, I didn't see it.
Oh, that's beautiful.
Come on.
Good morning, everyone, and nice to be here again after 2 years. There's a lot of evidence and a lot of... There has been done a lot of research in acute pulmonary embolism, but CTAF is even important, but it's still a little bit the smaller brother of the big ship. So, I thought, what are the comparisons between Greece and the Netherlands? And we have a lot of water, and we all love sailing. So again, this is a little bit how it goes. This is what my colleague just talked about, acute pulmonary embolisms, and this is how we want to see. Give anticoagulation after 3 months. The CT scan is without any thrombus, and the patient has no complaints anymore. However, this is in real life not what's happening. We have a big amount of patients who still have complaints after acute pulmonary embolisms. And just briefly, because then everyone is at the same level, again, how can you make the diagnosis of CTAF? By catheterization, you need to have a mean pulmonary artery pressure of more than 25 and a wedge as less than 15. Need to have at least one segmental perfusion defect on ventilation perfusion scan as you can see here by the red lines. Or by CTPA, you need a pulmonary artery obstruction. And in this case, you can see very nicely here a web in the right interlobar artery, which gives problems to all the basal segmental arteries.
Lilian, excuse me, very brief question or the request by our technical team. Maybe you could get a little closer to the microphone so that Michael also can hear you.
Oh, okay, he can't. Okay, I'm sorry. I'll talk in this one then. This is for the guidelines. It still says to do a pulmonary angiogram, and what can you see in the pulmonary angiogram? You can see the morphology, but you can also see the perfusion. And here by the yellow arrow, you can really see a nice web, so morphologic defect. But you can also see the big perfusion defect in the right lower lobe. And the most thing, patient need at least 3 months of anticoagulation. This is addressed in 2 guidelines. I will discuss them very briefly because probably you all know them. But the guideline of the pulmonary hypertension, that if patients have symptoms or sign of a history suggestive of CTAF, you need to start with the echocardiography. If there is a high or intermediate probability of pulmonary hypertension, you have to do the ventilation perfusion scan. And are there mismatched perfusion defects, then you go to refer to a PH or CTAF center, and then further workup can be done, a CTPA, a right heart catheterization, or sometimes a pulmonary angiogram. This is mostly where the expertise of the local center is. It is also addressed in the pulmonary embolism guideline. And then if patients have acute PE, and after 3 months they come back to the physician, they still have complaints of dyspnea, then they will have also an echo, and if the echo has a high probability of pulmonary hypertension, then again you go to a VQ scan. If there's an intermediate probability, then there's some additional testing you can do. Look for an elevated NT-proBNP, risk factors for CTAF, or an abnormal cardiopulmonary exercise test result. And again, you come by the old VQ scan. And then again, they say refer to a PH of CTAF expert center. The VQ ventilation perfusion scan is an old test, and it has proven its ability that it works good. But there are new techniques, and in a discussion yesterday, and some of you were there already, it's not available in every hospital, but it is a very promising technique, I believe. And this is a very nice study, and this was already performed in 2018, where they looked at dual energy CT perfusion and a ventilation perfusion scan. And what they observed, that the true positive, it was both in dual energy CT and VQ scan, it was the same. However, if you only look at the ventilation, so at the perfusion, then there were 6 false positives. But no one looks at the dual energy CT only at the perfusion. You also always look at the morphology, so at the vessels, and you look at the perfusion defects. And then you combine these 2 images in your head, or however, how you do that. And if you combine the morphology and the perfusion together, it had a sensitivity and specificity of 100% for diagnosis of chronic thromboembolic disease. So that are really good numbers. I know it is a small study, but still it is very, very promising. And this was a case of last week during my daily work, where again there was this question, does this patient has signs of CTAF? And if you can see at on the scan, if you look at the morphology, where the big yellow arrow is, you see a very tiny vessel. You almost can't see it because it's a tapered vessel. But if you see at the perfusion scan, Yodian map, you see a large perfusion defect. So this really helps in recognizing this kind of defects, this kind of disease, which is common in chronic thromboembolic pulmonary hypertension. And why is it more difficult to recognize chronic thromboembolic lesions than acute? It's because vessels kind of disappear And what is not there, people don't see. If something is there and is looking strange, they say, ha, that's strange. But when it disappeared, people just go over it because they're not used to see things what aren't there. They don't recognize it. But this really is a really helpful tool to pay your attention, see, hey, there's a big perfusion defect. Look back again and see, oh, the vessel disappeared. It's a tapered vessel, which is really a big sign for chronic thromboembolic disease. Okay, these are some other signs, and on the left side, everyone see this big mural thrombus. That's not very difficult. But more the smaller signs, like the little webs, if they're segmental, if you look at them, you can appreciate them. You will see them. But you really have to look at it and also look in different directions. Sometimes make a MIP image that make it a little bit thicker, so you can, the contrasts are a bit better, more seen. And then you can see these little defects which are seen by chronic thromboembolic disease. And even with the new generation scanners, you can even see them at subsegmental level. But you really should pay a lot of attention, and these scans cost time. If I have a scan, I have to prepare this for the meeting. It takes me sometimes 20-25 minutes to really look at every tiny vessel and describe all the lesions. And in a very big, busy practice, you really have to make time for it to do very good patient care. And also the signs of pulmonary hypertension, they can be seen on the CT scan. You really see a very dilated right atrium, right ventricle, also right ventricle hypertrophy. You don't see that by acute pulmonary embolisms. People don't have a dilated right ventricle with a thickened wall in the acute moment. It takes time for the muscle, for the right ventricle to get this increased muscle. So that is a sign of chronic disease. So if you see on an acute scan, you see a very hypertrophied right ventricle, you must think, is this really acute pulmonary embolism? Or is it acute and chronic disease? And also a very dilated truncus pulmonalis doesn't exist in acute pulmonary embolism. It takes time. And then again, you see here really the right ventricle with the high pressure where the LV is, the septum is bounced into the LV, appreciating the really high pressures in the right ventricle. The pulmonary angiogram is, the last meeting we had, we're saying goodbye to our pulmonary angiogram in daily practice. It is a very nice investigation, but sometimes also when people are dyspnoic, the images aren't always very good to judge. It does help in peripheral perfusion defects. I do agree, then it is sometimes really helpful, but it's another investigation. But here you can appreciate the morphology images and also nicely the perfusion defects. But still, we're all trying very hard, but our median diagnostic delay in CTEPH is still 14 months. So that is a very long time. And most patients see also not only one physician, but they went to the pulmonologist, the cardiologist, the rheumatologist, and finally, 2-3 hospitals, they come finally at the right place. So the perfect workup is not there yet. And it is very important, but we all appreciate, to detect CTEPH. And why is it so important? Because it's a treatable disease. You can perform a pulmonary endarterectomy where the surgeon takes out a thrombus, and also on segmental level, they can pull out a nice thrombus. As you can here see, the very nice big lump of thrombus, and the CT scan before and after, where all the thrombus has been removed. In this very nice study, we did it together with our colleagues at Leiden, and with Eric Klok, who's at the moment getting a twin, or his wife, but that's why he's not here, but we think of him. And we looked at these, we identified 6 radiology parameters as independent predictors for CTEPH. And we looked at the first scan which came in, dus the index CTPA we called that. And flattening of the interventricular septum, RV hypertrophy, intervascular webs and bands, vessel tapering, so like the vessels are getting really small, and dilatation of the bronchial arteries were all independent predictors for CTEPH. So it is important to look at these signs if patients still have, after 3 months of treatment, still are dyspnoic, look at the first scan again very precisely and see maybe, there are some other signs. In this other study we also did together with the group of Leiden, we looked at the baseline CTPA again, and we had 2 cohorts. One cohort with a follow-up CTPA and they didn't develop CTEPH. Another cohort with a follow-up CTPA and they all had, at the end, chronic thromboembolic disease. And what we did is that we scored all the vessels before and afterwards, and all the patients had 6 to 7 months anticoagulation. And the vessels were scored as normal or affected, and normal was no lesions at all, or they had a central thrombus, a total occlusion, a mural thrombus, a web, or the vessel was tapered. And what we observed was, which not surprisingly, central thrombi resolved after anticoagulant treatment. But total occlusions and mural thrombal either resolved or evolved into a web or tapered pulmonary artery. Webs and tapered pulmonary arteries they increased at follow-up, but none of the webs or tapered pulmonary arteries observed resolved. So did the patient have a web or tapered pulmonary artery at the index CTPA? After anticoagulation, these lesions stayed exactly the same. So we concluded that webs and tapered pulmonary arteries at the time of PE diagnosis strongly indicate a state of chronic pulmonary embolism. Does that mean that this patient have chronic thromboembolic pulmonary hypertension? No. They only have signs of chronic thromboembolic lesions. So they still need to have these high pressures. Here are 2 examples again, the web at the baseline at the follow-up scan and the tapered artery again at the lower level, which stayed the same. Then we have this other issue what I kindly want to address because it really intrigues me. A lot of patients after pulmonary enterectomy still have residual pulmonary hypertension. The pressures do drop significantly, and some patients are totally without pulmonary hypertension, but residual pH is still in 16 to 50% have residual pulmonary hypertension after pulmonary enterectomy. And we wanted to find out what is the relation to remaining sub- or segmental macrovascular lesions or to microvascular disease, because this is still unknown. And in this study, we performed, again, CT, but we also did MR perfusion. And we saw no significant difference in vascular lesions at CT and hypoperfusion with MR in patients with and without residual pulmonary hypertension, as you can see here in this nice graph. And this is where it's all about. So we had patients with residual microvascular lesions, and they did have, and there was an even group in patients with residual pulmonary hypertension and without residual pulmonary hypertension. So there must be another component that explains the residual pulmonary hypertension. So there must be a large amount of microvascular disease. And it's very intriguing because most patients come back to our meetings, and every time we have the discussions, when they after pulmonary enterectomy and they still have residual pulmonary hypertension, what should we do with these patients? Should we offer them BPA? Should we treat them medical or not? And we don't know it yet, because every time it's a discussion of like another half an hour because we are not sure what to do. And there are no good studies evolving this issue at the moment. So I want to close this meeting, my presentation with, there's an important role of radiology in diagnosing CTEPH. It is very important to closely read the index CTPA to detect early signs of CTEPH, especially webs and tapered vessel. I believe there's a promising role of dual energy CT in the guideline algorithm, and I know it's a new technique, but we have to move on to something new again. And we have to review the mechanism of residual pH for further treatment options. And I hope this is how it goes, that CTEF is getting the more leading role in the discussions. Thank you.
Thank you. Thank you very much. Can you hear me? Yeah. Thank you very much, Lilian. Thank you very much, Michael. I hope you can hear us.
Yep.
Oh, he's here. Perfect. So many thanks to you both, of course. Great speakers and great talks, but you must admit, I mean, as radiologists, you do always have an advantage because you're also showing beautiful images. So if you talk about epidemiology or cholesterol management, it's a little bit more difficult, right? You only show numbers. That's why, of course, we had such excellent speakers also yesterday, like Sigrid and Stefano. And of course, with you had great messages, and I think they are then evident also, even to non-experts. So we have 2 or 3 minutes for brief questions. Menno?
Thank you, Michael. You said that you did 50 in the past and now 400 per month. That is almost too good to be true if you are free for the weekend to play golf. So did you go back and do they follow diagnostic algorithms, or is it also CT scans for other purposes? Can you explain?
No. These are CTPAs for acute pulmonary embolism.
Yeah. So did you go back and try to dissect whether the algorithms were followed at all, or are they unknown at your place?
Unknown, I'm afraid. There's no, we have at times tried to. I made one attempt. This is probably about 2015 to look at the application of the clinical score, and we found that it was probably in about 40% of patients that had a pre-test clinical score given to us on the imaging forms. Went back to the notes and found that in a number of cases it was really haphazard.
Okay.
It was not, not been put together rigorously at all.
So it's time to go back again. I'll tell you, in our hospital, we have a system in which you cannot order a CTPA if you have not put into the electronic dossier the diagnostic algorithm. Thank you.
Yeah, I absolutely said the same thing to our guys about 10 years ago. Just make sure that order comms is organized so that it's not possible to get the investigation. And I was kind of fobbed off, as I usually am, by IT. But one of the arguments would be that the clinicians will just put a score in. I mean, they know what to do to get their test.
Yeah, but in daily practice they have to call us, and we don't accept it either if they don't is an elevated D-dimer or they have done their pre-test.
So I think this is a very important message. I mean, there must be some way to secure that there will not be excessive use without pre-test probability, exactly because Michael showed that there is this discrepancy if you have, there is a lot of uncertainty on the accuracy of the results. Brief question, brief answer?
Yes, a quick question for both of you. To Dr. Sproule, how would you differentiate sequelae to acute pulmonary embolism? And to Dr. Meijboom, would you recommend systematic CTPA after stopping anticoagulant to look after the sequelae?
No, I would not recommend standard CTPA after acute pulmonary embolism, because all patients do have, there's a nice study also done a couple of years ago, where a lot of patients do have rest thromboembolic disease, but they don't have any complaints. So if you don't have any complaints, don't do a CTPA, because you will see something and you have to do something with it. So only if patients do have complaints, are still dyspnoic, then again you do your workup. If they don't have any complaints, don't make images.
Thank you very much, Lilian, and many thanks to you both. We will have also our workshop later this afternoon again, so further questions can then be more interactively discussed. Thank you to you both.
Thank you.
This gives me also the occasion to particularly thank our technicians here, our technician team that have made it possible to have until now totally perfect, really a totally perfect hybrid symposium. So the next task is easy because I asked Dr. Meneveau to shorten by 5 to 6 minutes, and he said there's no problem because in my talk there will be no questions. So, so Nicolas will talk to us about, I think, his He's an expert in PE. We've known each other for more than 20 years since his then boss, right, Jean-Pierre Basson, was the head of the European Society of Cardiology. And he will talk to us about acute right heart failure in the pulmonary embolism. Thank you, Nicolas, for being here.
Thank you so much, Stavros, for this very kind introduction. Good morning, everyone. Well, I'm going to present the treatment of acute heart failure. These are my disclosures. Well, you all know that risk stratification in pulmonary embolism patient is mandatory for determining the most appropriate therapeutic approach, and that in the very first step is the initial risk stratification, which is based on clinical symptoms and signs of hemodynamic instability reflecting acute RV failure, extensive pulmonary embolism, and in most of the cases, severely reduced hemodynamic reserve. These hemodynamic signs of instability indicate a high risk of early death. And as you can see here, patients with Harvard clinical acute right heart failure in the ICOPER registry had a mortality rate of 50%, approximately 50% at 3 months. And most of the deaths were PE related. And similarly, in the VIII registry, the same patients had a 70-fold increase in mortality risk at 3 months. I would like to illustrate my topic with a clinical case from our daily practice, and this is the case of a 73-year-old male who was referred to the emergency ward for syncope and acute dyspnea lasting for a couple of hours. He had comorbidities including obesity, hypertension, rheumatoid arthritis, and peptic ulcer. And usual treatment combined calcium channel blocker, ACE inhibitor, and proton pump inhibitor. The patient was overweight. He initially presented without any signs of hemodynamic instability. He had tachycardia, left leg edema, tachypnea, and the blood gas analysis revealed hypoxemia with normal lactate levels, and the pulse oximetry was 91% in room air. ECG confirmed the tachycardia and indicated a complete right bundle branch block. And the baseline CT scan confirmed the diagnosis of pulmonary embolism with proximal right thrombus and a left segmental thrombus in the left segmental arteries. The baseline transthoracic echocardiography indicates some signs of acute right ventricular failure with an RV-LV diameter ratio at 1.5 and an RV to right atrium pressure gradient of 50 millimeter of mercury. Troponin and anti-proBNP levels were elevated, and the pulmonary embolism was classified as intermediate high risk according to the early PA-related risk. And then the patient was hospitalized in ICU over the first 48 hours, and he was given unfractionated heparin. And during the initial course, at 12 hours, he complained of dizziness. Heart rate was 130, and the systolic blood pressure dropped to 75 millimeter of mercury. The patient had sweated extremity. Saturation was 85%, and a non-invasive high-flow oxygen delivery and arterial lactate levels were elevated. Well, according to the guidelines, our patient clearly had hemodynamic instability related to obstructive cardiogenic shock, combining systolic blood pressure below 90 millimeter of mercury and end organ hypoperfusion. And you know that there are two classifications of cardiogenic shock based on clinical severity and on the response to treatment with some overlap. And our patient had clearly criteria of classic cardiogenic shock with hypoperfusion that requires an initial set of intervention. When patients are classified by hemodynamic phenotypes of cardiogenic shock, you have to know that the presence of low cardiac index is a common finding, but ventricular preload pulmonary capillary wedge pressure, central venous pressure, and systemic vascular resistance may vary, thus defining warm-dry, warm-wet, cold-dry, cold-wet phenotypes. And the cardiogenic shock caused by predominantly acute right ventricular failure usually present as cold-wet shock, cardiogenic shock. Patients have elevated right ventricular filling pressure and increased in the central venous pressure to pulmonary capillary wedge pressure ratio. Well, you all recognize the famous vicious circle of right ventricular failure in pulmonary embolism, first proposed by Adam Torbicki several years ago. Without going into details, I just would like to underline that the right failure due to acute pressure overload is considered as the primary cause of death in severe pulmonary embolism. And pulmonary vascular obstruction leads to an increase in ventilation perfusion mismatch and an increase in right ventricular afterload. And elevated right ventricular afterload results in an increase in wall tension, an increase in oxygen demand, and in a decrease in left ventricular filling and in cardiac output. And overall, all of these mechanisms contribute to systemic hypoperfusion, coronary hypoperfusion, cardiac ischemia, and cardiogenic shock, multi-organ failure, and death. The pathophysiological mechanisms that can lead to circulatory failure are well known. Pulmonary artery pressure increases if pulmonary vascular obstruction is above 30%. Above 50% of pulmonary vascular obstruction, both pulmonary artery pressure and pulmonary vascular resistance rise sharply and exponentially. And a normal right ventricle cannot sustain a sudden rise in acute or in systolic pulmonary artery pressure above 40 millimeter of mercury for the mean pulmonary artery pressure or 50 millimeter of mercury for the systolic pulmonary artery pressure without generating an acute circulatory failure. In addition, there is some ventricular interdependence in right ventricular failure, and the dilatation of the right ventricle is responsible for increased pericardial constraint, flattening of the interventricular septum, and left ventricular deformation. And again, all of these mechanisms contribute to decrease the cardiac output. While getting back to our clinical case, the management strategy was discussed with regard to respiratory support, hemodynamic support, and reperfusion strategy. Regarding the respiratory support, there are several factors that contribute to hypoxemia in acute pulmonary embolism. Ventilation perfusion mismatch is probably the most important criteria that is responsible for a profound ischemia, but intrapulmonary shunting, reopening of PFO, responsible for intracardiac shunting, and low cardiac output are also additional factors contributing to hypoxemia in acute pulmonary embolism. And while the guidelines recommend oxygen in patients with pulmonary embolism with oxygen saturation below 90%, and the non-invasive high-flow oxygen delivery does not increase intrapulmonary pressure and is therefore the initial therapy of choice in this setting. In patients with severe respiratory failure or hemodynamic collapse, pressure mechanical ventilation is required, but care should be taken to limit its hemodynamic side effect. Indeed, the positive pressure ventilation can further decrease the venous return and therefore the cardiac output. And PIP should be applied with caution, with low tidal volume, in order to keep the uninspiratory plateau pressure as low as possible. In addition, induction agents with limited hemodynamic effects are recommended, such as ketamine and etomidate. What about the hemodynamic support for our patients? regarding the pharmacological treatment of acute right ventricular failure, you have to keep in mind that volume loading has the potential to overdistant the right ventricle and thereby worsen the ventricular interdependence and ultimately reduce the cardiac output. And therefore, cautious volume loading is recommended. Vasopressors, inotropes are also recommended in case of sustained hypotension, and noradrenaline is indicated to restore blood pressure, while the butamine is indicated to improve the contractility of the left ventricle and increase the cardiac output. Now, the role of circulatory assistance, namely the veno-arterial ECMO, remains very poorly defined in patients with pulmonary embolism, and according to the ESLO guidelines, cardiogenic shock and cardiac arrest are the most classic indication for circulatory assistance. More recently, patients with pulmonary embolism presenting with severe hemodynamic compromise have also emerged as candidates for ECMO, while those who need an hemodynamic support pre or post cardiac surgery, including surgical embolectomy, are validated candidates for ECMO. Whether ECMO could be an alternative in PE patients presenting with cardiac arrest or refractory shock has never been assessed specifically and remains to be determined. And the data from the literature are scarce. They show that cardiac arrest is the main indication for ECMO in patients with high-risk PE. And by combining the results of these 5 small observational studies, including 136 patients, you can see that all of these patients underwent ECMO implantation. You can see that 2/3 of patients had cardiac arrest and approximately 1/3 refractory cardiogenic shock. Rationale for using ECMO in PE patients with cardiac arrest or refractory shock is related to the difficulties in performing effective CPR due to pulmonary artery obstruction leading to impaired left ventricular filling. And this scenario is, let's say, further complicated by the difficulty of diagnosis this condition. And early implantation of ECMO is supposed to stabilize hemodynamics and therefore leaving time to confirm the diagnosis and evaluate further treatment strategies. Now, before, and I think this is important, before placing a patient on ECMO, I think that the most important question is what's the therapeutic objective behind the use of ECMO in high-risk PE patients? There are 3 different situations according to potential roles of circulatory assistance, and ECMO may be considered as an adjunctive hemodynamic support after failed thrombolysis or after surgical embolectomy, or as a bridge to a perfusion strategy, such as surgical embolectomy or catheter-based therapy, or even as a destination therapy, considering ECMO as a standalone therapy while waiting for the endogenous fibrinolysis to take effect. This is the single-center retrospective study reporting the results of 17 patients who underwent ECMO after failed thrombolysis or as a standalone therapy in high-risk PE patients. And of the 17 patients included in this registry, 15 suffered pre-ECMO cardiac arrest, of whom 7 were cannulated during CPR and 8 underwent pre-ECMO thrombolysis. And you can see that the in-hospital survival was 47%, 88% of patients presented severe bleeding complication with no impact on survival, and the authors concluded that VA ECMO could be a life-saving rescue therapy for patients with high-risk PE when thrombolysis failed, or the patient is too sick to benefit from surgical embolectomy. What is interesting here is that for the authors, surgical embolectomy and circulatory assistance are incompatible. But conflicting results have been published more recently regarding the results of these patients with failed thrombolysis or with ECMO as a standalone therapy. And in this first retrospective study on the left, 32 patients were placed on ECMO for high-risk PE, of whom 53% survived the index hospitalization. What is interesting here is that all 5 patients who received systemic thrombolysis pre-ECMO died. And in the second study, on the right, 16 patients out of 36 received ECMO as a standalone therapy, of whom 69% died in hospital, yielding to an in-hospital survival rate of only 31%. Results seem to be more promising with a therapeutic strategy combining early hemodynamic support followed by immediate surgical embolectomy. And in this registry, the decision of definitive therapeutic management following ECMO implantation was made by the PERT, with surgical treatment being the preferred strategy in 56% of patients. And you can see that the overall in-hospital survival rate was 95%. Catheter-directed thrombolysis could be probably used as an alternative to surgical embolectomy in an attempt to achieve fast and effective reperfusion, but again, we have very few data, but the preliminary results seem promising, and this approach probably merits some further investigation. And combining the result of these 4 small retrospective study, you can see that the 1-month survival was 73%. We investigated outcomes of high-risk PE patients according to therapeutic strategy. And this was a retrospective French study conducted in 9 university hospitals. And among 180 patients with high-risk PE patients, 71% of patients were treated without ECMO, and only 29% of these patients underwent ECMO. Patients with ECMO were younger and more frequently had cardiac arrest. And you can see that the 30-day mortality rate was 43% in patients without ECMO and 61.5% in patients treated with ECMO. If we focus a little bit on the outcomes according to initial treatment, you can see that the 30-day all-cause death was as high as 77% in patients treated with ECMO plus thrombolysis, 77.8% in those who were treated with ECMO as a standalone therapy, and 29.4% in patients who had ECMO and surgical embolectomy. And there is a signal here for lower mortality and more successful weaning when ECMO is combined with surgical embolectomy compared with ECMO plus thrombolysis or ECMO as a standalone therapy. In our study, when ECMO was implanted during cardiac arrest, it was the worst situation. As you see, overall in-hospital mortality was 87%, and we did not find any difference between patients with refractory cardiac arrest and those with resuscitated cardiac arrest. More encouraging results have been recently published, and in this study, among patients placed on ECMO because they suffered cardiac arrest due to PE, those who had ongoing CPR at ECMO placement had a survival rate of 25%, while those who had return of spontaneous circulation before ECMO had a survival rate of 70% at 3 months. Pre-ECMO lactic acid level is probably also associated with survival in these patients, and a level below 6 millimole per liter had a good sensitivity and specificity for predicting survival to discharge. So, getting back to our patient, what is the best reperfusion strategy? We performed a systematic review and meta-analysis of available evidence comparing two strategies, the mechanical embolectomy and other strategies, including systemic lysis, CDT, or ECMO as a standalone therapy with regard to two clinical outcomes, mortality and bleeding. We included 17 studies comprising 353 patients. 48% of patients had refractory shock, 52% cardiac arrest, 36% received ECMO before reperfusion therapy, and 10% received more than one form of reperfusion therapy. Overall, 31% of patients had mechanical reperfusion strategy, including surgical embolectomy alone or with prior thrombolysis, and catheter-based embolectomy alone. And 69% of patients had other reperfusion strategies, including thrombolysis alone, systemic thrombolysis, and CDT alone, and ECMO as a standalone therapy. And as you can see here, the mortality rate was 23% in the mechanical reperfusion group versus 43% in the other strategy group, corresponding to a reduction in the relative risk of death of 54%, a significant reduction of 54%. The bleeding rate was 29% in the mechanical reperfusion group versus 26% in the other strategic group, and this difference was not statistically significant. We performed multiple sub-analyses according to specific reperfusion strategies, and again, the mortality was lower in patients treated with mechanical reperfusion than in those treated with either thrombolysis or ECMO as a standalone therapy. And again, the bleeding rate was also lower in patients treated with mechanical reperfusion than in those treated with thrombolysis or standalone ECMO. Finally, we performed a meta-regression model to evaluate the potential of heterogeneity, and we did not find any relationship between the covariates of more than one pulmonary reperfusion strategy or ECMO implanted before or after pulmonary reperfusion regarding two clinical outcomes, mortality and bleeding. This is the emergency management algorithm for patients with suspected high risk PE according to the European guidelines. The very first step is to give these patients some heparin, ECG, and echography are recommended to rule out alternative diagnosis. Oxygen, fluid loading, inotropes, and vasopressor are often required to stabilize the patient, and mechanical ventilation in the most severe patients. If you can stabilize hemodynamically the patient, then the diagnosis of PE should be confirmed and the reperfusion strategy should be undertaken. In case of absence of hemodynamic stabilization, then you have to consider ECMO to confirm the diagnosis and to undertake reperfusion strategy favoring surgical or catheter embolectomy. I think this flowchart can be slightly improved in light of the very last data from the literature. I think that perhaps we can integrate a multidisciplinary pulmonary embolism response team in the clinical decision meeting, but otherwise the first step is roughly very similar. In case of absence of hemodynamic stabilization, namely in patients with refractory shock or refractory cardiac arrest, ECMO should be placed on, and surgical or catheter-based embolectomy should be considered after confirmation of the diagnosis and after ensuring the absence of hypoxic brain damage. In presence of hemodynamic stabilization, then again, the diagnosis has to be confirmed, and systemic thrombolysis is clearly the first choice. But surgical or catheter-based embolectomy could be considered in case of contraindication to thrombolysis or failed thrombolysis. And in this setting, ECMO could be considered if there is a need for hemodynamic support pre or post-surgical embolectomy. Well, finally, to continue with our clinical case, the patient was placed to mechanical ventilation. He received cautious volume and noradrenaline. The management strategy was discussed. Thrombolysis was considered contraindicated given the recent gastrointestinal bleeding. CDT, I mean, time to effectiveness was to catheter-directed thrombolysis-based therapy was considered too long given the severity of the cardiogenic shock. We had no embolectomy catheter available at the time, and the patient was transferred to the operating theater for ECMO implantation followed by surgical embolectomy. He developed severe bleeding, but he was weaned from ECMO on day 4 and discharged from the hospital on day 10. At 3 months follow-up, he complained of dyspnea Wu functional class 2. He had no echocardiographic signs of pulmonary hypertension, and at 2 years follow-up, he's still alive and clinically stable. This is my conclusion. The etiological treatment of right heart failure is based on reperfusion strategy in pulmonary embolism. Mechanical ventilation, cautious volume loading, and inotropes are almost systematically used, but of limited interest. ECMO should be reserved for the most severe patients, those with cardiac arrest and refractory shock. The challenge consists in identifying the therapeutic strategy behind the use of ECMO. ECMO in patients with failed thrombolysis and those with no reperfusion is associated with unfavorable prognosis, but shows promise as a complement to mechanical embolectomy or as a bridge to surgical embolectomy. Thank you.
Thank you very much. Thank you, Nicolas. So also on the basis of this case, I mean, you are an absolute expert on this very difficult subject of let's say, very severe PE. So let's see if you were right. Are there any questions? There is a question. There are 2 questions.
Thank you for your very nice presentation. I was wondering, do they also look, because that I'm at many times in my center, that there were severe acute PE, but there was chronic PE afterwards. And then at the moment, they do a thrombolectomy, but they only remove the acute clot. Yeah. And then the patient still has a problem because all these chronic lesions are still there. Is that being looked at?
Yeah, I mean, yeah. You're talking about patients who need some hemodynamic support following surgical embolectomy, right?
Yes.
Yeah, this is
severe case, like the ECMO cases.
Yeah, this is exactly what I was saying. I mean, this is potential management, appropriate management for this patient. Yes. I mean, the ECMO placement in the setting of surgical embolectomy could be considered before or just following surgical embolectomy. And this is an appropriate strategy.
Yes, I mean that also has to be more looked at, that also the chronic lesion has to be removed at the acute moment. Sometimes they only remove the acute clot because it's acute and chronic disease.
So
and then
something of this because we had very recently such a case.
Yeah, we do, yes. Yeah. That's why I have this.
The patient died and it came to a process of litigation because the surgeon did a acute pulmonary ectomy. The patient had, acute and chronic. Yes. And then, I mean, there was a huge problem, an uproar, and so...
Yeah, but if you look at this slide, I mean, this data from a German center, I mean, in this small registry of 36 patients had acute PE and acute and chronic PE with a large success, with a large surgical success and overall in-hospital survival rate as high as 95%. So, I mean, if it's possible,
but maybe we can propose a compromise on this. So I think if you have an acute situation here, someone is totally unstable, right? So you have not much time to think. So what you can do, I mean, if it is about, if you do believe, based on the clinical situation, that you have at least an acute component, I mean, you can do the reperfusion, the thrombolytic, not the surgical perhaps so much, but the thrombolytic reperfusion, maybe the patient will stabilize enough to then take care of the problem. It does get more complicated. Fortunately, there are not many surgeons who would operate. I mean, this patient was operated. But if you come, it can become a problem if you suspect also chronic disease and it comes to acute embolectomy, then this patient with pre-existing CTF may die, right? I mean, of course, you're not so sure in an acute situation, but it can get, do you agree, Lilian? Yes, I do. So brief question. Piotr promised a brief question. Let's see. Yeah.
Yes, I tried. Congratulations. I have a question because I think that ECMO has a very important role. Don't you think that sometimes ECMO is started too late?
Of course.
So this is one of the causes of not perfect results of ECMO in PE. We should consider this aggressive treatment earlier.
Yeah. Short response. I mean, I think the real problem is that we have to keep in mind that failed thrombolysis required surgical embolectomy and not ECMO. But the patient could be submitted to surgical embolectomy and then underwent ECMO postoperatively. But most of the cases that I presented were patients who underwent failed thrombolysis, and in these cases, ECMO was implanted clearly too late.
And this gives also for one sentence to say here that there is now a very serious and very nice consensus paper coming out, led by Piotr, but also by Nicola and other experts. Andrew is here in the room, to try to define failed thrombolysis, because that's easy to say, difficult to do, but I think that you have come very, very close. So, but of course, nothing more on this, it will come soon. Cecilia.
Yeah. I don't want to talk about the patient in cardiac arrest, because it's clear that when you have a cardiac arrest, it's a different situation. But if I imagine what happened in my hospital, I work in a university hospital, we have cardiac surgery, and we have the hemodynamics. But if I say, okay, this patient needs surgical embolectomy, this will happen in at least 1 hour. So my point is, in the meantime, I need 5 minutes for thrombolysis. So what should I do? Because, because when we give an indication, it should be feasible everywhere. So I work in a university hospital. What happens if this severe patient arrives in a non-university hospital without cardiac surgery? So what is the indication?
And I also wanted to ask you, but of course it's also a long discussion, but briefly, because 20 years ago there was a lot about emergency thrombolysis during CPR. It was promising, did not fly. So is it dead in 2021, or is it still alive?
No, I mean, I think, I don't know if I can help you solving your problem, but I tried to set up a team specifically dedicated for ECMO in our university hospital, and they are available 24 hours a day, and well, it takes only 10 minutes to get the patient under ECMO.
Is it true only in the Monday morning, or is it true also in Saturday night?
Yeah, also in Saturday night.
So certainly more logistical progress will be...
I think the point is a logistical point.
In Germany, there are meanwhile mobile ECMO units that also fly the patients in and out of... I mean, you cannot afford it in every country.
But while you fly, you may give thrombolysis. So this is my point.
Yeah.
Yeah.
So this is the transition phase. Yes, you're right. So thank you very much. Thank you. You see, there were some questions, and the guidelines do need some improvement in this. So the guidelines do have some contradictions. So for you, it will be the next challenge. So thank you very much. We will reconvene at, let's do it like the German railway, giving very precise times that are never held. Say 10:47.
There.
Oh, here he comes after you with the bike.
Thank you.
So I think we start, and probably you've been introduced, but let me do it again. So Andrew Sharp is one of the few people who has large experience with catheter-directed reperfusion techniques, who has also experience on a daily basis with these catheters and reperfusion, and on a weekly basis. It's coming on monthly basis, yearly basis. Okay. So Andrew, this is your podium. Cardiologist in Exeter and also on the University of Cardiff, if I'm right.
Yeah,
connection.
I've moved from Exeter to Cardiff, so I'm in Cardiff.
Moved from Exeter to Cardiff. That's the latest news. Okay, we are very curious to have your talk.
Yes.
Catheter intervention for acute pulmonary embolism, current and emerging options.
Yes.
Andrew.
Thank you very much, Menno. Thanks. I mean, it's funny, depending on where you are, this is either something that's pie in the sky or something that's every day. So since I've been here, I've had 5 referrals from my region for catheter-directed treatment for pulmonary embolism in a region that didn't have catheter-directed treatment 2 years ago and wondered what the point was. So once these technologies are offered, people begin to see the results. But I'm going to talk through the strengths and weaknesses of the data now. So we've seen this many times. We're going to put it on your gravestone, Stavros, there. Thank you. It's a beautiful image that's very simple.
As soon as possible,
right? No, don't worry. We're going to clone you, don't worry. The golden groups for catheter treatments are the intermediate high-risk group and the high-risk group who can't have systemic lysis. So we all know about these data, very high in-hospital mortalities for high-risk PE. Thrombolysis is said to reduce the mortality by 70%. Interestingly, the randomized controlled trial data in high-risk PE consists of 8 patients, 4 of whom survived with thrombolysis, 4 of whom died. All the other randomized data are in patients who are not clearly in the high-risk shock group, and everything else is in observational data. But I think thrombolysis clearly helps. So at the moment, the standard of care for high-risk PE remains systemic thrombolysis. The problem is that if you look back at the ICOPA registry, 2/3 of people who are eligible didn't get systemic lysis, and I think in the modern era it's at least 1/3 and probably 1/2 of patients. And that's because who gets pulmonary embolism? It's patients with cancer, it's elderly patients, it's patients who've just had operations, it's patients who've had fractures. And so we have, although it's only 5% of the pulmonary embolism population, that means that about 2.5% of them have got a need for reperfusion and they're not getting reperfusion. So those are a group that we need treatments for. The intermediate risk group is a broad thing. It's probably more like 1 to 20% mortality at 30 days. But what's interesting is that that's not too dissimilar a mortality from ST elevation myocardial infarction. So I work in a system network that's had vast resources poured into it in order for me to be able to take an ST elevation myocardial infarction who's had aspirin, and therefore their risk has dropped from 13% mortality to 11% by giving aspirin. Rather than giving systemic lysis to those patients, which would have brought their risk down to 8% mortality, we take them at great expense to our cath lab, disrupt our running of the day, and then we do primary PCI, which drops their mortality now to 3%. So we have these coronary care units that are set up to look after patients with myocardial infarction, and the first time they receive those patients is after they've been to the cath lab, at which point their average mortality is 3 to 4%. And yet we've got this condition that's spread all around the hospital, frequently not being managed in an intensive enough environment, not being observed properly, which has a mortality that the bottom end of risk is 3% for intermediate risk pulmonary embolism. So I think one of the reasons I've been drawn towards PE is that there's massive unmet need and there's significant mortality that I think we can modulate. But right now, 99% of cases in the world of intermediate risk pulmonary embolism are being treated with anticoagulation. And then the low-risk patients, again, anticoagulation, we don't even admit them anymore. So risk stratifying. So I still use the original PESI, so thank you, David. I use MD Calc, and I calculate it on my phone. And I would encourage everyone to do that. I think it's a slightly richer one than the SPESI, although we could probably debate that until the end of the weekend. We all know how to do that. And what I like about it is it gives this gradation of risk of mortality. And so if somebody said to me, I've got this unmet need in coronary or in valvular heart disease, and you've got a 30% mortality from tricuspid regurgitation, which of course it isn't, but let's imagine someone came along and said, we've just discovered this thing called tricuspid regurgitation that's currently not being treated. And its 30-day mortality is between 4 and 11%. And we know this, and we're not iterating. We're just giving them the same treatment, and 4 to 11% of them are going to be dead at 30 days. I would find that shocking. In cardiology, these sorts of mortalities are unheard of now. We dramatically reduce the mortalities in everything except fulminant cardiogenic shock, way, way below this for almost all conditions that we treat. And so we do need to iterate. The question is how, and the clinical trials that underpin it. So when you're assessing patients for either catheter-directed treatment or any kind of large volume pulmonary embolism, I do find this useful. There's a question asked yesterday, how do we measure the RV-LV ratio? In many ways, it's overcooked as an idea, because if it's significantly dilated, it's significantly dilated. It doesn't matter how you measure it. You can just look at it. And if it's significantly dilated, you know you've got a problem. But as a rough rule of thumb, if I'm getting a call at 2 in the morning, as I now get probably every second day now from my region, to say I've got this pulmonary embolism, first thing I ask is what's the RV-LV ratio? Obviously, they'll fire the history at me, which is crucial, but the first test I ask for is what's the RV-LV ratio. If the RV-LV ratio is less than 1, then they're okay. If they're 1 to 1.2, they're usually well, unless they're on pressor therapy, which is increasing their left-sided afterload. If they've got an RV-LV ratio of 1.2 to 1.6, they can be very sick, but typically they've got just 1 or 2 parameters that are abnormal, so maybe their heart rate's 90, their blood pressure's drifted down a bit. I think that's a group that's got a broad range of severity. If they're over 1.6, they're usually sick. And if they're over 2, it's very rare to meet a patient who doesn't have a life-threatening presentation of pulmonary embolism, presuming they don't have CTEPH. And that's because to get above 2, you have to have underfilling of the left ventricle, which, as you're seeing here. And once you start to get underfilling of the left ventricle because the blood can't get through the lungs, then you've got a problem. And that patient is unstable, whatever their parameters say, because it only takes a small accidental insult to those patients, and they suddenly become a real problem. So RV strain is important. So what are we trying to do in pulmonary embolism? It's very rare that I've lost a pulmonary embolism patient due to hypoxia. I've lost pulmonary embolism patients due to RV failure. That is the main thing that they die of. And this meta-analysis has been several since, showing that an elevated RV-LV ratio, by whatever mechanism that you measure it, is associated with a significantly elevated odds ratio for PE-related death. And so that's one thing I want to get over to everyone here. I'm sure most of you know this, that right ventricular failure is the primary mode of death in large volume pulmonary embolism. And so in my view, our goal is to try and relieve right ventricular strain and avert death from right ventricular failure. Yes, hypoxia is important, it's very important, but it usually isn't the thing that kills them, unless they're forced to go onto a ventilator, in which case they die from their pulmonary embolism and their lack of ability to adapt to a reduced preload. Biomarkers are still in the business, take your pick, BNP or troponin I. The only issue is we've all now moved on to high sensitivity troponin, so I personally find that in the large volume pulmonary embolisms, 80–90% of them have an elevated high sensitivity troponin. So I'm sure there's work to be done on grading that high sensitivity troponin and what it means, but if it's negative, then I find that useful, because it means that they're less likely to have a problem. In the original data, the old troponin, it was harder to get a positive troponin, and that was much better as a positive predictor. There's some recent data suggesting it still has value. High sensitivity is a positive predictor, but I'm sure that there's a big research study waiting to be done, so if one of you wants to do it, I'm sure you'll get it in a big journal. Just pick me as a reviewer and I'll get it in. Why not just give systemic TPA in submassive intermediate high-risk pulmonary embolism? Well, Stavros has told us. So the largest study ever of thrombolysis PE, 1,000 patients, and it's a mirror image, so benefit versus cost. So the top side of the forest plot, it reduces RV collapse, but on the other hand, it causes significant extracranial bleeding and intracranial hemorrhage. And what that should say on the right, yes, it does say elderly, thankfully, is if you're elderly, if you're over the age of 75, you're looking at 20 times the rate of major extracranial bleeding. Who gets pulmonary embolisms? It's older patients. It's patients after operations and so on. So what Pythor told us very clearly is that you can avoid hemodynamic collapse with lysis. and that's a good thing. The problem is it caused too much bleeding with full-dose lysis. So Python 3 is currently ongoing. That's going to randomize half-dose lysis against standard care. And that's an interesting study that we look forward to seeing the answer to. Is 50 milligrams low dose? I personally don't think so. I routinely lyse people with 8 milligrams. So, 50 is a big dose. So it's by no means certain that 50 is going to mitigate these bleeding events, but we've got a really good randomized trial that's ongoing, and if anybody's involved in it, I encourage you to recruit. But what we've seen in the ESC guidelines is that routine use of lysis for intermediate risk PE is a class 3 indication, i.e. it can cause harm, so we shouldn't do it. But what we clearly need is a mechanism of reducing this risk of RV failure that doesn't have the same bleeding. I mean, that's not controversial. If we can reduce the risk of RV collapse without the bleeding risk and without the harm, then we're going to do our patients good. Stefano is here somewhere, there he is. So he did a postdoc analysis of Python, and what he showed, it's actually slightly richer than this, so forgive me, Stefano, but he had a 30-day mortality of 20% within the Python group. If you had two of a low normal blood pressure, remember if you're below 90, you're excluded from the study. So if you have a low normal blood pressure in intermediate risk PE of 90 to 110, a heart, that should be respiratory rate, sorry, over 20, despite oxygen, and a history of chronic heart failure, and it was actually of cancer as well. So if you had two of those, then you had a mortality of 20%. Now, this is not a rare thing for a patient to come in with a blood pressure of 105 and a respiratory rate of 22 with a large volume pulmonary embolism, and yet we're talking about mortality rates of 20%, which is unacceptably high. I mean, as a field, we cannot accept that. It's ridiculous. We would never accept that in cardiology. So additional risk factors identified in the literature, high heart rate and low SATs, and so we folded them into a trial that I'm about to tell you about. So in summary, when I'm assessing a pulmonary embolism, I look for PESI 3 to 5, because those are the groups with proven elevated mortality, and patients really don't like it when you tell them what their predicted risk is. The key parameters for predicting risk are tachycardia, low normal blood pressure, elevated respiratory rate or significant hypoxia, and if you've had previous bad lungs or bad heart, that's clearly not a good thing if you then go on and get a pulmonary embolism. RV strain increases risk odds ratio of 7-fold, and troponin BNP also elevates risk. So I think most of us know this by now. So what about catheter treatments? So catheter treatments, in my view, should be considered for patients with intermediate risk PE that have RV strain and abnormal troponin. So I mostly use them in intermediate high-risk patients or in patients with high-risk PE who can't have systemic lysis. I still use systemic lysis as the primary intervention for high-risk PE. And so what are we looking for? We're looking for these factors that predict a bad outcome on anticoagulation. Elevated heart rate, low normal blood pressure. It really isn't normal to have a blood pressure of 110 if you're 70 years old. There's something wrong if your blood pressure is 110 and you're 70. Hypoxia, significant hypoxia, elevated respiratory rate, work of breathing. Sometimes it can take 7 to 10 days for that to go away with anticoagulation. And that work of breathing may turn a stable patient on day 1 into an unstable patient on day 4. High oxygen requirements and a background of a bad heart and or bad lungs, and therefore a patient who's not going to tolerate a large volume pulmonary embolism as well as an ordinary patient. I also consider intervening in someone with a large saddle pulmonary embolism and a very high clot burden. This is going to be a really difficult thing to prove in the literature. So there's lots of evidence that if you had a large volume PE 20 years ago, you're more likely to have a problem. The difficulty is, how do you prospectively prove that going in and treating a large clot burden with catheters is going to help? And I'm not sure we're ever going to get those data. If you look at the material that's being taken out of pulmonary arteries now with the large bore thrombectomy devices, they've got smooth muscle in them, they've got collagen in them. The body is not going to break these down, they're going to be there forever. So if you've got a 35-year-old with a huge volume of pulmonary embolism having had a DVT for 4 weeks, then it's likely that that's beginning the process of infiltration, and therefore that stuff may never come out of the lungs. Now, if you're 70, it's probably not a big deal. If you're 35, should we knowingly now leave that stuff in there? And I really don't know, perhaps we can discuss at the end of this talk if we've got time, how we prove that that's a good thing. I think the best way to prove it is to get the complication rate from these procedures as low as possible, get it so low that we just have to accept that it's not a good thing to leave behind collagen and smooth muscle inside the pulmonary arteries. but maybe we'll never prove it. Maybe we're just going to have to do it on the basis of Gestalt. If there's significant pulmonary hypertension, so there is a cliche that if your pulmonary artery pressure is over 65, you must have CTEPH. It's definitely not true. I have treated many patients who've had pulmonary pressures invasively of 75 to 80. I've given them lysis or thrombectomy, and then 6 hours later their pulmonary pressure is 25. And I've proven it over and over and over again. So you've just got to be a little bit careful of that, because these are the PEs that are incredibly unstable. If you go in and get an invasive pressure of 80, I've seen people take their gloves off and say, CTEPH. But no, those are the ones who are in real danger of instability. And actually, even the intervention can be risky for them. So there's many a time where I've seen a left-sided pressure of 100 and a right-sided pressure of 80, 85. As soon as I measure it, I'll stop and just lyse them. Because getting catheters and wires up there is not a straightforward thing when you've got such a close balance between the right and the left side. Just a slight problem and that patient is in deep trouble. But what the cliche should be said as, if it's over 65 millimeters of mercury on the right side, think about CTEPH. And I think that's a very good maxim. The other thing I'll always do is I'll look at the grade of LV underfilling as measured by the RV-LV ratio. And if it's over 1.6, so many of these patients are in trouble or they have very long hospital stays. Now, we know that a long hospital stay in an ordinary time was a risk. Now we've got COVID, it's a really great risk. So for the last year and a half, I've had patients on wards where every day that they're on a ward, they've risked contracting COVID from somebody else or a member of staff. And so shortened hospital stays are an attractive goal. We've just got to prove that they occur. So what are our options? So there are three main options in the literature that I'm going to talk about. The ECOS, and the penumbra device, and the Inari flow retriever. There are other devices. I'm not going to talk about Angiojet because it's got a black box warning from the FDA, and so I don't use it. I'm not going to talk about standard catheters, although I'll mention Sunset PE shortly. So the ECOS device has been around for quite a long time now, about 10 years. And this is the one that I showed last night, if any of you were in here for my workshop. So it's a 6 French, it's actually 5.2 French device, but it goes through a 6 French hole, which is attractive. 6 French hole in the vein is very easy to control. Delivered via the leg or the neck. So I really enjoyed the workshop on right heart catheterization, but 88% of cases in the knockout PE registry of 1,000 cases of ECOS were done via the leg. And that's just because it's easy to strap the device in, and it's going via the leg is something familiar to a lot of interventionists. It requires either 2 6 French venous punctures, which should always be done under ultrasound, or it can be a 12 French with 2 holes in it. I much prefer the 2 6 French punctures. And what it does is it has 12 ultrasound catheters within the device that line up with injection holes. So if you put this device in a bowl of water and turn it on, it fires jets of water up into the air like the Bellagio fountains in Las Vegas. And that's what it's trying to do with TPA. It's trying to mechanically inject droplets of TPA inside the clot. So on a bench testing model, that has merit. And I think I've even got Engelberger's thing here. I'll show it shortly. So what trials do we have? The trials are not the highest quality compared to some of the other areas of medicine that we have because there's no outcomes data. But their mechanistic trials are good and they've been run well. So Niels Kuker did the Ultima study, 2014, he published it. It's only 59 patients, but it was actually powered for a reduction in RV strain. And what it showed is that at 24 hours, heparin did very little. Those of you who echo your patients every day when they have a large volume pulmonary embolism will know this. There's very little change on anticoagulation on day 1. But with ECOS, you had a significant reduction. Now, it's often said that these numbers are low, these RV-LV ratios are low, and therefore they weren't very sick patients, but it's just because echocardiography was the modality that was used. So on echo, it's always smaller. If I take someone from the CT scan, and on the CT, the RV-LV ratio is 1.6, it'll typically only be 1.3, 1.4 on echo. So just be careful about interchanging those. I don't fully understand it, but I've proven it over and over again, and I've done a lot of echoes in my time. Seattle 2 was a single-arm 150-patient study where they looked at CT resolution at 48 hours of RV strain and or clot burden. And what it showed is that in patients with intermediate or high-risk PE, almost a quarter of them had high-risk PE in this study. you had about a 25% reduction in RV-LV ratio and about a 30% reduction in PA pressure, which they measured, and 30% reduction in obstruction. What's very clear is that in order to avoid RV failure, you do not need to dissolve all the clot. You just need to create space, even microvascular space, and you start to see an offloading of the right ventricle. But one of the questions is there merit in getting rid of more of the clot? And again, that's a discussion we could take through to the weekend. So that's the primary endpoint. It's a single-arm study, no control. What's interesting is that in intracranial hemorrhage in the ICOPA registry was 3%, in PYTHO was 2%, albeit with tenecteplase. But in Ultima and Seattle 2, it was 0. So we're using much lower doses compared to systemic lysis. It was 24 milligrams in Seattle 2, and it was 20 milligrams in Ultima of alteplase. Optimized PE was convened to see how low it would go, and I was involved in this study. 8 milligrams over 2 hours, 8 milligrams over 4, 12 milligrams over 6, and 24 over 6. 24 over 6 is actually twice the speed of Seattle 2, and it was stopped because of bleeding events, although I'll have to say it was a little unfair because one of the bleeding events was in a patient who'd had systemic lysis, where they converted strategy because they were worried about the patient, and the other one was in a patient with a known platelet disorder. But nevertheless, the safety committee recommended stopping, I think partly because the other arms were doing so well. And what did it show? At 48 hours, your repeat CT showed that the RV strain had resolved, even with 8 milligrams given over 2 hours via the ecosystem. So the criticism of this trial is that there was no heparin control arm. The justification given by the authors, of whom I'm one, was that we'd already demonstrated that heparin doesn't work in this sort of time frame in Ultima, but I think this study would have been better if we'd have had a control arm with heparin. And we saw, although we didn't see a dose-dependent reduction in RV-LV ratio, they all seem to be associated with an improvement. PA pressure did show a dose-dependent response, whereby the 12 milligram dose and the 24 milligram dose showed a drop of about 8 to 10 millimeters of mercury at 48 hours, whereas the other two were much more guarded. And then again, clot burden, the more lysis you give, the more clot reduction you get. I don't think there's any surprise in that. The thing is, if it's clot and it's not collagenated, it's not got smooth muscle infiltration, it's not organized, I think the body will deal with that if you're on anticoagulation, as long as you're on full anticoagulation. The question is what you do about the stuff that the body will never be able to deal with. So there's a trial called Sunset PE that was recently released. It compared a plain catheter, a Craig-McNamara catheter, and one or two other types, where that catheter has holes in it, but it doesn't have the ultrasound to drive the gradient. And it compared the ultrasound versus the passive delivery of catheters that sit in either artery. So it randomized 81 patients, and it did the repeat CT scan at 48 hours, showed no difference in clot burden or RV parameters of strain. The only issue is that the TPA protocols were not standardized. So some of them had 8 milligrams, some of them had 30 milligrams in one arm, and I think if you're going to design a comparative study, you should probably try and standardize the alteplase between each arm. And it was underpowered, so I've actually looked, I've got a sketch design of this trial, and I powered it at about 600 patients. So if we tried to prove that ramipril helped in heart failure, and you did it with 81 patients, it would fail. So the power calculation exists for a reason, and that's to make sure that you don't get a false negative. So, but there is a question about the ultrasound now. On a bench model, it works, and on a human clot model, it works in terms of increasing the reduction of clot burden. And I think probably the main benefit of ultrasound is it allows you to use much lower doses. So 8 milligrams, 12 milligrams, and they didn't test that in this. But nevertheless, there is a question over that now. So in a summary of the ultrasound-assisted catheter lysis trials, there's no trials completed that are powered for hard outcomes. There is a dose-dependent reduction in clot and PA pressure, but not in RV offloading. All the protocols offloaded the RV at 48 hours. And you can do that with tiny doses of alteplase, with very low systemic concentrations. So systemic concentration of lysis is one of the predictors of adverse bleeding. So here we're doing 8 milligrams over 4 hours. It's a tiny dose. But this is what we need. And this is what we need support from some of you who are in the study in this audience. So HiPython has started now. This site's open in America, and we're about to open in Europe. It's a randomized controlled trial that's powered for outcomes, so 65 sites worldwide, over 400 patients. It's sponsored by Boston Scientific and led by Stavros and by Ken Rosenfield in America. It's patients with intermediate high risk who are randomized to anticoagulation with Clexane or anticoagulation with ECOS as well. And we'll be starting, it says late spring, early summer. Sadly, it's going to be 2 weeks' time. The trial criteria are an elevated heart rate, low normal blood pressure, or respiratory compromise. You need 2 of those 3, and that's based on Stefano's analysis of Python. And that we need to get them into the lab straight away. A lot of the events in Python were early, and so we want to make sure that the intervention is delivered early, as soon as we've diagnosed it. So this is what we need. We need an outcomes trial to underpin the catheter field. And the only reason we don't have one is that the FDA approved ECOS on the basis of data from the leg. If they hadn't have done that, I'm sure we'd have had that outcomes trial years ago. So now we've got it, and credit to Boston for putting a lot of money in to try and produce high quality science. So now aspiration thrombectomy. So the Penumbra device has been around for a number of years, being used in all sorts of parts of the body. It's now got a CE mark as of a year and a half ago for PE. The Extract PE trial is just about the only data, and we're talking 119 patients. Single arm study showing a reduction in RV-LV ratio at 48 hours. Again, no control arm. And this is just an 8 French guiding catheter, goes up into the lung, and it's connected to an engine that sucks clot. And it's okay. I'll show you a case. So it's a 58-year-old lady, passenger in a car, head-on collision at 50 miles an hour. Significant trauma and admitted to our major trauma unit. Sternal fracture, displaced radial fracture. I have to put circles on just so I know where it is, because I'm not a radiologist. And comminuted fractures of the tarsal and metatarsal bones of the left foot. So she's got a cast on her left foot and her left arm. And on day 4 of admission, she becomes acutely short of breath, and a CTA shows a lot of clot. So hopefully you can see that there's clot here. It's not the best CTPA, but clot here, and then we've got clot. So frequently this pattern exists where it goes up into the truncus and down into the interlobar artery. Substantial clot burden, and she was unwell. And she's got a contusion from the sternal fracture here in the lung. Significant elevation of the RV-LV ratio with underfilling of the left ventricle. And PE is a fascinating disease. There's no 2 large volume PEs that are exactly the same. So when I saw the CT, I presumed she was going to have hemodynamic instability. But interestingly, on this occasion, it was escalating oxygen requirements and not hemodynamic instability. So no matter how many rules I try and put in place for pulmonary embolism, there's always cases out there that defeat me. So we heard about this the following day, and we did an echocardiogram, and you can see here that the RVOT is barely contracting at all. It's just rocking. And she has a D-shaped ventricle, so I don't know how well that projects with the light, but it's a flattening of the septum. And you can see that the left ventricle is underfilled, and the septum is going the wrong way. Septum should be that way, and it's going that way. And that's because of acute pulmonary hypertension. As is frequently the case, echo underestimates the pulmonary pressure, and on invasive she had a pulmonary pressure of 60. So she was initially managed with anticoagulation, but her oxygen requirements were going up, and they were going to admit her to ITU. And then the inevitable hemodynamic decline started raising its head. But what's interesting is when you do a risk score, a PESI score, it was only 98 points. So our estimated mortality on that calculator was between 3% and 7%, but she was heading towards intubation. So I think there's no question that this lady's risk was substantially higher than that. If she gets intubated, she's in trouble. But interestingly, young people who are well, they can sometimes maintain their hemodynamics in a way that can be misleading. So we took her to the lab the next day. This is the aspiration we normally get in a myocardial infarction, and everyone does a woo at the end of the bed, and we say, great, we've got this clot out. This is what we got with the Penumbra in this case. And actually, as far as clot burden goes from extraction devices, it's not high. But do you see, I don't know how well that projects, but there is an area down here that looks a bit like a squished wine gum. I don't know whether wine gums exist in Europe, but it's like a sort of gelatinous sweet. And that's not ordinary fibrinated clot. So, and what's interesting about this case is on the top, we have the pre-thrombectomy echo. And I actually did an echo while she was on the table after I'd done the case, because the PA pressure came right down. And the RVOT started working again, and the left ventricle expanded. This is how the LV looked before, and then we started getting a rounder, more expanded left ventricle. And then this was before, with an underfilled left ventricle and paradoxical septal motion, back almost entirely to normal on the table. And that's with an 8 French device, so not, 8 French in the venous system's pretty forgiving system. And the RV-LV ratio had gone from 1.6 on echo back to 0.9. So this lady's normalized in terms of her echocardiographic hemodynamics. Her TAPSE's gone back up to normal. And her oxygen requirements came down within the next 24 hours. She still needed a bit because of the pulmonary contusion, we think. Her pulmonary angiograms at the end were pretty much normal. And she went on to have a Liz Frank operation on her left ankle the following week and came through that with flying colours. So I think this case, it went well. The downside of the Cat8 device is that it has a small lumen and you lose a lot of blood. Those are being addressed in America for about a year. They've had the Lightning 12 French system, so a bigger lumen, and the Lightning is a blood loss control system. As soon as it detects a flow rate of blood being sucked out of the pulmonary artery, it shuts off the suction. And so you try and find your way onto the clot, and then it will release the suction again. So I haven't got that yet. It's not coming in for another couple of months. But the Americans tell me that it's helped with the weaknesses of the Penumbra device. And obviously, the other main weakness is there's no outcomes data. They don't even have a control arm against heparin. So finally, I'll wrap up with the Inari. So if any of you are on Twitter, you can't get through a day without somebody showing you a picture of some clot that's been hooked out with an Inari device. It's a large bore aspiration catheter. In many ways, the amazing thing is why it hasn't been invented before, because it's just a big tube with a syringe attached. And originally it was a 16 and 20 French device, so that's pretty big. So that's the sort of size. 16 is what you're using in TAVIs, and 20 French is bigger now than most TAVIs will ever require. But it's in the venous system, so it's a much more forgiving blood conduit than an artery. And then there's now the 24 French device, which is the biggest of all. It's been around for a couple of years. And that can get a lot of clot out very quickly. There's these discs, which most people are increasingly not using. They're nitinol discs, and the idea is you unfold them like a stroke thrombectomy, and you leave it in the clot, and it marinades onto the device, and you pull it back. That's what they tell you, but my experience is slightly different. So I tend to just use it as a suction catheter. So the FLARE study, again, single-arm study, 108 or something like that patients. The results basically showed a reduction in RV-LV ratio, much like the Penumbra device and much like the ECOS device, but with no control arm. So I did the first case in the UK earlier this year. Congratulations to the German centre that beat me to the first case in Europe. And it was a case of paradoxical embolism with clot in transit and a large volume pulmonary embolism. So this was a lady who presented with actually a cold left leg, and she'd been told for 2 months to keep having COVID tests for her breathlessness because she was ringing up and saying, I'm short of breath, and they were saying, get a COVID test, get a COVID test. So she'd had something like 12 COVID tests and hadn't managed to make it to a hospital or a doctor. She presented to hospital because her left foot went cold, and when she came in, she had an arterial embolism of the left lower leg that was, it didn't create a critical limb, but she had a little bit of numbness and discomfort in the leg that resolved without any need for intervention into the artery. But what's clear is she had an obvious DVT on the right leg. So left leg had an arterial thrombus, and right leg had a DVT. And she had SATs of 73% at rest, which she probably had for weeks. And her respiratory rate was pretty high. An echocardiogram shows she was shunting through a PFO. She was quite difficult to supplement with oxygen. So she has RV strain, not too bad. As I said, the orthodox technique is to measure the largest right ventricle about 1 centimeter north of the tricuspid valve, and then find the largest section of the left ventricle. Doesn't have to be on the same cut, but in the end, it doesn't really matter. This is an elevated right ventricle. She has bilateral clot, not a vast amount. She's got a saddle here and some clot here and here. and into the left lower lobe. So this is the echo that we looked at in great detail. We're still not absolutely certain, but you can see that there's probably an atrial septal aneurysm with a PFO here, and there's this material here that subsequently was not seen as clearly on the post-procedural echo. So we think there was probably a bit of clot attached to the atrial septal aneurysm. So the decision is what to do about this. She's already had one paradoxical embolism through to the left leg. If she gets one through to the brain, she's going to have a pretty serious stroke. And you can see the shunting here, shunting through from right to left. And she has acute pulmonary hypertension that's stretched the right heart and has opened up a PFO. So about 1 in 5 people will have a PFO, but what's interesting here is that the strain on the right heart from the PE has opened it up and made it much more clinically apparent. So what we did was we took it to the cath lab, we put a sentinel cerebral protection device in to make sure that if we went up, we didn't cause a stroke by knocking the clot through that septum. We started with the Inari 24 French device at the base of the right atrium and put suction on it. We didn't get anything. We then went further in, closer to the atrial septum, and we got what's called a lollipopping. So we got an absence of suction of blood, so we were on something. There's a wire in, so it's probably unlikely that we were on the back of the right atrium, but not impossible. So we think we had the clot, and then as we were trying to pull it out, it released and went north. And that is a risk of doing these aspiration procedures in patients with a big PFO, is if you're going to suck that clot out the right atrium or even out of the lung, you've got to make sure it comes into the catheter, because if you're pulling it through the right heart and there's a big shunt, you're potentially putting the patient at risk. But in this case, we felt that we were justified in what we were doing, and I think what happened is we pulled it back and it went up into the lung. So this is the device. So this is a pretty uncomfortable appearance. So this is a 24 French device under a lot of tension, and this happens not infrequently with the Inari device, that you see this tension at the tricuspid valve. So at the moment, their published complication rates are very low, but I will wait and see what it's like in the real world. Yeah, I'm finished now. She was not enjoying the procedure at all, but we managed to do a very quick aspiration run in the lung. That's in the left lung. We got some clot out. There's actually more than that, but it got binned, unfortunately. And she made a transformational recovery and did extremely well, off oxygen within a few days, and actually went home on day 5, having been 73% on a 30-day follow-up. There's no clinical events. We can't see the PFO anymore. The potential for thrombectomy is clear. So this is another Inari I did. So a patient who was booked to go to ITU from the emergency department, and 50-odd-year-old with cancer came up to the cath lab. I got this out in one go, 20 minutes, the procedure. And you can see this material here. You wonder if that's ever going to go. Patient was fine. They were fit for discharge the next day, but needed a couple of things tidied up with their cancer. So, in conclusion, PE is a disease with increasing treatment options. There are 3 companies building research programs, but the only one with an outcomes trial is the ECOS device, which is now recruiting into a large, high-quality, randomized controlled trial powered for outcomes. PE-related mortality rates of 15% in patients without shock are too high. We can't accept this. We've got to do something about this. But that needs research, and it needs people to recruit to these trials, which hopefully we'll be doing over the next couple of years. So thanks very much.
Thank you. Thank you, Andrew. And the length of your talk is equivalent to the length of the thrombus you got out.
Sorry about that.
But this is of course very impressive. Come to Andrew in the intervening minutes. We have time for one burning question, because then we have to go on to stick to the program. I'm sorry, and there is of course possibility in the workshop
Yes.
to come back to this. So one burning question. And it's classic that the chair would ask this. So let me just have one remark. I was very glad that you mentioned that in spite of the extreme circumstances, we try to need 1A evidence and 1B, and it's so important. That's HiPiTo is now going to be run. And I hope that the design of HiPiTo will be flown to the audience, because that is good to have a grab and also the process, how difficult it was with the sponsor to come to this design. But it succeeded. Important. Thanks again very much, Andrew. Cheers. Now it's my real pleasure to announce a student in former days who went to Amsterdam, advised by his father to do research in the thrombosis department in the Tweede Helmerstraat 106 Amsterdam West, where I was a PhD, and this was Marcel Levi. And those of you who've never met him, just look at journals, not medical journals, but normal journals. For instance, Parool, Amsterdam Journal, he has a column. And Marcel is very optimistic, always smiling, and this is the way he describes life, and he is very outspoken. And that's why it's beautiful to have him as a speaker. His official titles are President of the Dutch Research Council nowadays. And he's also, and I didn't know this, the Chief Scientific Officer of the Netherlands. And that was an invention. I don't think it's yet fully clear what it means, but probably he will hint to that. And it's a real pleasure to give him the word. And you see that he formally and still is attached to University College London. Marcel, I give you the floor. Thank you very much.
Well, thanks, Menno. That's a very nice introduction. It's a big pleasure being here. I have to admit that I also do not know what it means to be Chief Science Officer of the Netherlands, but it is at least a title that made me convinced to come back from London, and also it gives me more salary. So it is working, at least for me. But that's not the topic of the talk today. It is about COVID-19, and I do realize that you had a talk about COVID-19 yesterday, which focused on thrombosis. So I will mainly focus in the first part of my talk on the coagulation system, but of course it is not avoidable to then move very quickly and briefly to thrombosis, because I will try to translate what we find in the clotting laboratory to what we will see in the clinic, and then a few words about COVID vaccination, which also has links, as you know, to a thrombotic condition. Just by means of introduction, COVID-19 is almost 20, no, it's a little bit more than 20 months with us now. And it is quite, well, mind-boggling to realize that such a small particle is only 1/10,000th of a millimeter, and it contains only 15 genes. In comparison, humans have 30,000 genes, has been able to put the world completely upside down. And you may realize this picture from China in January 2020. And at that time, most of us thought, well, you know, this is maybe an Asian problem, it's far away, we'll see what happens. And many people believed that it would never ever affect the rest of the world, which of course was not true, because very quickly it traveled around the world. It probably came from, that's the latest, from a businessman who worked in Wuhan, but then had some business to do in Singapore. So it traveled to Singapore, and then he went skiing in the Italian Alps. I'm very jealous of that type of life, but that's what he did, and then actually it started all over Europe. This is a theory, it's not, of course, very hard to prove. But you also do realize all these pictures of hospitals, first in Italy, Spain, but also then I think almost everywhere where hospitals were put under a lot of strain. And of course, the only remedy at that time was just, you know, start lockdowns, and which is actually quite effective, we all know that, but also has a lot of side effects in terms of social and economic things. Well, everybody will have an opinion about that. I'm not going to elaborate much more, but I'd like to focus on the science, because it is quite impressive what actually happened. Very briefly, after the first patients with COVID-19 were discovered in China, because after 2 weeks there was already a publication which later on appeared in the New England Journal of Medicine, identifying the virus, characterizing the virus, even photographing the virus. And another 2 weeks later, we knew the molecular composition of the virus, and that's still the blueprint, of course, for the tests that we do, the PCR tests that we do still. And another 4 months later, people developed a vaccine. And another 4 months later, vaccines had been tested clinically. And another 4 months later, they were implemented clinically. So I think this is a big triumph of science. And that's also true for the coagulation and thrombosis part of COVID-19. So apart from all the tragedy and the difficulty that we all experienced, I think it is also a little bit, sometimes a little bit to celebrate. This is one of the very first publications from China again, pre-published in February already, and then published in the New England online in the end of February. And they quite precisely already described clinical characteristics of coronavirus disease. And they were the first to say, well, actually there is something strange going on. So they focused on some laboratory parameters, and they did show there was an interesting, it may be a little bit small, but I'll tell you, there was, well, in some patients, a very, very mild reduction in the platelet count, but those were the most severe patients. But what was really impressive was the D-dimer level. And they saw high D-dimer levels in most patients with severe COVID-19, but actually they were also able to already relate this to disease severity. And there were high levels of, much higher levels of D-dimer in the most severe patients and the ITU patients and patients with the better outcome. But also they saw D-dimer levels which were much higher than what we usually see in patients with, example, with pulmonary embolism. And they were also much higher to what we see in patients with disseminated intravascular coagulation, who usually have the highest level of D-dimer. So this was really exceptional, and this is different from D-dimers that we usually see in those patients. Well, and then it started. If you type into PubMed COVID and coagulation or thrombosis, and I did this in October last year, then I already found, and this is then within 9 months or so, almost 2,000 publications. And not all these publications are, well, the very best publications in the world, but still, this was actually something that was eye-catching to many people who actually wrote down their experience. I did it again lately, and then there was another 1,500 publications on top of that, including a lot of randomized controlled trials, which help us to manage these patients. So this is actually attracting quite a lot of attention. So back to what we were actually seeing, Dr. Tang, I think, should be credited for the first publication in the Journal of Thrombosis and Hemostasis, describing a little bit more in detail the coagulation system. And there is lots of information. It's only a relatively small study at that time, but still more than 180 patients, and he divided his patients into survivors and non-survivors. And what he actually demonstrated was there was a little bit of a signal in the prothrombin time. It was slightly longer, especially in the most severe patients. Again, he also described the D-dimer phenomenon that was already described before. But there's also interesting other information in this paper. Many people focus on fibrinogen, which I think is totally ridiculous because it's just an acute phase protein and it doesn't tell you anything about COVID-19. But look, for example, to APTT. I already showed you platelets and antithrombin, and they're only very, 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 there are some alterations, but they're also very, very, very minor. So this is not the typical consumption coagulopathy, disseminated intravascular coagulation that we see in critically ill patients or VIII. It has some features, but it is something distinctly different. And I think that's important to realize. Back to D-dimer, I think now we have many more studies. A lot of repeat studies, which is okay because it will give us more robust information. And I think if you put them all together, it's fair to say that just an elevated, I'm not even talking about the very high D-dimers, but just an elevated D-dimer increasing your chance of dying of COVID-19 by a factor 6, which is quite impressive. There's not very often that risk factors have such an important predictive power. So whatever you think of D-dimer, and I'll come back to it in a second, it has a very strong predictive value. I did hear somebody say this morning that, and I agree with that actually, that nowadays it seems that D-dimer is being measured by everyone who comes into the emergency department, even if they just come in to ask the road or visit someone else. Everybody gets a D-dimer, and it's just waiting until we do a D-dimer every hour, because you never know what you'll find. And I have to say, I'm working both in the emergency department. I worked in the emergency department in London, and now I'm working in Amsterdam. It's almost impossible if you have coughed 3 times to leave the emergency department without a CT angio. So on one hand, you can make jokes about that. On the other hand, we learn a lot. And it is actually sometimes helpful, I have to say. But we've come in a very strange situation. At least in London and Amsterdam, it may be much better in your place. It's interesting to think where D-dimer is actually coming from. You all know that D-dimer is a fibrin degradation product. So you cannot get D-dimer if there is no fibrin, but you also cannot get D-dimer if there is no fibrinolysis. It's a mixture of both. If there is no fibrin generation at all, you cannot get D-dimer. That's different from most fibrin degradation products that you can also sometimes see in the laboratory, because they cross-react with fibrinogen degradation products. So if there is lots of fibrinolysis but no coagulation activation, you can still get FDPs, but you don't get D-dimers. So that's interesting. They're quite specific for both. And that helps us a little bit. So you can argue that this is just a consequence of coagulation activation and secondary fibrinolysis, and that's the reason that there is so much D-dimer. But okay, that's something you may consider, and you can even argue, well, there is also a little bit of thrombocytopenia, which is suggestive of thrombin generation and consumption, and the clotting times are a little bit prolonged, which may be suggestive of slightly lower coagulation factors, also as a result of consumption, all true. So that may be true, but that doesn't explain why D-dimers are so high, so much higher than what we see in the most severe septic cases, even meningococcal septicemia. So it is disproportionately high. And to be honest, we have all kind of DIC scoring mechanisms, whatever you think of them, but still, hardly any COVID patient scores positive on these systems. So it is hard to say that this is the only explanation. There is another interesting thing, and that is that many patients with COVID-19 have a specific pulmonary picture, as you know, which is actually pathologically dominated by fibrin deposition, which is a hallmark of acute lung injury and adult respiratory distress syndrome. So there is tons of fibrin in the lung, which is slightly unusual for patients with acute pneumonia. And it might be that that contributes to D-dimer levels as well. So it might be just a hallmark of that particular pulmonary situation. It's actually a little bit more complex than that, because we now know much more about the different processes that underlie coagulation activation in patients with COVID-19, and it is these mechanisms that I've just explained to you, but there's also lots of additional interesting mechanisms, some of which are in an early phase of discovery and other ones are fairly established. So I'll tell a little bit about endothelial cells in a second. There is interesting information rapidly accumulating now about the role of neutrophil extracellular traps, which is something that we know in other situations, that we know also in infection-associated coagulopathies, but is actually quite impressive in patients with COVID-19. There is a role for platelets, and then, of course, there is the ordinary things that we see in patients who are critically ill. Interestingly, there is also a very specific effect on the plasminogen-plasmin system. I specifically do not say fibrinolytic system. It is, of course, the fibrinolytic system, but it has more roles than only fibrinolysis. And that's why in this setting, you better call it the plasminogen-plasmin system. And this is not specific for SARS-CoV-2, which is causing COVID-19. It is exactly the same with SARS-1. Actually, to be totally honest, the thrombotic prodeposition that we see in patients with COVID-19 is exactly the same for all coronaviruses. It's the same for MERS, it's the same for the original SARS, but the patient numbers were much smaller. The patient concentration was much more localized. MERS was mostly in the Middle East, SARS was mostly in Asia and a little bit in Canada. But those who did systematic research saw exactly the same. But since the numbers were so much smaller, it did not attract a lot of attention. And why is it that coronaviruses are so strongly associated with this coagulopathy and this thrombotic tendency? Well, I'll give that answer in the next slide. But just focusing now on the plasminogen-plasmin system, all coronaviruses are associated with enhanced plasminogen activator activity. So that's another explanation for the high D dimers. There may be a little bit of coagulation activation, but there's also a lot of fibrinolytic activity. And that may be important, not only for creating D dimers. You may argue that that's not so important, but plasmin is one of the important mediators of the metalloproteinase system, and that may be a very good explanation for matrix, very rapid matrix remodeling, and that may cause vascular leakage and pulmonary edema, which is another feature which is quite specific for COVID-19. Well, where does this all come from? Well, this is the answer. Coronaviruses directly infect endothelial cells. The only other virus that can directly infect endothelial cells is cytomegalovirus, but not very effectively. But coronavirus does it very well. And that's probably giving us a lot of answers in the underlying pathophysiology. So this is the dimer, you already knew that, and thrombin generation. But this is, for example, von Willebrand factor antigen, which is a poor man's marker for endothelial cell perturbation. And that is fairly high in patients with COVID-19. And if you look at more specific markers of endothelial cell injury, then you'll find them, like the selectins, you find them to be very, very high. And there is now also direct evidence of infection of endothelial cells by SARS-CoV-2 from pathology, mostly from patients who died, but sometimes there is also biopsy material, which is quite convincingly showing that there is not only direct endothelial cell presence of the coronavirus, but also directly related to thrombotic depositions very nearby in these infected cells. Beautiful, beautiful evidence that helps us a lot. And it also explains something else, because post-mortem findings in patients with COVID-19 were indicating also a lot of microvascular thrombosis and hemorrhage, mostly in the lungs, sometimes in other organs like the heart or the brain, and in the peripheral tissues. And it is hypothetically so that if your endothelial cells are in particular affected by coronavirus, there will be massive release of ultra-large von Willebrand factor multimers, which is normally, as we all know, cleaved by ADAMTS13. But that is a system that is very rapidly overwhelmed if there is too much von Willebrand factor release. And therefore, there may be a secondary consumption decrease of ADAMTS13, even more high molecular multimeric von Willebrand factor, and this of course will stimulate pathological platelet vessel wall interaction, or in other words, thrombotic microangiopathy. And this is not only theory anymore, but there is now an increasing number of publications. This is the first one, but there's also more larger studies and also a little bit more robust, showing that in the most severe patients with COVID-19, there is fairly low levels of ADAMTS13, sometimes even below 30%. Well, of course, that may bring you to the speculation that maybe doing something about this, and we now have nice interventions for patients with TTP, for example, that may help some patients with COVID-19. But this is not a single study in the world has looked at this, but it is maybe something for the future. So putting that all together in a very simplified scheme, there is this inflammatory effect of coronavirus, which is just a traditional route of activation of mononuclear cells, tissue factor expression, and coagulation activation. But besides, there's a couple of specific mechanisms that are a little bit different. Endothelial cell injury by direct infection, which causes plasminogen activator release, which may contribute also to the high D dimers that we see next to the fibrin in the lung, and then a component of thrombotic microangiopathy. So if you want to put this all together clinically, it's not so easy. It is a little bit of DIC, but as I've argued, there is also lots of arguments that this is not the typical DIC that we usually see. There are components of thrombotic microangiopathy, but it's not the classic TTP, hemolytic uremic syndrome type of disease that we see. There is a little bit of literature on the role of antiphospholipids, and I find it difficult to really understand that literature, because, but certainly it does not meet the official criteria for antiphospholipid syndrome as we know it. And there's some components looking like inflammation, or if you wish, cytokine storm-induced coagulation activation. But probably it has a little bit of everything and is a distinct coagulopathy in itself. Well, the relevance of all this, apart from all the laboratory abnormalities, is not so much hemorrhage. The incidence of hemorrhage in COVID-19 patients, even the most severe ITU patients, is fairly low. Even if we give them anticoagulants. I'll come back to that in a second. So there is some hemorrhage, but it is not the type of hemorrhage that you would expect from a severe coagulopathy. But there is, of course, the phenotype of thrombosis. And this was already very early in the pandemic, where people actually say, well, we do see a lot of acute pulmonary embolism in those patients. And of course, in the first case, these were just case reports and nice pictures and impressive CT scans. But fairly soon, there were also series. I think the first one was of Frederick Klok from Leiden, who was speaker in a symposium. He's unfortunately not here. And he was already showing that there was quite a high incidence, not only of pulmonary embolism, but also of venous thrombosis. We diagnose more pulmonary embolism because we do so many CT scans in these patients, also for other reasons. But if you would systematically do venous ultrasound, then your numbers are also high. And that may be an explanation for the fact, if you quickly look at this slide, the numbers are a little bit variable between the different studies. Sometimes it's much lower, sometimes it's much higher. And this may have to do with study methodology, patient selection, but also with how we actually diagnose venous thrombosis and pulmonary embolism. And it may also have to do with the whole discussion on were these patients getting prophylaxis already or not. And you may say, well, why? Every critically ill patient will get thrombosis prophylaxis, but believe me, that's not true everywhere in the world. Again, we now have a long list of these studies, and it is helpful because they come from different parts in the world, from different health systems, and what you see here is that there is indeed a fairly high incidence, somewhere between 25–30% of patients, still difficult to say with or without heparin prophylaxis or low molecular weight heparin prophylaxis, who do develop venous thromboembolism. And the difficulty in interpretation is also so because in most of the publications we distinguish critically ill patients who are in ITU and patients who are sick and are in hospital on the regular ward. But that distinction is also not the same everywhere in the world. So my biggest surprise when I came back from London to Amsterdam is that many of the COVID-19 patients that we had in hospital went to ITU, whereas in London they were just being seen on the regular ward. And we did lots of non-invasive ventilation on the regular wards. But in another health system, that may be an indication for an ITU admission. It just depends on the skills of your nurses and how the hospital is organized. But it may have quite some impact on the studies. And that will also be interesting if we discuss heparin and the dose of heparin, because there seems to be a distinction between ITU patients and non-ITU patients, but people forget that that's not a clear definition everywhere in the world. There are huge differences between countries. Okay, nice to see very briefly whether there are specific risk factors for venous thromboembolism in patients with COVID-19. And no surprise, the typical risk factors that we know as risk factors for an adverse outcome in patients who are infected with coronavirus are also risk factors for thromboembolic complications. So we don't know whether this is a specific risk factor or just related to the fact that these patients are sicker. Male gender, age, and higher BMI increase the risk of thrombosis and pulmonary embolism in COVID-19. A few words about treatment. I know it's been discussed yesterday, so I'm going a little bit quicker here. Again, I'd like to give credit to Dr. Tang, who under difficult circumstances was brave enough and strong enough to publish what he found with these first patients. And this is a classical study, and he actually said, well, you have to give heparin to these patients, because if I compare patients treated with heparin with those who did not get heparin, I'm talking about heparin prophylaxis, then I do see a difference. Of course, you can really discount this study, but I'm only showing it because it's the first one, and I find it impressive that he was able to do this in very difficult circumstances, because only 15% of patients in China got heparin prophylaxis, which is very different, I think, from the Western world. And also, it's a very small study. But, okay, it gives some indication. SIC, as you see here, is sepsis-induced coagulopathy, which is just a coagulopathy score. As I tell you, we don't think that it is sepsis, so we now have COVID-19 specific coagulopathy scores, which are not that different, I have to admit, from what you see here. He was also able to show that the biggest difference between heparin and non-heparin, again, this is not a randomized controlled trial, this is just retrospective analysis, was that in patients with the highest D-dimer, the biggest the effect of heparin was. And that is actually being copied by many of the bigger prospective randomized controlled trials that were done later on, and was even an entry criteria for the most late studies. Well, and then I skip a lot of interesting publications, then I come to the big randomized controlled clinical trials, again, a triumph of science that they were done at an international level, very quickly, very rigorously, in situations that it's not so easy to do clinical research, but they were done. And this is, of course, an important one, where the therapeutic anticoagulation was compared to prophylactic anticoagulation in critically ill patients. And as you can see on this slide, actually no difference between the two groups in terms of effect, but there was a difference between the two groups in terms of, let me go back, in terms of bleeding. More bleeding complications in the therapeutic heparin group, which is not a surprise because these were critically ill patients on an ITU with lots of indwelling catheters, invasive procedures, very sick. So not surprised that if you give therapeutic anticoagulation that the bleeding rate will go up. The surprise was actually that it was still very low. It was below 5%, which is much lower than what we see in septic patients who get, for example, therapeutic heparin. But it was fairly higher than in the non-therapeutic heparin. There was no efficacy signal, so many people believed, okay, we have to stay away from therapeutic heparin if there's no clear indication in critically ill patients. It might be slightly different in patients who are non-critically ill, so patients on the ward, with my caveat that that's not everywhere the same. And there was a difference in favor of therapeutic heparin compared to prophylactic heparin, but I have to say it was fairly small. And there was also a bleeding difference between the two. I apologize, that's the lower line here. There was almost a doubling of the bleeding risk, but again, the numbers are fairly low, so it went from 0.9% to 1.9%. Still, some safety effect that we need to take into account. And this is just another example, an action trial, also a beautiful trial, that was recently published in The Lancet, where they saw a slightly bigger effect of therapeutic anticoagulation compared to prophylactic anticoagulation. So there's lots of discussion now, and part of it was already discussed yesterday, whether for this particular group we may consider higher doses of heparin, but you have to take into account that there is a safety signal. If you put this all together, this is published this month. It is pre-published, I have to say, but it will appear in the European Heart Journal of Cardiovascular Pharmacotherapy. Then, if you take it all together, then it is actually, well, it gives you some information. If you take mortality as an endpoint, you're not going to expect a lot from therapeutic heparin, and that is because most mortality obviously occurs in an ITU setting, and there the difference was fairly low, whereas mortality of COVID-19 patients in a ward setting is usually not extremely high, and there was not much difference. And the bleeding effect I already described. And this may be hard to see, but it is just to give you an indication, yes, it does help to reduce VTE. Very good. Well, that's what we would expect from therapeutic heparin. So, okay, it is not mortality, but it may still be an important outcome. It does not affect arterial thrombosis, which, to be totally honest, is not the huge or very specific problem in most patients with COVID-19. And then all kinds of guidelines have been developed, and I'm not going to dwell on the guidelines because, well, they just follow the clinical evidence that there is, and they're not very complex. It is not a wrong thing to assess coagulation regularly, but not too often. I would suggest every 2 or 3 days, just to get a feel on where you are with your patient. And of course, they can have another complication. And I think most centers will agree that all these patients at least will need prophylactic heparin. And for some selected non-critically ill patients, you may consider actually to give higher doses of heparin. Well, and then of course, if there is so much worry about therapeutic heparin, and we are comfortable with prophylactic heparin. People speculate about intermediate dose heparin, so that's somewhere between prophylaxis and therapeutic, and there are ongoing studies looking at that. I'm almost finished, but I'd like to say a few words about the coagulopathy that's related to COVID-19 vaccine. And that's mostly the vector-based vaccines, and then in particular the chimp vector-based vaccine from AstraZeneca, and to a smaller extent probably the Janssen vaccine, and probably not at all with the mRNA vaccines. And I was actually, it was my last days in London that we saw the first patients with this, presenting with a very typical, mostly cerebral vein thrombosis, so this is sinus venous thrombosis or sagittal vein thrombosis, but also a lot of portal vein thrombosis, mesenterial vein thrombosis, and ordinary venous thromboembolism like venous thrombosis in the legs or pulmonary embolism. And they all had this complication about 2 to 4 weeks after their first injection of AstraZeneca vaccination. And they all had very typical low levels of platelets and not a specific further coagulopathy. And we speculated at that point in time that this looked very much like a syndrome that we knew, and that was heparin-induced thrombocytopenia. But that was a wild guess. But Mary Scully, who is actually the principal hematologist in London, then called me the next day and said, well, I did a HIT test and it's positive in all of them. And we had about 7 of these patients in the hospital at that time. And then she also had access to samples from other centers in the UK, from Birmingham, from Scotland, from some other centers, and they were all positive. So it was actually quite interesting to see this. So at that time we thought this is a type of heparin-induced thrombocytopenia, but not caused by heparin, but by vaccine. So that was the first name, vaccine-induced thrombocytopenia and thrombosis. And that was not the case. It's slightly different, as I'm going to tell you in a second. But it looks, clinically, it looks very much the same. It is characterized by thrombocytopenia in combination with venous thrombosis. Typically, and that's different from heparin-induced thrombocytopenia, cerebral vein thrombosis. And up until now, it is not clear why it is that typical type of thrombosis. And that's a very interesting and good question to ask, because if we know that the answer to that question, we probably understand this even better. The diagnosis is not very difficult, and I'm also coming back on that in a second. It is in most centers the conventional heparin-induced thrombocytopenia test that you would do in a patient. And that's a lot of work by Andreas Greinacher and his colleagues from Germany and from Austria, who were also describing this in the same issue of the New England Journal of Medicine. They were the first actually to identify this mechanism as well. And he did a lot of work on which diagnostic test you should do in those patients. And I think most people now believe it's a simple antiplatelet factor 4 ELISA. Most of the antiplatelet factor 4 ELISAs will do it. So the whole thinking about the mechanism is it has nothing to do with heparin. It is just an autoimmune phenomenon where you make antibodies against your own platelet factor 4, which actually activate platelets. And then the mechanism is not very dissimilar from heparin-induced thrombocytopenia. Also lots of work, again, in the same issue of the New England Journal of Medicine. This is actually amazing. This was published 10 days after the identification of the first patient, at least in London. So it went really fast. So they can do it quickly if they have to. So it's something to remember if you have to wait 6 months or so until you get an answer from them, if you submit the paper. And they did actually also a lot of work on the therapy. And they found that if you give intravenous immunoglobulins, maybe prednisolone, we're not sure about that, but everybody's doing that right now. Avoid platelet transfusion, because in the beginning, most of these patients get almost as a reflex platelets, but that's probably made it worse instead of making it any better. And sometimes apheresis, but again, that has a big question mark. Then most of the patients recover fairly quickly. And the good news is also that we looked at patients very recently. This has just been accepted in this journal, but that you can find it online already, where we looked at the group of patients with an early diagnosis in the very beginning, just when we started doing vaccination. So this is February, March, April. And more recently, because there's in the world still a lot of patients who do get these vaccinations, and you look at the incidence and the outcome of the disease, the diagnosis is made more frequently, which is not a surprise because we are much more eager to look for it and to recognize it. But also, if you look at mortality, that's the bottom of this slide, has dramatically improved. It's still high, it's still 22%, but we came from 50%. And we believe that if we go even further, then it might be that the prognosis of these patients might be even better, because the prognosis, usually the prognosis of cerebral vein thrombosis, it's a dramatic disease, of course, but usually their prognosis is fairly good, and their mortality is far below 10%. So there is no reason why we should not reach that here. It's extremely rare. It is overall 1 in a million. In younger people, 1.5 in a million, but still something to realize. So in conclusion, and then I'll stop, of course, severe COVID-19 is associated with a specific coagulopathy, which is different from what we've seen before. It is a marker of adverse outcome, in particular D-dimer. It does translate into a pro-hemostatic state with a higher incidence of thrombosis. And we have learned a lot about the optimal prophylaxis and treatment of these patients, but I think there's still room for a lot of further improvement. Thank you very much.
Thank you very much, Marcel. I am not at all disappointed. On the contrary, it was a beautiful talk, intriguing, provoking. We have time for a couple of questions. We will go with the other program. Who wants to raise a question? Yes, please, David. Microphone is coming. David Jiménez.
I know these are indirect comparisons, but it is intriguing because therapeutic anticoagulation is associated with large reductions in mortality and organ support-free days as compared to antiviral trials, corticosteroid trials. Do you have any explanation for this? Thank you.
Yeah, that's a very good question. So in general, I think it's all supportive treatment, in fact, because it's non-specific treatment, but it has some effect. It only, for me, underlines the importance of thrombosis, not only as the importance of thrombosis in itself or pulmonary embolism that may affect clinical course, but also just thrombosis as a factor in causing organ dysfunction in patients with COVID-19. And I think we need to learn a lot about that, but I think there's much more under the level of the water, like the tip of the iceberg, to learn. And the next, it's not typically your question, but it inspires me to think about this as well. We also have now all these patients with what we call long COVID, which is also a lot of trouble even after the COVID itself has been resolved. And a subgroup of them has, in particular, cerebral and psychological problems. And the neurologists that look after these patients now tell me that they think that microvascular thrombosis, so the thrombotic microangiopathy, is a factor in that. So a lot to learn. But yeah, I do agree with you that thrombosis is important and anticoagulants have a massive effect.
Yeah. Stavros?
Marcel, thank you so much for, that's really inspiring, a really great talk, as we expected, of course. We are seeing those patients who have had thrombosis, let's say 3 months after they have recovered from acute thrombosis and COVID, and they're now on therapeutic anticoagulation. So most people say, well, this is provoked thrombosis, so 3 months should be enough, but we're nevertheless faced with a problem. My question is, would you suggest any laboratory markers, any other markers that would let you say, let's prolong for 3 months, or I don't know. I mean, we do some inflammation parameters, to be honest. I'm rechecking D-dimers when I take those people off anticoagulants, but do you have some better advice?
Well, to emphasize, there is no evidence-based answer to your very relevant question. And I also, in my outpatients, I see these patients who had COVID, and I always say, oh, this is provoked thrombosis, so 3 months. But I'm not so sure about that, actually. So a duration of anticoagulation trial might be interesting, and there are massive numbers of patients, so it should not be the most difficult thing to do, comparing, 3 months with a year or so. And even more interesting, your suggestion, because I do remember the old COSME studies years ago, where she actually used D-dimer as a marker to stop anticoagulation or to continue anticoagulation, and found a reduction in recurrent thrombosis. So maybe you can, if you have an intelligent design, you can actually do a study where you look at the length of duration of anticoagulation and looked at D-dimer stratification at the same time.
Before we go to Piotr, very quick, you gave a beautiful talk on translational things, thrombosis. You stayed away a bit from the connection between the clinical apparent pulmonary embolism and the massive fibrin in the lungs.
Yeah.
Because there's a lot of discussion among people who are far more intelligent than the two of us.
Well, that's also a good question, and it might be a next step, because I do remember the very first COVID patients when we were not even that aware of pulmonary embolism. Most of them went for lung scanning because they had clinical deterioration, massive clinical deterioration. And then they went for scanning, and then we found pulmonary embolism and so forth and so on. I do believe that there is room to look at that connection, but there's not a lot of information available.
Piotr?
Yes, congratulations. I have one question. Do you think that this vaccine-induced prothrombotic thrombocytopenia is also present in other vaccines, vector vaccines?
Well, you know, the chimpanzee vector vaccine has only been used for Ebola so far, apart from COVID. And that was for a very small number of patients, and there are no reports of vaccine-induced thrombosis, but, well, maybe people had it, but it's very different circumstances. So that's the only thing we really know. I personally believe, looking at the evidence, that it might have more to do with the fact of the overexpression of the spike protein and is not related to the vector. Because the expression of spike protein after the vector-related vaccines is much higher than compared to the mRNA vaccines. Actually, please don't cite me in public, the vector vaccines are probably clinically more effective than the mRNA vaccines because they give so much overexpression of the spike protein, but that also is causing now adverse events. But you know, all these things need to be sorted out. There are millions of patients who are getting these vaccines, so of course we will learn, and lots of people looking at this. But yeah, at the end of the day, it may not be true what I'm saying, and then it might be vector related. But it's a bit strange because the vector, the adenovirus vector in the Janssen vaccine is very different from the chimpanzee adenovirus vaccine, and they both give this complication. So that's what makes me think it must have to do with spike protein expression than something else.
So Marcel, you really prickled and tantalized our spikes in our head, and I hope you will be available after the presentation of the abstract. I know that Marcel is very approachable, so please go to him if you have more questions, more ideas, and you will get back the same answers as he does just the other minute. And then you can go get to work. And if you have done this work, you again mail Marcel. He answers the minute you send this mail, and even sometimes before you have sent the mail. Okay, Marcel, thanks very much for your talk. Fantastic. So now there are a few housekeeping rules before Stavros is running to his talk for Romanian doctors.
Yes, just 1 minute. What is going to happen after the abstract session? So we will reconvene. You know, we have a briefer break today for lunch. So we will be ready hopefully at let's say 1 o'clock or 1:05. We will meet again. So we start again at 3:30. So two things about this. We do have a true hands-on extra demonstration of the right heart simulator. So I do invite you to, we will be here, Dr. Michele Dalto and myself, starting 2:45. So please come in. It will not be a lecture. You can be very casual, and please touch this thing and see how it works. It's good when you're talking about pulmonary hypertension to know what a right heart catheter is. Otherwise, you're just writing. So the other thing is, in our abstracts and our workshop sessions, so for almost all workshop sessions, the groups that were there will remain there, and the moderators will come to you, and that the group that was here will remain here, and the moderator will come to you. Only one exception. There is only one exception always, and the exception is the pair of the workshops 7 and 8, right? Because there we also need Michael Sproule, and we only have live streaming from this room. So this is the only exception, so that those who were in workshop 7 will have to come over here to see workshop 8, and those who the participants who were in workshop 8 will have to go over there to the other room. So that's the only exception. In all other cases, as participants, you stay where you were, and the moderators will change. And that was all. I'll be with you in
Okay, Stavros. Now I ask Karen Schreiber and Nicolas Meneveau to chair the abstract session number 3. And I hope we will give follow-up on yesterday evening, which was very interesting because aside of the pitches, there was some small question by the... There were some small questions by the chairs, which was really upgrading the pitches to a mini presentation. The floor is yours. Thank you very much.
Is it 5 minutes per patient? I was about to say, per presenter.
I'm not sure if it's... I think it's a little bit... It's 3-minute talks, but... Yeah. 3-minute talks.
Hello, everyone.
Can we get sound here? Sound here, please, with the chairs.
Hello? Yeah. Hello, everyone. So welcome to the abstract session 3. My name is Karen Schreiber. I'm a rheumatologist based in Denmark, partially working in London. And Nicolas, do you want to? Well,
and my name is Nicolas Meneveau from Besançon. I'm a cardiologist.
Yes. So I think we would like to welcome the first presenter, Dr. Burgraaf. Would you like to present yourself?
Thank you. So I'm a PhD student at the Department of Clinical Epidemiology in the Leiden University Medical Center, and on behalf of all co-investigators, I want to present to you a protocol of the Leiden Thrombosis Recurrence Risk Prevention Study. So as clinicians, you may all recognize the clinical question on treatment duration after a first venous thromboembolism. And the question is then, should I continue or should I discontinue anticoagulant treatment after the initial 3 months? And this, according to guidelines, should be a decision made on the balance between VTE recurrence and major bleeding risks. Both risks are considerable in the short term, but even more when you consider long-term risks. So therefore, we have made a treatment strategy, and we aim to evaluate tailored duration of long-term anticoagulant treatment based on individualized risk assessments of both recurrent and VTE and major bleeding risks. And here on this slide you can see this algorithm. So what we do is, what we aim to do is a multi-center cohort-based randomized controlled trial in which we will include 1,600 patients with a first venous thromboembolism, both provoked and unprovoked venous thromboembolism. And what we then do is we will assess the risk of recurrence and the risk of major bleeding during the initial 3 months of treatment using the L-TRIP and VTE bleed score. And then after 3 months we will make a decision to either stop, continue or randomize duration of anticoagulant treatment. And that we will do as follows. So in patients with a low risk of recurrent VTE, we will discontinue the treatment. In patients with a high risk of recurrent VTE and a low risk of major bleeding, we will continue the treatment. And in all other risk groups for whom it is still debatable how the balance between major bleeding risk and recurrent VTE risk is, we will randomize between discontinuation and continuation of treatment. And then after 2 years of follow-up, we will assess the rates of recurrent VTE and major bleeding, as well as some other secondary outcomes. So hopefully in 5 years I will be able to present to you the results of this trial.
Thank you so much. That was very... I'm very impressed with the numbers you're aiming to enroll. How many centers are you in total?
Well, now at this time we have started recruitment in 5 centers, but we aim to include more centers. So there are some centers in the process of obtaining approval, but we will need a lot of centers to...
Yes. And do you have a minimum recruitment target for the centers that you take on, or...?
There is no absolute minimum recruitment target, no.
So if there are any ambitious people here, they can join you
yes,
for your
they are welcome to discuss with me.
Okay.
On a methodological point of view, will you be allowed to separately analyze the impact of your strategy on the bleeding risk and on the rate of recurrence? Or will you not be allowed to analyze separately these two outcomes and use this as a net clinical endpoint?
Yeah, of course, we will also assess the different rates of recurrent VTE and major bleeding, but in the end, you want to have that treatment that results in the least of both, because both endpoints have considerable long-term consequences for the patients with the primary and with the VTE.
Thank you.
Thank you. We have a moment for a question, if there's a question from the audience.
Okay.
Okay, I think then we move on to the next speaker. Thank you so
very
much.
And the next speaker is Dr. Catheter from the VIII registry.
So, good morning. I'm very pleased to be here. My name is Judith Catheter, and I come from Lyon in France. I work on the VIII registry, and I hope that everybody knows it. This is a registry. We include consecutively patients with deep venous thromboembolism and deep venous thrombosis. So we focused on the risk of gastrointestinal bleeding after starting anticoagulant therapy for venous thromboembolism. And we include more than 80,000 patients with acute VTE. First, we found that the cumulative incidence of major gastrointestinal bleeding and non-major gastrointestinal bleeding was around 1%, while the cumulative incidence for other locations of major bleeding was 1.6. Gastrointestinal bleeding is a very important location of bleeding. Furthermore, it was interesting to notice that a good proportion of bleeding happened in the first 30 days after starting anticoagulant treatment. After 1 month, for patients who had major gastrointestinal bleeding, 7% rebled, 4% had VTE recurrences, and the third were deaths. This is a very poor outcome. And lastly, we built a prognostic score, including male sex, age over 70 years, initial VTE presentation as PE, active cancer, prior VTE, recent major bleeding in the gastrointestinal tract, esophageal varicosities, anemia, abnormal prothrombin time, and renal insufficiency and corticosteroid, corresponding to the risk factor to the initial characteristics. And our score had a pretty good statistics. With our score, we were able to identify patients with a cumulative incidence around 6% of major gastrointestinal bleeding. These scores may be very interesting in the future in our practice to adapt our practice. Thank you.
Thank you. Very brief question. Thank you for this presentation, nice presentation. Do you think that these results will change your daily practice?
I hope. For the moment, the score is very difficult to use because all the factors to calculate that are not very easy, like in the SPZ, for example. But I hope we can simplify it.
I do have a question as well. So the corticosteroids, usually we would divide them into low dose or high doses, and sometimes people use a cutoff of 10, other times 10 milligrams or 20 milligrams. Did you stratify for that at all?
No, we did not find any correspondence to the type of anticoagulant or the dosage.
No, the corticosteroids, the steroid
corticosteroids.
Yes.
No, the dose is not was not recorded.
Okay, thank you. So the next speaker is Dr. de Jong.
Thank you for the introduction. My name is Cindy de Jong, and on behalf of all the Team VIII investigators, I will present to you the first results of the Team VIII study on risks and outcomes of anticoagulation-associated abnormal menstrual bleeding. So the risk of abnormal uterine bleeding is increased in women that use anticoagulant treatment, with varying risks for the different anticoagulant drug classes. And abnormal uterine bleeding could lead to poorer quality of life and also lead to the need for blood transfusions. But however, there are little solid studies that quantify the prevalence of abnormal uterine bleeding. So therefore, we aim to assess the occurrence of new onset abnormal uterine bleeding in female patients with venous thromboembolism, patients in their fertile age treated with oral anticoagulants. And as a secondary aim, also the results of routine diagnostic workup were assessed. So this was an international multi-center cohort study. And women, female VTE patients aged 18 to 50 years were included. They were non-pregnant and had to have an active menstrual cycle. And menstrual blood loss was assessed by pictorial blood loss assessment charts, or PBACs, recording the number of sanitary pads and tampons for each day of the menstrual period. And these PBACs were filled out at baseline to assess the amount of blood loss for the last menstrual cycle before inclusion, and also prospectively during the 6-month follow-up. The patients were also contacted every 2 months to evaluate the presence of abnormal uterine bleeding. And 3 definitions of abnormal uterine bleeding were used: a PBAC score above 100 during 1 menstrual period, or above 150, or a self-reported increased menstrual volume. And 98 patients were included. And of these patients, 65% met at least one of the 3 definitions of abnormal uterine bleeding. And that was at one moment at least during the 6-month follow-up. A PBAC at baseline was available in 83 patients and used to select the patients that had no abnormal uterine bleeding at baseline. So we used that to assess the incidence of new onset abnormal uterine bleeding, as depicted in the 2nd and the 3rd column. So for example, in the patients with a PBAC of 100 or below at baseline, 60% had new onset abnormal uterine bleeding. And then these figures show that the prevalence of abnormal uterine bleeding decreased over time, suggesting a decrease during every next menstrual period. And the diagnostic workup showed a lower prevalence of explaining comorbidities than expected when compared to women with heavy menstrual bleeding in the general population based on literature. So our findings are suggestive for a causal relation between abnormal uterine bleeding and anticoagulant treatment. So for more details and also the next steps and analysis that we will perform, please visit my e-poster. Thank you for your attention.
So, thank you very much for your lovely presentation. It's actually a very important topic, I believe. So, do you have any explanation why the bleeding decreases over time?
We don't really have an explanation yet. Also, for example, for the varying risk between the thrombin inhibitors or the factor Xa inhibitors, it's not so. Yeah, it's not sure where it comes from. So maybe it's a state of that the body needs to get used to the start of anticoagulants, but we're not really sure. And for example, in the GI tract, it has to do with the mucosa, but we're not sure. No.
So sometimes what happens is that, for some physicians, it happens that once there's a VTE presenting in a young female who's on an oral contraceptive pill, the automatic reflex is to stop that pill. And what happens is women start to bleed. So the question is whether these women were started on other contraceptive methods, the spiral, like the hormone spiral, or something that would reduce the bleeding risk per se. So I think that would be important for you to gather that data once you
This is a good point, yeah.
present.
Definitely, yes, definitely. That's one of the secondary aims we're going to look at.
Very good.
Yeah, the effects of the modifications also in anticoagulant treatment during the whole follow-up period, but also the contraceptive measures. Yes.
Wonderful. Thank you so much. Thank you.
Thank you so much. Well, the next speaker will be Dr. Hendricks from the year's investigators. It's a Dutch session, isn't it?
Thank you very, very much for the introduction. And my name is Stefan Hendricks. And on behalf of the year's investigators, I would like to present our latest cost analysis comparing home treatment to initial hospitalization in normotensive PE patients in the Netherlands. Well, we know venous thromboembolism constitutes to substantial healthcare cost, and only in the Netherlands it's amounting to 60 million euros a year. And as we learned yesterday, VIII incidence is increasing. Well, home treatment could be beneficial for cost reduction, but an accurate estimation of cost savings per patient treated at home is currently lacking. Well, we therefore aim to compare healthcare utilization and cost during the first 3 months after PE in patients who were treated at home or who were initially hospitalized. We therefore performed a post-hoc analysis of the year study, also mentioned yesterday, performed in 12 centers in the Netherlands. And we only took those patients who were normotensive, diagnosed with PE, of course, in whom home treatment may have been considered. And then we assessed the average total healthcare cost during that 3 months period. Now the results, in the final analysis, we included 383%. And as you can see, nearly half of them were treated at home. Those patients were slightly younger than those patients hospitalized, and there were no relevant differences in gender or active malignancy. Well, home treatment was defined as discharge within 24 hours. So mean admission days for those treated at home was 0.7 days, whereas the patients with initial hospitalization were more than 4 days in hospital. Well, I'm not going to dazzle you with every specific costs in this 2-3 minute pitch. So these are the end results. Total average cost for those treated at home was 1,500, whereas patients hospitalized cost 32. And after adjusting for several co-founders, of course, we had an adjusted mean difference of 1,483 euros a patient. So if you want to know more about the specific costs and the cost reductions, please take a glance at my e-poster. Thank you for the attention.
Thank you very much. I don't want to be provocative, but I mean, home treatment is less expensive than hospitalization. Okay. Now, is it relevant? I mean, should we take this consideration into account in the management of our patient? I mean, I agree. I'm a little bit provocative, but...
we want to quantify the number. That's for once. But what you can see, those patients who get outpatient treatment, they all come to the more at the outpatient clinic, and they got a little bit more of readmissions. So that was taken into account too. What's the netto effect of home treatment? And luckily, we saw this result. We were expecting it also. Yeah.
Very good. Thank you so much.
Thank you so much.
And the next speaker is Dr. Yamakov.
Yeah, good morning, everyone. My name is Mateusz Yermakov. I work in a teaching hospital in Warsaw, Poland, and we are one of few centers in my country who perform catheter-directed treatment in acute pulmonary embolism patients. And what I want to do is to share our experience with you in this topic. I'm not going to repeat it because we've heard everything in the presentation just an hour ago. What are the indications? So when you have patient that doesn't improve despite your treatment, and you want to exaggerate the treatment, but you cannot because of the contraindications. And yeah, good luck with talking to the surgeon and taking your patient who deteriorates to the theater. That's the place where the catheter-directed treatment is perfect. We still don't do it on a daily basis. As you can see, we enrolled 33 patients over the period of time of almost 2.5 years. They were generally in a bad shape. Almost half of them was high-risk patients. For the intermediate, is it working? For the intermediate high-risk patients, the median BOVA score was 5 points. The level of troponin and natriuretic peptides was elevated, almost more than 10 times above the upper limit level. We analyzed the outcome in groups of mortality, the early mortality in hospital, and during the follow-up, we also analyzed the complications that could be related directly to the procedure. I'm not going to show it now. I invite you to see it on my poster, discuss it, maybe question the things that the decisions that we have done. But the general conclusion is that we are very enthusiastic about these methods, and we find CDT procedures not only very safe, but only extremely effective in patients of acute pulmonary embolism. Thank you.
Thank you very much for your lovely presentation. I missed, what was your hypothesis?
Well, this is more like a serious report, because we didn't randomize, of course, those patients. There are other trials for that. We just wanted to collect the data from our center and to share with you our results.
Sure. So, and your patient demographics, do you have them on your poster so we can see the comorbidities of those patients that you were assessing?
We can see on the poster the criteria that led us to that qualify them for CDT. The comorbidities, not really. This wasn't the case. The status of the patient during the hospitalization was important. So no comorbidities.
Okay, thank you.
Just a short question. The result you obtain in high-risk PE patients is very impressive, with a mortality rate of 9%. Do you preferentially use a specific device in this specific setting of high-risk PE patients?
Well, the device that is used is up to interventional cardiologists, because I'm not doing this. I'm a doctor from the ward. So, according to the disease, to the burden of the patient, they chose one from 2 or 3, I believe, systems that was used. You can see that on my poster, what was used.
Thank you.
Thank you.
Thank you very much. Next speaker will be Dr. Papanastasiou.
You will have 30 seconds extra for the long walk.
I'm sorry for the long walk,
no,
but I was...
welcome.
Okay.
We're looking forward to your presentation.
Actually, I'm the second author of this work. The title is Oral Anticoagulation Patterns and Prognosis in Octogenarian Patients with Atrial Fibrillation. So these patients are largely underrepresented in observational studies, and no focused RCT data exists. So this is a sub-study of an RCT we undertook in the second largest hospital in Greece, and it is a teaching hospital. The original study included 1,100 patients, all comers with AF, which were admitted for any reason in the cardiology ward. This sub-study included 330 patients who were over 80 years old, and they were, as the all comers, hospitalized with atrial fibrillation, comorbid AF. So we saw the stratification regarding oral anticoagulation treatment in these patients. Almost half of them received NOAC at discharge, and 30% received VKA at discharge. After doing an extensive multivariable regression, Cox regression, we came out with this number, the 0.72, which is the adjusted hazard ratio for all-cause mortality when comparing NOAC patients with VKA patients at discharge. This came out as not statistically significant. And among the variables that we used to adjust for, age, the presence of heart failure, diabetes mellitus, and the left atrial volume index were significant predictors of all-cause death. So these are the Kaplan-Meier curves. You see a small divergence in the first Kaplan-Meier curve between VKA and NOAC, but this difference diminished after multivariable regression. The secondary endpoints included stroke and major bleeding, and these came out not significant from the beginning. Thank you very much.
Thank you very much. I mean, your result just confirmed the data from previously reported registry data. I have just a short comment. I think that on the methodological point of view, a propensity score analysis would have been maybe more appropriate in this case. You have any comment on this? What kind of variable do you use for adjustment?
Okay. Apart from those variables that you see that came out significant, we had the BMI, we had gender, and we had presence of CKD, I think. These came out not significant. We used the rule 1 to 10, one variable for 10 events. So we used the maximum variables that we were allowed for the model. Another choice would be propensity score matching. It's just that we chose for reasons of expertise this method of multivariable regression.
Great.
I think it's something you could implement if you want to publish this. You can do that in your manuscript.
What do you say?
A propensity score match for your cohort. You could think about doing that.
Yes, of course. This is an alternative, but from a statistical point of view, this would be allowed also, but it would yield inferior. I agree that it's an inferior methodology.
Any further questions? No? Good. Thank you.
Thank you.
Thank you so much. Thank you. And the next presenter is Dr. Lütjen.
Thank you. I'm Dielke Luijten and I'm also from the Leiden University Medical Center. And on behalf of all authors, I would like to thank you for allowing me to present the abstract regarding the incidence and determinants of thrombotic and bleeding complications in patients with glioblastoma. Glioblastoma is a frequently occurring malignancy of the brain. It has an incidence of 3 over 100,000 persons. But it's also a very aggressive tumor with a median survival of 15 months. Glioblastomas are associated with a high risk of venous thromboembolisms, VTEs. But complicating the treatment with anticoagulants is that there is also a very high risk of major bleeding. The problem with current literature is that adequate incidence estimates are lacking due to that the current studies are small numbers, heterogeneous groups, and they include different stages of disease. Therefore, the aim of this study was to assess the cumulative incidence, risk factors, and prognostic impact of VTE and major bleeding in glioblastoma patients. We did this through a retrospective cohort study in 2 Dutch hospitals, where all adult glioblastoma patients were included, and they were followed 6 months before diagnosis until 24 months after diagnosis. These are the most important results. There were 967 patients included in this analysis. This figure shows the cumulative incidence of venous thromboembolisms, which is adjusted for the competing risk of death. And when expressing this in numbers, there was a 2.5-year cumulative incidence of 12%. The lower figure shows the cumulative incidence for major bleeding. And also when applying this in numbers, there is a 2.5-year cumulative incidence of 16%. The table on the right presents the predictors for VTE and mortality. And as you can see, a higher age, a higher ECOG stadium, so performance score, and biopsy over resection are all associated with a higher risk of VTE and also a higher risk of mortality. When a patient has a VTE and is treated with an anticoagulant, there is also a higher risk of major bleeding. And both VTE and major bleeding are associated with a high mortality. In concluding, there's a high risk of VTE, a high risk of major bleeding, and when a patient is treated with an anticoagulant for their VTE, this increases the risk of major bleeding. And that poses a very difficult question, because what is then the optimal thromboprophylactic strategy? Thromboprophylactic strategy and VTE treatment strategy in those glioblastoma patients. If this presentation has drawn your attention, I encourage you to visit the e-poster, and I look forward to discussing this very difficult but yet important question. Thank you.
Thank you.
Would you suggest to consider systematic pharmacological prophylaxis in patients who are not be operated on?
Yeah, that's a very good question. Based on these results, first go back, about half of the major bleedings were during the operation period and half were non-operative. And based on these results and also based on the fatality of the major bleeding, because when, especially in the absolute numbers, there were 12 cases of major bleeding which were fatal, and the venous thromboembolism, there was 3. So it's a 4-time increase of fatal major bleeding compared to VTE. So it's a quite difficult balance, but in the conclusion we suggest, in accordance to the ISDH guideline, to not give thromboprophylaxis for all patients.
Okay.
Yeah.
Okay.
I do have a question as well, actually. I was very impressed by your numbers. So 967 patients, that's a huge number of glioblastoma patients. So in your predictors, you mentioned that type of surgery or you looked into that variable. Were there any patients who did receive antibody treatment, targeted treatment, monoclonal antibodies? Sometimes these patients will receive that type of treatment, which may be associated with an increased risk of VTE.
Yeah, not that I'm aware of. They usually got a biopsy or a resection, and then were treated with radiotherapy and chemotherapy.
Okay.
Yeah, most of them. Yeah.
Good. Thank you.
Yeah. Okay.
Thank you.
Thank
So
you.
much.
Now the next speaker is Dr. Schenker from Bern.
Hello. My name is Carla Schenker, and I'm from the University Hospital of Bern in Switzerland. And let me tell you something about bleeding risk in elderly patients. So the study aim was to examine the proportion of elderly patients who would have been excluded from landmark VTE treatment trials, and to compare the risk of bleeding of patients who would have been enrolled in landmark VTE treatment trials and excluded. So we have a prospective multicenter cohort of 991 patients in Switzerland, aged 65 years or older with acute symptomatic VTE. What we did is we selected 12 randomized controlled trials, 6 out of the 2008 edition of the American College of Chest Physician Guidelines, and 6 guidelines out of the 2016 edition. Why 2 editions? Because 2008 would represent the VKA era, and 2016 the DOAC era. In a first step, we abstracted the trial-specific exclusion criteria, and on the table on the right, in the first column, you see the median number of exclusion criteria abstracted from the 6 VKA randomized controlled trials were 4.5. Out of the 6 DOAC areas, 13.5. So much more exclusion criteria in the DOAC trials than VKA trials. And consequently, more excluded patients on the right side of the column. Overall, in all 12 randomized controlled trials, there would have been 44% of our 991 patients who wouldn't have been eligible for any of the trials. That's the median. We took all of these exclusion criteria and did 5 major trial exclusion groups: hemodynamic instability, high risk of bleeding, comorbidity, co-medication, and invasive treatment. If you would like to see which one of these exclusion criteria has the highest bleeding risk, please come to the poster. What we did is we calculated if a patient presented 1 or 2 or 3 or more of these 5 exclusion criteria groups I showed before, and the subhazard ratio for major bleeding, clinically relevant bleeding. And what we saw is if a patient presented 2 exclusion criteria, he had a 2-fold risk for major bleeding, a bit less for clinical relevant bleeding. If a patient presented 3 or more major trial exclusion criteria, he had even a 3-fold risk of major bleeding. So our conclusion is that due to strict eligibility criteria, older patients who carry an increased bleeding risk are often excluded from trial participation and underrepresented in landmark trials. And it poses for us the question if trial results as such can be extrapolated to our general population, which is a lot elderly, multimorbid patients. Thank you.
Thank you. This is a very interesting study. Do you think that, I mean, in the field of antithrombotic therapy, do you think that we should design randomized controlled trials specifically dedicated to fragile patients?
We were thinking about that, and we think it's important that randomized controlled trials as well as guidelines clarify for which kind of patients trials have been made. And this is not happening right now, or not visibly happening, so that they put a hint that patients who receive this kind of medication or are at higher risk for bleeding, so that there's more focus on these patients to help clinicians in their daily basis, because it's risky to do trials with these patients.
Okay, thank you. That was a very lovely answer. Thank you. The next presenter is Dr. Vinci.
Hello, my name is Alessandra Vinci. I come from Perugia, and today I'm going to introduce my study. 934 patients were included in a multi-center prospective cohort study from January 2014 to January 2020. All patients received DOACs for acute venous thromboembolism, deep vein thrombosis, or pulmonary embolism with or without deep vein thrombosis. The aim of this study is to assess the effectiveness and safety of DOACs for the treatment of patients with acute venous thromboembolism from the acute to the extended phase after 6-12 months. The study outcomes are efficacy outcome, symptomatic recurrent VTE, and safety outcome, measure bleeding in according to the ISTH criteria. For recurrent VTE, you can see that the majority of these events occurred when DOACs was stopped. The mean treatment duration was 9 months. In patients who stopped this treatment. In patients who continued this treatment with the full and the reduced dose, no difference in recurrent venous thromboembolism was observed. For bleeding events, major bleeding is one of the main reasons for stop this treatment. A slight higher risk for bleeding was observed in patients receiving DOAC in reduced dose compared to patients receiving DOAC in full dose. Maybe because these patients have a higher independent risk for bleeding related to cancer, previous major bleeding, especially if the cause was not amended, renal failure. In the last figure, you can see the cumulative incidence of recurrent VTE in according to the 4 risk categories as reported in the ESC guidelines. You can see that patients categorized as high risk and provoked have a higher risk of recurrence compared to patients categorized as intermediate or low risk. So we can conclude that DOAC have a good risk to benefit profile in the extended phase after an acute venous thromboembolism event.
Thank you very much for your lovely presentation. Dr. Vinci, thank you. Can you comment on gastrointestinal cancers and bleeding risk in your cohort?
In this study, there were more patients with cancer and more patients with gastrointestinal lesion. So these patients were the patient in those who we stopped this treatment after a major bleeding. Cancer is the most important cause to stop this treatment. But we don't have enough data about the type of DOAC now.
Thank you.
Thank you very much. Your next presentation is doing by Dr. Visser from Netherlands again.
Hello. Well, I'm not from Leiden University, but I'm from the Rotterdam University, and thank you for introducing me. On behalf of the Dutch COVID and Thrombosis Coalition, I would like to give you a little appetizer on the results of our study, which looks into the immediate effect of COVID-19 vaccination on anticoagulation control in patients that are using vitamin K antagonists. As you all know, patients that are using VKAs, their anticoagulation stability is affected by several things, such as diet, medication, but also systemic effects. And what we saw was that in COVID-19 vaccine recipients, systemic effects were reported in 50% of the cases. And that's why we wondered how COVID-19 vaccine affects anticoagulation control in patients that are using VKAs. And what we did, we included adult outpatient VKA users who received at least one Pfizer vaccine of 4 Dutch anticoagulation clinics, and we compared the most recent ENR before the COVID-19 vaccine to the ENRs after the first and after the second vaccination, and we used a conditional logistic regression to see whether or not patients had a higher odds of reaching a sub or supratherapeutic ENR after the first and second vaccination. And what we saw by using data of more than 3,000 VKA users was that after the first vaccination, 1/3 of the VKA users had an ENR out of range compared to 1/4 of the VKA users before vaccination. And we also looked at the odds of the users, and we divided the VKA users that had a standard intensity, so an ENR, a target ENR range between 2 and 3, and also high intensity, so a target ENR of 2.5 and 3.5. And what we saw was that in the group with a standard intensity, the sub and supratherapeutic, the odds of getting a sub and supratherapeutic ENR was higher after the first vaccination. And in the high intensity group, we saw that the odds of getting a supratherapeutic ENR was higher after the first, but also after the second vaccination. And if you are interested in the specific odds, please come to my poster. So to conclude, we see that the Pfizer vaccine is associated with a negative effect on anticoagulation control, and that's why we advise to monitor VKA users shortly after the COVID-19 vaccination. Thank you.
Thank you very much. These are very impressive data.
Thanks.
Do you have any explanation?
Yes, of course.
Very short response, please.
Yes. We looked at the Pfizer vaccine, so it's an mRNA vaccine, and some small studies have shown that mRNA can influence the coagulation markers. So that's maybe one side. And the other side is that VKA users could also have these systemic effects, which eventually will lead to a worsening of their anticoagulation control. But another effect could be also that is the human effect, so to say, so that maybe professionals, because they knew patients were going to receive the vaccine, that they maybe change the tablets. Or what we also heard was that some of the patients, because they were afraid of getting any bleedings, that they, without saying, took less of their tablets. So there are several explanations.
Yes. Yeah, very good. Did you consider diet? As in, when I received the vaccine, I got very ill. You know, I didn't feel like eating very healthily those days. Yeah. So, do you think that could have an impact?
Yes, of course. That's what I meant by the systemic effect.
Sure.
So,
yes.
on one hand, the illness, the fever, but also all the other factors that come from the illness as well, like having less appetite.
Mm-hmm. Thank you. That was a lovely presentation.
Yeah.
Thank you so much.
Very interesting.
And the next presenter is Dr. Vucci from Zurich.
So, thank you very much. My name is Davide Vucci, and I'm a research assistant at the University Hospital of Zurich Department of Angiology. I would like to present you the early hemodynamic effects of fixed-dose ultrasound-assisted catheter-directed thrombolysis for COVID-19-associated pulmonary embolism. So we performed an internal institutional research to see all the consecutive patients with main or lobar artery pulmonary embolism that were treated with ultrasound-assisted thrombolysis from 2018 to 2021 at our department. We identified 9 patients with COVID-19 that we have age-sex matched to 27 controls without COVID-19. All patients were treated with fixed low-dose USAT protocols, means alteplase 10 to 20 milligrams over 15 hours. And of course with unfractionated heparin. We measured the mean pulmonary artery pressure just before the beginning of lysis and at completion of USAT. We have also measured the NUS parameters hourly, such as respiratory rate, heart rate, systolic blood pressure, temperature, oxygen saturation, and the level of consciousness of the patients. According to the primary outcomes, we have seen a similar reduction of mean pulmonary artery pressure in the 2 groups of patients, and we have also seen an increasement of the NUS score after the beginning of USAT. According to the secondary outcomes, we have seen after the USAT start an increase of the heart rate, a reduction of the respiratory rate, and an improvement of the oxygen saturation. Besides, the clinical events were very low in both groups. We have only seen 1 death in the COVID-19 patients, and no major bleedings were seen. thank you very much for your attention, and I am glad to answer your questions now and also at the poster presentation afterwards. Thank you very much.
Thank you very much. In our experience, most of the COVID patients referred for pulmonary embolism had thrombus distally located, and we had very few patients with proximal thrombus that could have been treated with CDT. Do you have any comment on this? Do you have a lot of patients with COVID disease, acute PE and proximal thrombus?
So we, our cohort of patients, okay, Switzerland, we are 8 million inhabitants in Switzerland, it's not that much, but our cohort of patients were patients principally with a central pulmonary embolism, and most of them were bilateral. So in our cohort, most of patients had central, so this is what I can say.
These are reassuring data, aren't they?
Sorry?
These are reassuring data. Reassuring as in they are, I don't have another word for reassuring, but but it's good to see, isn't it?
Yes, it's good to see, yes. And I mean, we didn't expect something else. I mean, we wanted to see if there are some new things that we can say in the COVID-19 groups of patients, but at the end we saw that there's a similar reduction, and this is what we expected, yes.
Yes, very good. Thank you so much for your presentation. Thank you.
Thank you all, and thank you to all presenters for the high quality of this abstract session.
Okay, and thanks. Yeah, and it's finished. You are done. So thank you, chairs, both chairs. So now we have a break, and we have a break until 15:30. I hope this is correct. If not, there will be an alarm all over the hotel to get you early on. And there is this possibility what Stavros informed you on. Nu, the posters. Sorry, now the poster presentation. Poster presentation is starting now. Excuse me so much. Yeah, so please go to the posters and discuss with the poster presenters. Okay, thank you.
hear me now? I think so. Doesn't work?
You have to speak close to the phone
Ah.
so that they can also put the streaming.
Of course. Now you can hear me. Okay, very good. From those in the room, I have a very quick question. Who attended the workshop yesterday already? Okay, well, half. Okay, very good. So this is a very brief introduction into Cathy and what Cathy is doing. Cathy is basically a Germany-based, privately held simulation technology company that is dealing with simulation technology since more than 20 years. And one of our specialities is the right heart catheterization that we are going to demonstrate to you. And basically the idea is to give you the opportunity to play around a bit, which is probably of most interest for you. Before I will give you a very, very quick overview on which kinds of simulators we do have. And my name is Manuela Werner. I'm the person who is responsible for marketing and sales. And Catherine Höfer, she is our technical expert. She is working then with you afterwards on the simulator. All right, so we do simulation. And we do have several simulators. Basically, this is our standard simulator, the Catheter 3, the long tube that you see here, which you can use basically for all kinds of simulation in the endovascular area, from the head to the toe. It provides the opportunity to use 3 instruments simultaneously in parallel, independent from each other. So this is basically our standard tool. But we also do have a little one. This is our Catheter Smart, which provides the same features, so you can do any intervention, any procedure with it. You just have the limitation that you can use just one instrument at a time. Yeah, and when we talk about right heart catheterization, it's rather the Catheter Smart that we use for this application. So this is basically the one that you are going to play around with. I think this is already the last slide. This is just to show you that we usually work with control units and that we are able to work biplane and monoplane. I don't know if this is of relevance for you, but for many, many experts it is, so we used to mention that one. I have a quick question. Who of you has been working with simulation before? Okay, this is clear. Nobody so far. Okay, interesting. Good to know. We consider it actually as a hopefully in future mandatory application in the curriculars, because
it's not yet very widely applied.
Yeah.
In America, it is more widely.
Yeah. In other
we also have simulations for, let's say, PCI or for interventions.
all kinds, neuroradiology, cardiology, whatever you mention. I can provide a list of all procedures to you, and you can, of course, share that. It's also, by the way, common in the Middle East and also in Asia. It's a part of the curricula, a mandatory part. So we are kind of more behind in Europe, I would say. The last thing I would like to ask you before you can then try yourself at the simulator, we are a bit curious to understand how you perceive and how you consider what we are doing with our simulator, and therefore we have created this form, and it would be really nice if you could fill it out and help us to improve what we are showing and to give us your feedback from your side. So please take the sheet, fill it out afterwards, and yeah.
Would it be possible also to leave some sheets? So some colleagues will definitely come, let's say, now in a couple of minutes.
Mm-hmm.
But some colleagues, of course, will also, or all of the remaining colleagues will attend the workshop tomorrow.
Yeah.
Should we leave some for them
Yes.
also for tomorrow,
Yeah.
right? For
Yes.
evaluation. So that
Yeah, we will print out some more. That's not a problem. We can do that.
That's
here.
perfect. Yes,
Yeah,
that
we
would
have
be
enough.
better. So then that you will have from many colleagues. So
Exactly.
they're impressive.
Perfect. Thank you. Okay. Good. I will take a few photos once you are playing around. If somebody is not okay with being on a photo, please show me or let me know. Okay? Good. Then I would propose, let's get started. Try around and ask your questions. And yeah.
the syringe at 2.5. You put the syringe like this.
It's a simulator.
Ah, okay.
A lot of
Okay,
time.
this is
Normally, of course, you
Okay.
check if it's
Okay.
going up.
And yeah, what I do usually is to freeze in water, just to understand. It's very, very uncommon, but you know, there are no bubbles, and it's the correct one. This is just to stop, if you inflate...
It's not important because you also have the stop here, right? I mean, so
Yes, it's red. Usually it's red. Usually red. So after you stop, and the balloon remain inflated, if you want to deflate the balloon, you have just to do like this, and the syringe by itself will do like this usually. If you want, you can. Okay. Let me check this one.
Yeah, it's always a red one.
Yes.
Yeah, so
That's
it's
the
also
stop.
it's not working.
Okay.
Yeah,
This
but
is to
it's
inflate.
always a red one.
Okay, but it's not inflating. Does it work?
No, it's not working as well. We have always it's a
I think we can
demonstration.
start
Yeah.
inserting so that
Yeah.
people will see
Okay.
the demo.
Okay.
Yeah.
Come on.
Yes.
Let's start inserting.
Okay.
And these other two is one is connected to with the end of the probe. So if you inject water here, the water exits from here. And if you connect this one with the line, this part, this tip of the catheter, is able to collect the waves. Okay. This other, this usually is blue, is another line when you inject cold saline. Consider that catheter is like this, so the water came out in right atrium. There's tricuspid valve here, pulmonary valve here. Inject in right atrium, and there's a thermistor, that's something in the tip that collects the difference in temperature. You inject cold saline, the blood temperature is 37, the cold saline is in the fridge, is 10. So this is able to have a curve that describes the difference of temperature, blood and cold saline. So
Now we are femoral. We just changed insertion point. So the head is here.
Jugular vein yesterday, so today we're femoral.
I can change it, yeah. And you have X-ray here. It's on your foot pedal. When you press, you see the sign. This is the femoral.
We see it there.
Yeah. Okay. So, and you can go in saturation. If you need saturation on any situation, you can take saturation.
This is quite basic information.
This is the balloon.
So put probe inside. When you put this part, the introducer, how can you understand if you are in the vein or in artery? Looking at the wire. You will see that the wire is pulsing. Of course, if there's some pulsatility of blood, but looking at the fluoroscopy, if came out on right is vein, if came out on left is artery. Okay, usually. Okay.
But there's also an easy trick. So before you insert the catheter, you open this thing,
Yes.
and if it goes like this, then you know you're in the wrong place.
No, but before putting this one,
Yes.
when you put the wire, you have the needle, you have this one,
Yes,
it's an
right,
18
when you
needle.
put the wire.
You put the wire inside, it wire go like this, you are in artery. So don't put the introducer. If like this one, you are in right side. Okay.
Okay. So I'm inside now. I will inflate the balloon.
No, don't inflate because there's no need, at least at the beginning, because if you inflate the balloon into the introducer, you're unable to push.
Balloon is of course in the catheter,
Now
so
you
now
can
you can inflate.
now you can inflate.
You can inflate this one, because this one is not
Yes.
kaput, but you can see now the balloon. You should see it, right?
Okay.
Pressing X-ray, then you can see it. I'm your table. Normally we have a control panel.
You are now, you should be now in right atrium. If you want, when you are at the liver level, that is over there, you have to rotate a little bit the catheter, just to avoid that going so
If you want
hepatic.
to show something, you can use.
At
I
this
can
level,
make the
okay,
light a
you
little
have
bit
to
darker.
rotate the catheter in this side, but if you go in so hepatic, nothing happens, no problem, okay? ventricle, you are in right ventricle?
Yes, just push. Catheter means keep pushing.
Okay, this is a good loop because the tricuspid is here. You are coming. You have to achieve this. This is the ideal hole to go in there. You are in the ventricle now. Let's give the core. Let's give a look to the core. Okay. If you push again, there are two possibilities because you can go direct. You can go directly from here to here. In this case, for example, if you find very difficult to do this loop, you can also help with a wire. Because the catheter should be used over the wire. You put a wire that is very, very smooth. And you can also try to do this loop or try to go directly from here to here. Okay, this is better to use, for example, if a patient has some pacemaker or defibrillator and some leads into the heart. The first is, primum non nocere. The first, don't damage the patient, so don't move the catheter. In that case, we prefer jugular approach. If you go from femoral, be very, very careful. It's better to advance the wire and to advance the catheter over the wire, just to avoid to do something. Okay.
Do you like this right ventricular pressure, Lucas? It's quite high, right?
It's quite high, yeah.
Does anyone know who first measured pulmonary artery pressure in men and diagnosed pulmonary hypertension? Henri Cournant in 1937, he got the Nobel Prize for this. So he measured 80 to 90 millimeters mercury pulmonary pressure.
I think that Stefano is very tall. I have to move a little. It's not Stefano, it's him. Okay.
Oh, that's
I don't know, Stefano, that's your fault. Okay. Note the difference. Pull back the catheter into the ventricle. In this case, the diastolic pressure is 40. This is impossible. There are two reasons to understand that this is a pulmonary artery and not right ventricle. First of all, of course, fluoroscopy. But the most important that the diastolic pressure is very high. This should not be a ventricular pressure. And the second, that there is a diastole that is a little bit more low. Yes.
The closure of the pulmonic valve, right?
Okay,
you want to explain it better, then I can give you, you want it that way, or you want to explain it more this, or you want to explain it this?
Okay, like this.
Like this?
Okay.
Yeah, okay, you want...
Now there are two possibilities to, in this case, for example, you exclude that as pulmonary stenosis because the pressure in the right ventricle and the pulmonary artery, the systolic pressure are more or less the same. So there's no gradient, no difference between the two chambers, okay? Now, if you push the balloon, usually you wedge in the right artery, in right pulmonary artery, in some branches. Push till the catheter stops.
Until the waves change.
Let's give a look. The wedge pressure, okay, it's here. It's very low. It's much lower than diastolic, so it's okay. Okay. What I do at this time is to deflate a little bit the balloon and inflate gently again. If you deflate the balloon, in this case, it should appear again the pulmonary artery pressure. Can we deflate, Catherine?
Yeah, this is your balloon, and you can play with the balloon.
Okay, deflate the balloon. And despite you are still here, it will appear usually the pulmonary pressure. This means that whatever you are, we are still the wedge pressure here. Balloon is not deflating. Okay. Okay. So if you measure, consider that here is the pulmonary valve. If you measure here or here or here or here, the pressure is always the same. Okay. So if you are not satisfied with the wedge pressure because the pulmonary branch is very big and the balloon is unable to stop the retrograde flow, in this case, you have to deflate the balloon, advance the catheter a little bit, and after gently inflate the balloon again. Don't watch the balloon, watch just the trace. When the trace drops, you have to stop inflating, okay?
Do you have the feeling that
yeah.
the diameter, the maximum diameter has been
Actually, no, but the only thing that you have to rely is the trace. When the trace, try to inflate the balloon again.
Michele, as you said, as soon as the trace goes down, so actually you do not need the fluoroscopy. If you're in intensive care, you do not do it with You just guide, you just let, that's the whole idea of this, otherwise it would be a normal catheter. You just like, and it's important not to overinflate because you may have wrong pressures and of course you may burst some arteries and then you will have hemoptysis, especially on rheosipua, as Lucas knows. So that's not
and please never pull back the catheter if you have the wedge pressure trace, because you can strip the artery, okay? Deflate, when the pulmonary trace appears, you can do everything. Okay, have you got a simulation for showing over wedge?
Yeah, shall I make it directly now?
Yes.
Or, okay.
If you inflate
when you retrieve the balloon, the catheter, of course, always deflate, right? Because otherwise you would make the pulmonary valve go down. So if you have to deflate, always pulmonary. So always forward with full balloon and
backwards
without.
Okay. So I made an over wedge.
Yes.
But a bad trace, right? No real waves. So Dr. Hobum, Andrew just fragmented a thrombus, a huge thrombus in the pulmonary artery, and he just, went back and forth, and now the thrombus is gone.
Of course, yeah, the patient too, but I think my radiation time is quite better.
Can we please just shift for one moment with my presentation? I will show the reason why an overwedge is... Okay, this is the ideal condition. We inflate the balloon, and this is the tip of the catheter that measures the pressure that is in left atrium, that is the telediastolic left ventricular pressure. If you inflate a little less than you want the balloon, this is not a good trace. Please, the person that is here with this shadow. Okay, it's Stavros, probably. Okay, if you inflate too much the balloon, this is what's happened. Because in this case, you inflate too much the balloon, so your transducer is not free, but measures the pressure into the balloon. So this is not reliable, because should be at least the same or probably lower, like in that position, compared to the diastolic pressure. And in this case, you inflate too much and you have pushed too much. So you are measuring the pressure in the vessel more. This does matter. This is not what you want to achieve. Okay, let's shift again on the presentation, on the simulation.
Go back to the
simulation. Okay.
Overwedge since 10 minutes.
And of course, overwedge or normally wedge, of course, and you never leave a wedge catheter and go for coffee or show slides, right? You
So to have a coffee, okay.
Except of the spring school, of course. Except of the spring school.
Yeah, except for the spring school, but otherwise it's not a very good idea because then the something reds come.
Okay. Now I'm deflating.
Deflate the balloon. So in this case, if you are in overwedge, you have just to deflate a little bit. And the traces of the wedge pressure, I will explain what are the traces of the wedge pressure, because it seems messy, but each wave has a meaning.
And you should move now the catheter, or you
now
just
you
inflate?
can move. Now you can move, because the catheter is sufficiently deflated, because you have the pulmonary pressure. Let me show the different parts of the wedge pressure. That is very interesting. Okay, if you can shift again on presentation, please. Okay, this is what you want to achieve. You inflate the balloon here, so with the transducer, you measure this pressure, that is left atrial pressure, and this pressure, that is left ventricular and diastolic pressure. Otherwise, why we want the wedge pressure? Because we want to know if there's a problem in the left ventricle. So if the left ventricular and diastolic pressure is high, So these are the waves, and it's very complex. It seems to be very complex. Okay, there's this. What are these waves? This is the. Can we move this peak? Because okay, I'll do like this one. Okay, this is the this is a systole and this is diastole. Okay, the first wave is the epsilon wave starting from here. This is the passive left atrial emptying. So imagine that this is the pressure on the left atrium. So in this case, the mitral valve is opening. Okay, so there's an emptying, passive emptying of left atrium, so the pressure drop. And this is the second part of diastole, that is atrial contraction. Okay, the pressure increase into the left atrium because there's a contraction of the atrium. So at the beginning there's the passive empty, and here is the contraction of the atrium. So despite the mitral valve is opening, the pressure in the left atrium increase. Here is the end of the diastole and the starting of the systole. There's a contraction of the ventricle. You know, at the beginning there's isovolumic contraction because the left ventricle contracts, the mitral valve closes, but there's no flow anywhere. So there's just isovolumic contraction. And the pressure a little bit increase, and this is the C, and the closure of the mitral valve. After this wave, this negative wave, is X wave, because the annulus stretch down. When the ventricle contracts, do like this. Okay, contract and stretch down the valve. So despite this contracting, the pressure in the left atrium is reducing because they're stretching down the annulus. And after the pressure increases, and this is the V wave during the contraction. So what's happened in this case? That if you consider these different phases, the only moment where there is the column of blood that is the same in the atrium and ventricle is here at the end of diastole, because no flow, no contraction, nothing. This is the ideal point for measuring the wedge. It's quite complex doing this, you know. So what's happened that usually the machine gives you the mean pulmonary pressure. It traces like this. This value is similar to this point. It's 1 millimeter of mercury difference. It's acceptable. But what's happened, if you, for example, have a mitral valve regurgitation, an important mitral valve regurgitation, or have a stiffer left ventricle, the V wave increase. So that's the reason why the mean pulmonary pressure measured from the machine, for the wedge pressure, I mean, is a little bit higher, so the diastolic gradient should be negative. In this case, you should cut the V wave and consider just this point. You know, it's very difficult, but what I recommend to you is print the trace and measure exactly this point that is between A and C. It's not so easy to identify. Something like this, I will show you. Okay. This patient. This patient has a moderate mitral valve insufficiency, and this is the V wave. If this patient has no mitral valve insufficiency, this V wave will be a little bit small, like this. Okay.
So it gives you information on the mitral valve. And if you could show the normal flow that we have, Michele, because that's also important. So normally and counterintuitively, the main wave that you see downward. Do we have the one that we are seeing here? I don't know. Can we show, being hands-on?
I will also show some other. I'm here.
In order to show also a little bit, because Mrs. Werner wants to have the hands-on. So to see what Lucas is seeing right now, if I may show this one, because we can show it also. No, I wanted to show nicely that the wave that you showed.
Yeah.
Can we have the original wave that we are recording now? Can we have that screen? Maybe in order to not make
you mean
it
this one?
lecture, but make it a little bit. Yeah, I wanted to make it more hands-on. But so normally the prominent wave is not the wave of the late diastole when the valve opens, it's the wave of the early, it's this wave of systole, because this is when the ventricle comes down. And it's essentially the same curve that you get in the right atrium, right? That's the same curve. It's very
Absolutely,
similar.
absolutely.
So when we talk of filling pressures, they are quite similar. So now we have, and if you go now to the, let's say, the real simulated pressure, yeah. Could we have another scale? Because it's also always important not to have the 1 eye scale. 50. It's not a very good sign, right? Looks a little bit.
Should I deflate again?
Can we have a higher velocity, 100 per minute?
That done?
Not so good, right?
Yeah.
Not so.
It's
Yeah.
a bit sharp. Yeah.
Excuse me? Yes, that should go down now. So, okay, so it's a little bit, because what happens is, so this is, can we freeze it? Is it 100, right?
Yeah, yeah.
Can we freeze it?
100, it's
not
not 100,
160.
no,
Please
it's
give
100.
Give another scale. Please
Yeah.
give us 40 or 60 scale.
50,
or something. Yeah, that's good.
And stop.
And stop. So if this is, so look, this is the, right? So this is the systole, and the V wave of the systole, oops, oh. So the V wave of the systole is this one, right? It's exactly after, or at, or immediately after the ST segment. Agree, Michele? So
Yeah,
this is the V wave. So if you do not want, you always need an EKG to see what waves you have. So this is the X wave. So this is the late, the late systolic. So the systolic downward wave. That's the one that Michele was explaining. That's actually the most prominent because the whole ventricle sucks the blood. And then, although the valve is closed, and then that is the epsilon, the Y curve, because this
and
is...
in this point should be measured the wedge pressure. There's this notch.
Yes.
That is here, okay? That is more or less...
so this is the A, and this is the C, to put it like that.
And this is also... If you can switch again on the presentation. Let me show. This is an example with fluid loading. This is the... Okay, but let me show. This is a recommendation from the guidelines. Okay, in sinus rhythm, average A wave, because the A and C wave are more or less the same. There's just that notch that I showed you. In sinus rhythm, in atrial fibrillation, measure the pressure 130, 160 milliseconds after the onset of QRS, before the V wave. Okay, that's the point that Stavros showed you. Okay, that's very important. Yes. And after, just to show you what does this is the transition from right ventricle and pulmonary artery. Let's show you a false wedge pressure. This is a very slow velocity. This is pulmonary artery. This is in real right heart catheterization. This is the false wedge pressure, okay? Because this is with the balloon not completely inflated. It's like this, okay? So this is intermediate between the real wedge pressure and the pulmonary artery, okay? So in this case, what I did is just for educational purposes, was to inflate a little bit the balloon, and this is a false wedge pressure. Let's give a look. If you consider this wedge pressure, the patient should have about 30 of wedge pressure. So it's important post-capillary pulmonary also the morphology of the fluid that is very similar to the ideal morphology threshold. You have to inflate a little bit more the balloon to have the true wedge pressure. Okay. So don't forget that this value is the DPG, the diastolic pulmonary pressure minus the wedge pressure, and this expresses the vasculopathy. Higher is the value because the normal is between 0 and 4. 7 is between 4 and 7 is gray area, gray zone is borderline. More than 7, you have vasculopathy. Okay, but this is the TPG, the mean pulmonary pressure minus the wedge pressure, and the TPG divided by flow reflect the resistances. Okay, so this interval reflects the importance of the vasculopathy, and this is important to measuring the wedge pressure, to measure the resistance, because the resistance is the mean pulmonary pressure minus wedge pressure divided by flow. The resistance is the difference of pressure divided by flow.
So the pressure that was consumed to push the blood through the capillaries divided by the flow. So S is the V to I ratio, right? Also in the electricity and also in hemodynamics. We have T minus 3 minutes. I must remind everyone.
I don't know if we want to shift again or
maybe
we have some questions.
We can show, Lucas, maybe we can do a brief hands-on again, because I see that not all colleagues have come. But
somebody else? Or?
Yeah, if someone wants. Lucas, do you want to do something?
Do we know what the patient has already?
No, we don't know. We don't
Okay,
care.
no.
Now we just want to push the catheter.
Okay.
We'll do that in the workshop.
Okay. Another one.
So I think we can give 5 more minutes, right? Because not everyone has arrived, so we will give it until 3:35 p.m. So.
Can the patient die?
Oh yes.
Yes. Yeah. Especially when 100 people around you, then it's not normal.
I used to work on a pseudo-simulator 25 years ago, where you could
preparation,
really
which pressure, then, but only in small
doing
groups.
something on the patient,
Okay.
and then there was a skull that appeared and said, you were totally wrong. Yeah, really, that was not a joke. You killed the patient.
Yes, on the next, calibration.
Yeah.
We had the perfect zero calibration. I'm not sure if your colleague done it before.
How do you calculate?
So, what's the
Yesterday we spent lots of time for tell which is the ideal point to zeroing the system. That is mid-thoracic level. Of course, this is very, very important because if you zeroing the system on the table of hemodynamics on the chest of the patient, you can do a very big mistakes. So be careful between zeroing the system is the first step before starting right heart cath.
Normally you do it with your right. You press. I give you right my table.
Nice. So we are already destroying the kidneys.
Go back and rotate to the catheter. That's good.
It's okay.
You were
might
in
remain
the
sufficient.
right kidney vein.
It's okay.
No
We'll do just a create balloon. Yes. Now.
This is your balloon.
Nice. So I can.
The balloon
but I
should be non-traumatic. So it's much better.
It should not be traumatic.
Not be traumatic.
So.
Traumatic.
That's it. But should I inflate it completely now at this stage?
Yes. Completely or half.
It's only when going backwards that you should be careful.
Like this.
And that's closed. No. And then we go.
Push the catheter.
And we have the lever at some point.
You can go also a little bit quickly. Follow the cut. Okay. Should be rotated. Okay.
Should I rotate now or is it? No, it's good.
Okay.
Wow.
You should rotate like this. Okay, perfect. So the tip of the cutter should be there.
This is too low.
No. Pull back and now.
Yes.
Okay, that's great. Perfect.
So we're going all the wrong ways, but then...
Yes. Consider that here is tricuspid valve, from here to here.
Yeah, so we went...
And here is the pulmonary valve.
Now we can't go wrong. I don't
You
remember
are, yes,
there
you are
anything
now
other.
in the pulmonary valve. You have just to push to go in wedge position. Push the catheter.
In real life, you do it more slowly than I'm doing now, right?
Yes,
Yeah.
but when the catheter stops, let's give a
Okay.
look with the one eye, you look the catheter, with the other eye, you look the monitor.
So, we're on the pulmonary artery. Are we there? We are probably...
Again.
I push.
Never mind. That's great.
That is resistance.
Oh,
God. So we are there, and now I should...
You can now, if you don't like this curve, or anyway, if we want to check, can we check again?
Yeah.
Deflate the balloon.
Yes. But you should always keep this with your...
Yes, no, the probe doesn't move. Now you can also leave the probe here, deflate the balloon, push a little bit more, and inflate again very
Afterwards.
gently.
But I'm waiting for... Oh, why does it inflate back?
We deflate the balloon.
Yep.
Turn the valve. Yeah.
This is the valve.
Yeah, of course, it was still closed. Very good. Oops.
Okay.
Inflated.
Push a little bit the catheter, and now start inflating again very, very gently.
As I
forget
advance.
of the catheter.
Yeah.
Okay. Give just a look to it.
Yeah. So this is...
This is your wedge pressure with big waves.
I
This
am
is the AC. This is the
Ideal
point
point
where the
of
ideal
measurement.
point of measuring the wedge, that should be 22, more or less. Okay?
So shouldn't
And
I
this is
inflate
the
more?
giant V wave that should be due to mitral valve regurgitation, to stiffness of the left ventricle, and so on.
But shouldn't I inflate more?
So in this case, this is a post-capillary because it's 22, 23. Okay? This is 21, but this is the mean value, but you have to avoid this one. That's the point.
Yeah.
How we are not sure that we have not inflated the balloon enough, like you saw that.
Because if you inflate the balloon too much, the pressure rise and is much higher than the diastolic pressure. We don't have the wave for it, right? Exactly. So it's not realistic. Okay, because by definition, it's like the flow of the water. It's impossible that water comes from the low to the top.
How long can you?
Yes.
Well,
so it's post-capillary.
Yeah. This is if it's not the full sweat pressure, then it's...
How long can you leave the balloon inflated?
I
Just not more than 1 to 2 minutes.
Very nice. So, how much will it cost?
Now deflate the balloon. Save the patient.
The patient.
Yeah.
The patient there is some
So
cough.
hemoptysis.
I don't know why.
We can close it.
I take care.
Thank you.
Thank you very much. So
I take care for his
So we can go back to the normal screen. So for all of you who were not with us, and if you, of course, we have tomorrow the normal workshop, right, with the right heart catheterization. I really urge you to have an idea. If you don't have to become a cardiologist or interventional cardiologist. It's always good to see, to know what you are talking about when you are publishing some, even for radiologists, right? I mean, and vice versa, of course. You cannot talk about right left ventricular ratio and not know the radiological findings. So this is also something. I think it's very important, and yeah. So I will give over immediately to our chairs for the abstract session. The same rules apply as in all the previous sessions. The only housekeeping thing I would like to remind everyone is that we will then have the workshop session 8. Right, we will have the workshop session, we will have the workshop session 7 here and 8 over. Excuse me. I'm saying it correctly again because I said it this before the lunch break. So, the session 8, which is the radiological session, and which will be done by Lilian together with Michael Sproule, must be done here again because this is where we can stream from and where he can participate. So. That's the only case in which Lillian and Michael will stay here, so the colleagues that were over there will come here. And of course, the colleagues who want to go to the session 7 will go over to the Apollo, to the other room. In all other cases, you as participants will stay where you were in the room, and we will come to you and change. Lillian, is that correct now? It is, right? Okay, thank you. Because the next workshop sessions will go without a break now. So the break and the visiting of the posters will take place a little later, right after the sessions as well.
So the micro is working? Yeah, it's working. Is it working? Yes. Okay. Okay, good afternoon, everybody. Welcome to this abstract session 4. I have to say I have the impression to be in the cath lab, but okay, this is fine. So our first speaker will be Dr. Brahms from the Netherlands. And the title of its abstract is Exercise Intolerance After Pulmonary Endarterectomy for Chronic Thromboembolic Pulmonary Hypertension is not explained by impaired right ventricular function. The floor is yours.
Thank you.
So that's a perfect example for right heart cath.
Yes, indeed. So you had the practice, so now I will tell you something about pulmonary hypertension.
Can we change?
Yeah, so what is this? Yes, so hello, my name is Natalia Brahms. I'm from the Amsterdam University Medical Center. And today I would like to discuss with you a recently finished trial about right ventricular function during exercise and then after the pulmonary end arteriectomy for CTEPH, the chronic thromboembolic pulmonary hypertension. So we all know that pulmonary end arteriectomy, that's the surgery for CTEPH, improves resting hemodynamics and also RV function in rest. However, we also know that exercise intolerance is frequently present after surgery, even if the pulmonary pressures have normalized. So therefore we aim to investigate whether exercise intolerance after surgery for CTEPH coincides with an altered RV response to exercise. So we performed a prospective study where we included 19 patients diagnosed with CTEPH, and we had several measurements performed before the surgery and also 6 months after the surgery. So on the first day when the patients came, they had a maximal cardiopulmonary exercise test. We performed that to define exercise intolerance. So exercise intolerance was defined as a peak VO2 of less than 80% of predicted. And then patients with exercise tolerance were patients with a peak VO2 of more than 80% of predicted. So we had 2 groups, so we could compare it then. And then the next day, patients had a submaximal invasive cardiopulmonary exercise test at 40% of the maximum load what they cycled 1 day earlier. And during that test, we could measure, we measured the rest and also the exercise measurements. And then we measured the mean pulmonary artery pressure at rest and during exercise. We measured the cardiac output by the direct VIII method. And with that together, we could measure the slope, the mean pulp cardiac output slope. But we were interested particularly in this RV response. So that's why we also looked at the RV arterial coupling by measuring the EES, the end systolic elastance, and also the arterial elastance. And then we could calculate the coupling and see what happens with the RV function during exercise, independent of the load. So we found similar rest to exercise responses in the pulmonary pressures and also in the RV function in both patients with and without exercise intolerance after surgery. So I will guide you through these figures because they are a little bit complicated. So if you look to figure A, there you see the rest to exercise slope in mean pulp to cardiac output. So on the y-axis you see the mean pulmonary artery pressure, and on the x-axis you see the cardiac output. And then in green you see the patients before surgery, these ones. And then we have the rest measurement, and here is the exercise measurement. And these lines are the patients after surgery. And then in red we have the patients who have exercise intolerance after surgery. And in the blue line, the patients without exercise intolerance after surgery. And as you can see, surgery did something, because the mean pop is here around 45 millimeters of mercury in rest. And after surgery, it's in most patients, it's below 25 millimeters of mercury. But what you can appreciate from this graph is that this slope is quite steep before surgery, but after surgery it's similar in steepness, and we did not find the differences between patients with and without exercise intolerance. However, as I told you before, we were particularly interested in the RV function. So if you look to figure B, we have the RV contractility on the y-axis and RV afterload on the x-axis, and there we found the same results, that the slopes before and after surgery were similar. So therefore we can conclude that incomplete recovery of RV function does not explain exercise intolerance after PEA. Thank you.
Thank you for the nice presentation. Just one question. Do you have other hypotheses if it's not the right ventricular function?
Yeah, that's a very good response. We know that the VO2, the peak VO2, is defined by your cardiovascular status, your ventilatory status, but also the muscles. And there is a recent article in circulation of Howden from this year. And they looked to the O2 the diffusion, and they found that in the microvasculature that the diffusion of the O2 to the mitochondria is disturbed. So we think that that's the problem why patients have exercise intolerance.
Okay, thank you so much.
Yes.
The next speaker is Dr. Chen from Leiden University Medical Center, the Netherlands. With abstract title, Heart Failure and Subsequent Thrombotic Complications in a Population with Low Baseline Risk of Thromboembolism, a nationwide cohort study. Please.
Okay, thanks for the introduction. And my name is Qin Gui. I'm from Leiden University Medical Center, and I'm from the clinical epidemiology. So my main research in direction actually is about, we try to use some real-world data and try to provide some evidence or insight in the field of, of course, including thrombosis. And frankly speaking, my research direction is more about stroke. So maybe the finding today is not that very interesting for VTE. So my talk is about heart failure and the subsequent thrombotic complication. And we focus on a population with low baseline risk of thrombotic embolism. And so we use data from the Statistics Netherlands. So it's like a national registry for data from different various data sources. And we included all the adult Dutch inhabitants who are defined, we define them as low baseline risk of thromboembolism. So we used, they didn't have heart failure, atrial fibrillation, valvular heart disease, ischemic stroke, of course, VTE, myocardial infarction, in the at least within 5 years prior to the first day of 2019. And we also exclude patients, inhabitants who have been prescribed with anti-thrombotic agents within half a year before the index date of January 1st, 2019. And so in this, the study design we used here is a cohort study design, and developing heart failure is considered as a time-varying exposure, and then we study this exposure and with several outcomes, and as presented in the right of the slides, compare with people without developing heart failure. If you developing heart failure, then for stroke or arterial thromboembolism, the risk increased by more than 30%, and for VTE, it's about 90%. And I think it's what's right to mention about some clinical background about this for heart failure patient with sinus rhythm, so without atrial fibrillation. It's controversial whether this patient should receive routine antithrombotic agent for ischemic stroke, but for VT actually it's clear that they should, unless contraindicated or they're already on anticoagulation, otherwise they should receive prevention, VT prevention. So as I say, so actually the main background is about stroke here. But actually here is only the very initial result of the whole study. At the moment we're submitting the abstract, and more important, in the following study we will try to identify which patient group are more at high risk of developing stroke. So that's the main finding about study. Thanks. Thanks for your attention.
Thank you very much. I see that the risk of venous thromboembolism is increased. And I was wondering, did you also have a look at PE and DVT? Could you?
Yeah, you mean whether we investigate the association in different, it's being also DVT or PE in subtype of VT. We didn't look at include the list as outcome, but I mean, according to the data we have, actually it's possible to do that. But as I explained, actually the main background, I mean, what's controversial actually is more about the ischemic stroke. So that's why we didn't especially look at that. But it's, I mean, it's a good supplement. I must say, yeah.
Yeah, I think it would be interesting if you have the opportunity to also look at DVT and PE separately. It would be interesting.
Yeah.
Yeah.
Oh, thanks.
Thank you very much.
So our next speaker is Dr. Dayat from Norway, pulmonary hemodynamics in patients with chronic thromboembolic disease at rest and during exercise.
So Suka, who's at this hospital probably, right? Sorry? Suka, who's at this hospital, right?
Yes, that's right, that's right. Thank you for your kind introduction. So the general belief over the years has been that if you survive a thromboembolic event, you get put on a blood thinner for a certain amount of time, you live through your first P, and that's it. But what's evolving right now in the recent couple of years is that we are gaining a greater understanding of the long-term sequelae after an episode with pulmonary embolism. Now we have this entity, as you can see on the right-hand side, called chronic thromboembolic disease, abbreviated to CTED, CTED, where, like CTEPH, have presence of chronic obstructive lesions in the pulmonary vascular bed, but without pulmonary hypertension. And many of these patients may or may not report symptoms at rest, but many report symptoms during exercise. So an important research question is therefore whether this is due to abnormal hemodynamic response in the pulmonary circulation during exercise. So we are therefore conducting a cross-sectional study with seated patients who are symptomatic with exercise limitation. We are identifying them from our thrombosis registry at our hospital at Sykehuset Østfold, a little place east of Norway, as you can see on the map of Norway on the left upper hand side. And these patients are undergoing advanced cardiopulmonary examinations, both invasive with exercise right heart catheterization, as you can see on the left-hand side, but also non-invasive with stress echocardiography and cardiopulmonary exercise testing. And we hope these examinations will contribute to the definition of CTED, helping to identify the main cause of exercise limitation. We started recently, and as of now, we have only examined 10 patients in this ongoing study. And the preliminary results will be presented in my e-poster presentation. So stay tuned for more. Thank you.
Thank you. Very nice investigations.
How many patients are you planning to include in the study?
At the moment, we have 40 potential candidates. 40 more. Mm.
Okay.
Thank you.
The next speaker is Dr. Dzikowska-Dydur, and the title from the University of Warsaw, Poland, and the title is 6 minutes walk test, diagnostic method of evaluating symptomatic patients after acute pulmonary embolism.
Good afternoon, everyone. My name is Mateusz Jermakow. I'm presenting this study. Instead of Dr. Dzikowska-Dydur, she couldn't come to this conference. So 6 minute walk test is something less sophisticated that we saw before, but I want to show you that this is quite useful in evaluating patients who are suspected for CTEPH. Obviously, when patients after acute pulmonary embolism present symptoms, we start with echocardiography. But we know that echocardiography is not always abnormal, even though the patient has pulmonary hypertension, because this is an exam that we do at rest. So we investigated a group of patients who had a full diagnosis and retrospectively analyzed the 6 minute walk test. And those are the results. As you can see, there is a significant difference in the distance that the patient covered between the group that has the CTEPH confirmed and CTEPH excluded. There is also a difference between the saturation level before and at the end of the exam. And of course, the percentage of desaturation. What is I think quite interesting, the heart rate was the same at rest and after the exercise in both groups, so it didn't change significantly. So 6 minute walk test is widely available, it's safe, it's costless, I would say, and it can help identify patients who have correct echocardiography, but we still want to investigate them because we suspect CTEPH. Thank you.
Thank you very much. Do you think we should perform the 6 minute walk test to every patient?
Well, I don't see any contraindications to performing 6 minute walk test. They can do this waiting for a doctor.
Okay, thank you.
Next presentation as well. Okay. A different colleague is presenting. Okay, the title is Echocardiography in the Diagnosis of Pulmonary Hypertension After Acute Pulmonary Embolism, Gold Standard or Merely Standard.
Hello, my name is Magdalena Gałecka-Nowak. I will present you this nice data because here is a question, is a gold standard or maybe it shouldn't be a standard at all? Okay, so we know that symptomatic pulmonary embolism survivors should be screened with imaging diagnosis. And the first step, due to guidelines, should be echo. And it's a standard rest echo. But, and then we can choose a patient with echocardiographic probability of pulmonary hypertension, and due to guidelines, they can be shown as high, intermediate, or low probability of pulmonary hypertension. And during our study, we took 555 patients, survivors after acute pulmonary embolism, and they were 6 months fully coagulated. And after this time, when they told us that they still have dyspnea or chest pain, so they feel functionally impaired, we, as the guidelines say, we offer them echo. As you can see that we found that 69 of them have the echocardiographic probability of pulmonary hypertension high, but only 25 of them have at least CTEPH. And as you can see, the low probability of pulmonary hypertension was much more higher level, but still 2 of them developed during time CTEPH. And the question is, if we are satisfied with, as you can see, This number is 31% of all people who develop CTEPH have intermediate and low echocardiographic probability of pulmonary hypertension. So the question is, if the echo is a good exam for the beginning, maybe we should look for something else. Maybe 6 minutes walk test, maybe some exercise tools. Because most of our patients say that they have dyspnea during exercise. So maybe it's not a gold standard. Maybe we should do something more. Thank you. Questions?
No, that was the question.
So do you think we can, in the future, combine a 6 minutes walk test and...
It's cheap.
Yeah.
It's easy to access. Maybe we should do it together, because when we think about echo, we can find, for example, heart failure, valvular disease, different reasons. But as it was shown by Mateusz, 6 minutes walk test was combined with, CTEPH in the future. So maybe both. I think that we still think about CTEPH and pulmonary embolism with less courage, I would say. We should be, more aggressive, more quickly. We should do it more quickly. If you compare, for example, CTEPH to chronic coronary disease, it's also chronic disease, and the patient come to you and tell you, I have dyspnea, I have a chest pain. Do we do for him echo, rest echo? Is it enough?
Okay, thank you so much.
Thank you.
So our next speaker is Dr. Iding from the Netherlands. Residual venous obstruction as an indicator of adverse outcomes following deep vein thrombosis.
Hello everyone, thank you for the kind introduction. I'm Aaron Iding, and I will indeed now be presenting our study on the residual venous obstruction as an indicator of clinical outcomes following deep vein thrombosis. So I'd like to start by giving a short introduction to the current management of deep vein thrombosis. So international guidelines continue to recommend that anticoagulant treatment be dichotomized for provoked deep vein thrombosis, only 3 months, while unprovoked deep vein thrombosis should get indefinite anticoagulant treatment in absence of high bleeding risk. And this is a bit in contrast with what we see in literature, that there is actually more a gradual increase in recurrence risk. And also we see in studies such as earlier this year, the VIII study by Palaretti and colleagues showed that clinicians actually in practice don't really use this dichotomy. So this motivates to find further tailored treatment, tailored duration of anticoagulant treatment. And that's why I'd like to introduce you to residual venous obstruction for those who are not known with it. So it is the persistence of obstructing material in the vein following deep vein thrombosis after several months. And it has been established as a risk factor for recurrent venous thromboembolism. And actually it is thought to indicate a hypercoagulable state, which is possibly a transient hypercoagulable state. And following the seminal paper by Prandoni in 2002, in our hospital, Maastricht University Medical Center, we introduced a management strategy based on residual venous obstruction. So this means that patients, the regular anticoagulant treatment was 3 months for patients with provoked deep vein thrombosis, 6 months for unprovoked deep vein thrombosis. But if, at the end of this regular duration, if they still had residual venous obstruction, the duration was prolonged to twice that duration. So besides evaluating our strategy, here I'd like to present an analysis of the associations we found of residual venous obstruction with the outcome. So interestingly, in these patients that had prolonged anticoagulant treatment if they had residual venous obstruction, we did not anymore find an association of residual venous obstruction with recurrent venous thromboembolism. So the question is, maybe the association is dampened because we have prolonged anticoagulation in these patients, but the design of this study does not allow to assess this. However, we did see an association with post-thrombotic syndrome assessed during the first 2 years after deep vein thrombosis with a twice increased odds ratio. And also for arterial thrombotic events, we saw a twice increased odds ratio in these patients with residual venous obstruction over a 5-year follow-up. And then finally for cancer, we did not find a significant association with residual venous obstruction. So these findings, first of all, I think might trigger clinicians to consider residual venous obstruction to identify patients for intensified post-thrombotic syndrome prevention or cardiovascular risk management. And also it triggered us to look further into what is the underlying mechanism, if hypercoagulability has a role in this, and that's what I will be presenting in my next presentation. I'd like to ask the moderators, will we ask questions now of this and the next?
Thank you for the nice presentation. So, you know, it's a little bit controversial area because some papers have shown that, there is no clear relationship with the right ventricular obstruction and the recurrence, and some others, yes. So do you think the way it's measured has an impact on that, or how did you?
Yes, that's a good question. So in our study, we defined this as the presence of 2 millimeters or more of residual, vein diameter when we compress with the ultrasound at the transversal plane. And this is the original definition made by Prandoni. But since then, there's been more and more towards the 4 millimeters, so higher cutoff. And that's because of especially a meta-analysis which showed that it would be more sensitive to recurrent venous thromboembolism in unprovoked deep vein thrombosis. So that's something to consider for us, and we can't really know if here the association is gone or if it's because of the prolonged anticoagulation. Also, the timing might be relevant. In this analysis for unprovoked, they saw 3 months was the most sensitive for recurrence, and here we did it 3 months for provoked, but 6 months for unprovoked deep vein thrombosis.
Okay, thank you.
I have a question too. You said that in those with residual vein thrombosis after the first period of anticoagulation, then you doubled the time. And then how many of those with residual had still a residual vein thrombosis after?
Yes, so we measured in most patients, and we saw that 60% still had, by our definition, residual venous obstruction. But at that point, it is not thrombotic material anymore. It will be more like scar tissue. Yes, and we did an analysis, but we did not find that at this time point it had any predictive value.
Yeah, thank you. And then we go to the next presentation with the same speaker.
Same, yeah,
then
I
just have to, yes. And that's, I need to thank you. This is there as well. Coagulation parameters in relation to residual venous obstruction and adverse outcomes following deep vein thrombosis.
Yes. So this is a sub-analysis of the previous study. So the previous study had 801 patients, and in 306 patients, they agreed to donate blood 1 month after stopping anticoagulant treatment. And in this blood, we measured in platelet-poor plasma the coagulation potential and ongoing coagulation. The coagulation potential was represented by thrombin generation measured by calibrated automated tomography, and the ongoing coagulation was represented by complexes of activated coagulation factors with their endogenous inhibitors. So what we found in these patients, that patients with residual venous obstruction after this prolonged anticoagulant treatment had an increased potential of coagulation. Specifically, they had a higher thrombin peak height, but they had actually a decreased ongoing coagulation. Specifically, the thrombin-antithrombin complexes and the activated factor IX antithrombin complexes were lower in patients with residual venous obstruction. Then, in accordance with the previous large study, we saw that there was no association with the recurrent venous thromboembolism, so recurrence rates were similar for RVO and no RVO, but twice increased for post-thrombotic syndrome and arterial thrombotic events. And we also looked at the association of these coagulation parameters with these outcomes. We saw that, as we would expect, recurrence was associated with both an increased coagulation potential, represented by an increased endogenous thrombin potential, and increased coagulation complexes, so the ongoing coagulation. Meanwhile, post-thrombotic syndrome was not associated with the thrombin generation parameters or with the ongoing coagulation, with the coagulation complexes. And for arterial thrombotic events, we only found one complex, the activated factor IX antithrombin complex, which was increased and associated with arterial thrombotic events. But it must be mentioned here that the thrombin generation is in platelet-poor plasma. So that might make a difference if we take platelets into account. So these findings motivated us to look further than coagulation only to understand these associations. There might be an association with fibrinolysis, with inflammation, or especially for post-thrombotic syndrome, it might be in local obstruction, which is the major factor. And this is what we'd like to study in further research. So that was my presentation.
Sorry, just maybe I just missed it, but you did. Yes. You also did platelet tests for activation, or I missed it.
Sorry? No, it was only measured in platelet-poor plasma. So if you go to look at the poster, I left it out for this presentation, the D-dimer levels. There were also associations, but to keep it more simple, now I left it out in this presentation.
Okay, thank you. Any questions? Oh. Okay, thank you.
Okay.
So our next speaker is Dr. Catheter from France. Complete recovery of post-thrombotic syndrome 6 months after venous recanalization.
Thank you for the introduction. Good afternoon, everyone, and thank you for giving me the opportunity to present my work today. I will talk about complete recovery of post-thrombotic syndrome 6 months after venous recanalization. Post-thrombotic syndrome is a long-term complication of deep venous thrombosis. Its incidence varies between 30 to 50%, and from the patient point of view, it reduces the quality of life, and it's also associated with a major public health cost. Currently, there is no effective treatment for PTS, and it's all about supportive management. But nowadays, there are new invasive therapy, such as endovascular approach to do venous recanalization. There are several series with promising data and many trials ongoing. In our center, we already perform venous recanalization for patients with PTS, and that's why we decided to do a descriptive retrospective study in the Georges Pompidou European Hospital. We included all the patients who benefit from venous recanalization with a PTS defined by a Villalta score from 5 and above. The aim was to evaluate the complete recovery from PTS 6 months after the procedure. From 2015 to 2019, 67 patients benefit from venous recanalization. 77% of them were female. The median age was 40, and 18% were obese. As you can see here on the Sankey diagram, okay, no, I can't share with you. Okay, as you can see here on the Sankey diagram, 43% were with a mild PTS syndrome at the initial time, 35% with a moderate PTS, and 18% with a severe PTS. 6 months after the procedure, 67% of the patients were released from PTS. We compared the patients cured from PTS to the patient with persistent PTS, and we find a higher initial Villalta score and also a more frequent initial popliteal location from the DVT. In conclusion, our study has shown that endovascular treatment of deep vein thrombosis sequela improves the post-thrombotic syndrome 6 months after the procedure. And using a multivariate analysis, the initial VIII score odds ratio to predict the persistence of PTS at 6 months was 1.4, and sequela of the superficial vein was 3.8. Thank you.
Thank you. Do you plan to follow up further these patients to see if they develop
Yeah, we already follow them up for more months. It's on the poster. You can come and see the data, and the result persists in the time.
Okay, thank you so much.
Then the next speaker is Dr. Mauro Manuli from the University Medical Centers of Johannesburg Gutenberg University in Germany, and she is joining us by Zoom. And the abstract title is Temporal Changes of Echocardiographic Right Ventricular Function in Intermediate Risk Pulmonary Embolism, Results from the Pulmonary Embolism International Trial, the PETO-2 study.
So, hello everyone, can you hear me?
Yes.
Okay. So, thank you very much. So, my name is Anna, I am coming from the VIII, and I would like to give you some insights regarding the involvement of the echocardiographically evaluated right ventricular function in patients with pulmonary embolism at intermediate risk that were assessed in the PETO-2 study. Next slide, please. So, PETO-2 study is a multi-center, multinational study that has already been published, the primary analysis of which has already been published. The primary aim of this study has been to investigate both the efficacy and the safety of an early switch of, from parenteral heparin to oral anticoagulation with topicatran at day 3. And part of this analysis is to evaluate a secondary point of the general changes in the involvement of the echocardiographic and laboratory measured RV dysfunctions in these patients. So echocardiography was performed in the patients at baseline as well as in the follow-up at 6 days and at 6 months. And the different parameters that were evaluated were categorized into 4 categories that were reflecting the right ventricular size with, for example, evaluation of RV-LV ratio or RV-D1 and diastolic diameter. Then the second category is RV contractility, for example, including TAPSI. Then the third category is RV compression due to pressure overload in the right ventricle, for example, with evaluation with paradoxical septal motion or right ventricular eccentricity index. And the last category is right heart decompensation, for example, with assessment of inspiratory collapse of inferior vena cava. And here in the table on the right side, we can also see the normal values that have been used for this analysis. Next slide, please. Thank you. As said, the primary analysis of this study has already been published. The study has included in the intention to treat population 402 patients that were followed up for 6 months. And 7 patients developed the primary outcome of recurrent symptomatic venous thromboembolism, while 2% died from any cause and around 3% had major bleeding. As shown in the current analysis, we've seen that the echocardiographic dysfunction, echocardiographic RV function actually improved in the 3 out of 4 patients at day 6 regarding the categories of RV contractility and RV pressure, while around 63 to 64% were also involved as normal, staying normal or even improved regarding RV size and right heart compensation. Interestingly, we see that also at 6 months, the percentages are more or less ranging in the same range, but we see that they are even more involved in normality or improvement ranges, with the RV contractility and RV pressure being more improved or staying persistently normal in regards compared to the RV size and right heart compensation. However, we can see that almost 1 out of 4 patients may have at least one abnormal category or persistence in the abnormal category or deterioration of echocardiographic RV function, which gives us the message that the patients should, even if they are found normal at day 6 after pulmonary embolism, it is good that we follow them up for further time. Thank you very much.
Thank you very much. I have a question. This was a single-arm study, so I was wondering how your findings on RV function corresponds to those from previous studies with a later switch of heparin.
Okay, so actually the primary aim of this analysis is to see the evolution of the RV function in the patients that actually were included in this study, so patients with pulmonary embolism with intermediate risk. So yes, it's very interesting also after that to see in comparison with other studies to find the subpopulations in previous studies that actually evolved intermediate risk patients. Yeah, and also something that I didn't say is that most of the patients were actually in the intermediate high-risk group, so it would have been really interesting after this analysis to also compare with previous studies with intermediate risk patients, especially intermediate high-risk patients, to see if there is any improvement or comparison with that studies.
Okay, thank you.
Thank you. I think you can go ahead with your second abstract, sex-specific differences in the 2-year disease-specific and generic quality of life after pulmonary embolism, results from the follow-up after acute pulmonary embolism focus study.
Okay, yes, I go on then. These results actually are coming from the focus study, the follow-up after acute pulmonary embolism study, which has enrolled around 1,100 patients, all comers with pulmonary embolism. And please, next slide. Okay, and in this study, a lot of different clinical, echocardiographic, laboratory parameters have been evaluated. Along all of these, also quality of life and patient-reported outcomes have been assessed. Pulmonary embolism is a field where research has still to be done regarding quality of life, and as seen in previous articles, it has been shown that several diseases, and especially cardiovascular diseases, may have different evolvement of quality of life in men versus women. So in the focus population, we evaluated the patients that have quality of life measurements for all the 3 follow-up time points of the focus study, which were 3 months, 1 year and 2 years. And the quality of life measurements were assessed were both for generic quality of life with the EP5T5L questionnaire and for disease-specific quality of life with a PEMQL instrument. So for the generic quality of life, the less the score, the worse the quality of life, in contrary to the disease-specific quality of life with the PEMQL instrument, where the less the score, the best the quality of life. So for the generic quality of life, there was seen that there was an improvement both in men and in women that was comparable for both sexes. And please, next slide. Thank you. And here in this slide, we can see the differences for the PEMQL score. So as we see the graphs, we can see that women almost always and at all subdimensions of disease-specific quality of life actually exhibit worse quality of life at 3 months and subsequently also at the other follow-up time points at 1 year and 2 years. Although the difference seems to be become a bit not so profound between the first year and the second year, with regard to first 3 months versus first year, for example. And however, as we have seen and we can see now in the table on the right side, we have found that actually the female sex was not associated with a worse quality of life, but comes a little bit in contrary to the first study that we have published in our group in test regarding the 1 year quality of life, where we have found that female sex, as well as cardiopulmonary disease and BMI, for example, have been associated with a worse quality of life. So here we see that at 2 years, somehow there is a balance between the two sexes, and So far, we've seen that there is no so much difference between the two sexes regarding the quality of life if we adjust for several parameters. So thank you very much.
Thank you so much. Are there reasons for which women do less well than men, according to you or your analysis?
Okay, so as it has been shown in several other cardiovascular diseases, yes, it can be some social reasons that may actually lead women to report worse events because of these quality of life assessments are patient-reported, meaning that the patients actually report for themselves what they are feeling or how they are doing. It's not a clinician aspect of it. And it can also be that women, for example, tend to sometimes report worse effects, even if they have the same symptoms. So it can be social aspects, it can be other economic aspects, or even some baseline parameters of some comorbidities that still may have an effect on it. So a lot more research has to be done in this direction to find out exactly what can be attributed to this.
Okay, thank you so much.
That was the last presentation. So we end this abstract session. I would like to thank all the speakers for good presentations. And it's very interesting to hear about all the research projects that are going on around Europe. I would like to thank you all for participating, and I would like to encourage you to look at the posters and discuss with the presenters later today. So, thank you.
So you have now some time, if you wish. We have about 20 minutes, so you can visit the colleagues who present their posters and have a discussion. And please be back to the workshops at 4:45, right? Punctually, so that we do not take. Thank you. Thank you.
Everybody, we're only with a few people, so it will be nice to come a little bit to the front, the ones who are at the back, yes? No, we're not. No, this one is that didn't change because we had the line to England. So it's only possible here. Yes. Yeah, that's right. And it's, you have to change, yes. Yes. This is the one that's acute P on CT. Okay. Okay, let's get started. I will start first, and this works is about acute PE or on CT, or was it pre-existing CTAF? Some of things are a little bit of the reminder of this morning, but then we'll go further on to it. And if you have any questions, don't hesitate, just ask them. Yes? This is a case of a 60-year-old male, and he had no history. And since 2 days he had palpitations, and he was very dyspnoic, and he could only walk 25 meters, but he didn't have any chest pains, he didn't have any other complaints. His physical examination had a tension 100/60, heart rate of 140, but his saturation was 96% with 15 liters of oxygen, so that was very high. The rest was normal, and he had increased CRP. His chest X-ray was normal, and this was his CT scan. I will let it roll twice because once is very quickly. I'll stop it. Oh, we'll go back one slide. And can someone comment what they saw? Just describe briefly. It doesn't have to be a whole description, but did we see embolisms? Yes. Did we see some dilatation of the right ventricle? Yes. Okay, very good, because that are the most important thing to look at an acute CTPA scan. Do we have embolisms? Yes. Do we have RV dilatation? Yes. Okay, you're already very good in examination of the CT scan. Okay, so what do we see on the right side? We really see a very, on here, we see a very central contrast. Here's the contrast, and here we see that there's no contrast. So this is a thrombus, and it's very central orientated. So this is really the configuration of an acute thrombus. But on the other side, with the other arrow, what do we see there? Who can comment? What happened there with the pulmonary vessel there? Someone? It's tapered, yeah. So it's a little bit glued together. There's no thrombus in there, but it's a bit just packed together. Okay, so this is on the acute scan. You see these things. That's a little bit strange, you think, because mostly you don't see that at an acute event. And on the other side, you see this dilated right atrium, dilated right ventricle, a little bit of hypertrophy of the right ventricle, and you see the septal bowing. It goes to the left side. That means there are very high pressure on the right side. You've heard it all today. So the septum goes to the left. And normally the pressure is higher on the left side than on the right side. That's why the septum is the other way around. And so if the pressure increases on the right side, the septum goes to the left side. So you don't have to remember it, you just need to know where the pressures are, and then you can just go further on it. So here we see a patient with acute pulmonary embolisms, and we see right ventricle problems, but we also see, are there some chronic features? Very quickly to the risk stratification, there was a lot of talks about it today. So in our patient is in which risk group? Now we have the original and the simplified PACE, and the PACE was more than 1. And and the troponin was also increased, and the NT-proBNP as well. So the patient became in the intermediate high risk group. Then he visited his GP the last month several times. And so they went back to the patient, they saw the CT scan, and they thought, the story is still a little bit strange. And then the man said, oh yes, I went to my GP many times, and my conditioning is a little bit going down. He bought an e-bike. The whole of Netherlands buying e-bikes, so it's not really reliable anymore, but still, even 16-year-old students all have e-bikes at the moment. But he said, it must be my older age. And does this change your treatment? But at the acute moment, does this change your treatment? No. What are you doing? Yeah, so you first start treating the patients, and then we look further again, because he's coming back again. See how it goes. So, we think he had unprovoked bilateral pulmonary embolisms, and maybe it was acute on chronic disease, but you first starting treating him normally. And maybe in your back of your mind you think, maybe he can have, or at the end, maybe some CTEPH. I discussed this with you this morning. Need elevated pressures, the segmental perfusion defect on VQ or pulmonary arterial obstruction at CT or pulmonary angiogram, and you have to treat the patient at least for 3 months. This is not always the case. Sometimes we have patients coming into the hospital and they're so unstable, like they told already, and you know there's CTEPH, there's no acute event, but if the patient is very unstable, you're not going to wait for 3 months. Then everything goes a little bit faster. But what are the signs of CTEPH on a CTPA? Dilatation of the main pulmonary artery, dilatation of the right atrium of the right ventricle, flattening of the septum, RV hypertrophy. And here you can see these are also signs of pulmonary hypertension. Here you really can see the dilated right atrium, right ventricle, the truncus pulmonalis, and the septal bowing. Why wasn't this described like 5 or 10 years ago? Because the CT scanners was really improved in function. They're much faster, and the heart is a moving organ. So in the beginning, we had more problem to see the heart very clearly because it was moving, and it was always a little bit of a blur. So many old radiologists don't describe the heart because they say, I can't see the heart, I've never seen it. But at the moment, you can see it because all the scanners are faster, and the temporary resolution is the same like your photo camera. If you made a click, in older days, children really has to stand still, and then the photo came, and now with your iPhone you do click, and people are still moving, and your photo is very sharp. It's exactly the same. The scanners are faster, so the images are more clear, and the heart is really very good depicted. So you don't have to stand still for 10 seconds anymore to see the heart very good. So even on a normal CT scan, you can see even the coronaries. You don't see really the grade of stenosis, but you can see if there's calcification. All this is extra information of the last 5 years. And we should recognize this, that we have this information on our CT scan. And it's also, also every extra information is in is where do you put the contrast timing. You can play with it. You can make sure that the contrast is mainly on the right side or also on the left side. You can even combine the two. Then you give a little bit more contrast. So that are all protocols where radiologists can play with what you want to visualize. And as a clinician, you should write clearly what you want to see, because then we adjust these protocols. The other signs are residual thrombus attached to the vascular walls, the intervascular webs and bands, the complete arterial occlusion or the tapering of the vessels, what I already said before. Then the vessel is hardly visible because it's so narrow. So you really have to go segment by segment to see, hey, I'm missing the postural basal artery in my lower lobe. Where is it? And sometimes then the perfusion helps you, and then you say, oh, wait, it's a tapered vessel. And also sometimes you have the poststenotic vascular dilatation that also helps. Here again, nice picture what kind of lesions you can have. So it's not only like the central thrombus, what you see by acute pulmonary embolisms. And if you know the signs and recognize them and you go to UCT, you see them much more often. Here again, more the mural thrombus attached to the vascular walls, but also more the little webs, which gives the stenotic pinpoint stenosis on your vessel. Here again, you see it again. Sometimes it's a little bit less clear, but again, you can see there a nice line walking through the vessel, so that's a really nice web. Now, then we have the dilated bronchial arteries. We can always say like, the lung is a very happy organ. It has two blood supplies. And if the one is going down, like this is happening, then we have the bronchial arteries, which can supply blood. And you do see an increase in the bronchial arteries if you see if the arterial supply is going down. This is a very nice example where you see really large bronchial arteries going to the right side. And if you don't have any contrast in your aorta, it's more difficult to see these bronchial arteries. So sometimes people say, I don't see them. No, if your patient didn't have pH after 2 years. These are the parameters. And there was a sensitivity of 72% and a specificity of 94% for diagnosing CTEPH on acute PE scans. And these were the best predicting parameters for underlying CTEPH. So the septum, hypertrophy of the right ventricle, the webs, the retraction, and the stenotic vascular dilatation, and the dilated bronchial arteries. And if you have 3 or more of these parameters, then there was a sensitivity of 70 and a specificity of 96%. Now, after 3 months at the collation in the outpatient pulmonary clinic, it was going much better. However, he was not back at the level it used to be, and he was still cycling on his e-bike. We did another CT scan. These were the images. And you still see a dilated right ventricle. But also you still, again, the tapering of the vessel on the right side and also on the tapering of the lower lobe. Here, there are the, again, some arrows. And again, you see that the acute thrombus has disappeared after anticoagulation, but the tapered vessel was still there. This patient was discussed. There's another example. Again, you can see the mural thrombus after 4 months. And again, you can see the RV hypertrophy still being there on the right ventricle. And this patient also had a pulmonary angiogram. And here again, you see the large diffusion defects and also the morphologic problems in the vasculature. There was a right heart catheterization being performed, and the mean PALP was 62, so it was really high pressures. This patient was presented for surgery, and this was the thrombus that was pulled out. It was very impressive, large thrombus what came out of the pulmonary system. There was again a right heart catheterization done after 6 months, and then the pressures decreased, and the mean PALP was 31. Still, it's called residual pulmonary hypertension, but the patient was feeling much better, so the pressures were not totally normalized. I already said that is, still many patients a problem. So in time we'll learn how if the patient gets complaints again. And, but he was very well recovered. He went back to his normal bike, so it was bye-bye e-bike. So do you have any questions for me? Yes.
You mentioned CTEC and never CTEC in the chronic pulmonary disease without
Mhm.
pulmonary hypertension.
Yes.
Is it on purpose or is it because
It is on purpose. Because the pulmonary hypertension is a very clear group and we quite know how to treat them at the moment. In our center, again, we have every multidisciplinary meeting, a lot of discussion at the CTED patients. What should we do? When do we present them for surgery? Do we do a PPA or not? Do we give them revalidation? And we're trying even to start a study. We're trying to get money for it to more investigate this, because the treatment options, again, at the moment for CTED patients are not clear. They're not clear in the guidelines. And we're not certain yet how we should treat the patient. So I sometimes see the chronic thromboembolic disease, and there are like 4 or 5 segments. It has a mean POP of 22, 23. What should we do? Yeah, and I think it sometimes depends which clinician is there on our meeting. Sometimes it's like a young people of 30, and he says, I used to cycle 150 kilometers. I really want this operation because I'm a top athlete, or I'm in the military, or I can't. Yeah, or it's like an 80-year-old lady who says, yeah, I don't mind, then I'll go take my car to the grocery store. It really depends. So what is your experience?
So that's really a very interesting discussion, because in every major congress there is one surgeon, PA surgeon, who will show you a very spectacular case of someone who had completely normal pressures at rest, but then they did it and he had some CTED, and now they operated on this person. So actually in Germany there is a very big center that does 150 PAs per year, and at each congress I hear of such a patient, and it's always the same patient. So they found one patient, and this patient has been shown over 8 years.
Yeah, we have operated in our center some of these patients, but especially young patients who are really, they said, I'm so disabled, I don't want to live like this. And it's more about the clinic than on really how many lesions there were.
But it's as you say, Lilian, it's not standardized. No. And this is something that one can take on a case-by-case basis, but it is not something where one would say, you know what, if you find something like this, but the hemodynamics are normal at rest, then you should, I don't know, operate these patients. I mean, it's not, it's not appendicitis. I mean, it is always a major surgery, and so I fully agree. But I don't know. In Germany, I always see that same patient who is now climbing up the Pyrenees, you know, and I don't know if that is healthy, but anyway.
Yeah, sometimes we decide then to do BPA. Because the patient's coming back, but then still it's not where we don't have the evidence yet. That's why it gives a lot of discussion, boss.
I just want to ask one question. From your point of view, is there any role for MRI in the diagnostic workup for CTEF?
In the diagnostic workup, we don't. We do it to do the RV ejection fraction, and yes, we do MRI in all the patients.
But for diagnosing?
Not for diagnosing, at the moment, not. We're not. We're doing dual energy CT for all the patients. But we don't do MR perfusion. We've done in a study, we did MR perfusion. But I think it's still a little bit less reliable, in my opinion, and it takes a lot of time and effort compared to CT, dual energy CT. I mean, that is done in 1 minute, and with the MR, it takes like half an hour. Mostly you have to be by the scanner to sit with the technicians, how they have to do it, how to time the scanner. So it takes a lot of time still.
Okay.
Yeah. Maybe we should go to Michael. Michael, are you there? Or are there more questions? Otherwise we'll switch to Michael. Yes?
my question was about also how do you distinguish recurrence PE, recurrence of PE, from sequelae from PE? And for example, a patient with 6 months treatment, it has been stopped, and then 3 months after he came to the ER with chest pain, the D-dimer high, and you perform a CTPA, and you have the same images, I mean, the same, I don't know, segmental pulmonary embolism than 9 months earlier. Is it a recurrence or is it a sequelae? How
but
can
sometimes
you distinguish
you see the difference in morphology. You do see, we have those patients, and then I see really a difference in morphology again. So you do, see new lesions or different lesions, so yes.
Can I say something?
Yes.
I know I promised to shut up.
No, you're welcome, please.
Because, yes, I think that Lilian said it very clearly today, that routine follow-up CTs or radiologic examinations of any kind are not indicated unless there is a reason. I wanted to say, I know that our French friends are quite friendly towards radiation, and maybe in the Netherlands more so. So in Germany, you know, it is illegal to order an examination, to order an examination that exposes a human being to radiation unless you can confirm that there is no other better way to reach the diagnosis. I mean, this
the
is
ALARA principle.
Self-evident, but you have to sign it. So you have to sign that. And this is because, I mean, you should not underestimate. I mean, you're doing a CT, so okay, you take a photograph. It's not a photograph, right? I mean, the radiologist knows it. And there is also a stochastic exposure. When you are exposed to radiation, you always have a cancer risk. It's
especially for young women.
Exactly.
I mean, for patients above 60, I'm getting a little bit...
So, let's say, in Germany where I practice, this is not done, and we very clearly state it, as Lilian said, but it's also something that they are not allowed to do it. So the radiologist must refuse the examination, otherwise he may be held responsible. So that's really very, very strict in order to avoid overuse of radiation.
If patients really have new complaints and they're deteriorating, of course they can have a new CT scan. Yes, of course. No, it's not really. It's not complicated. No. Michael, I'll switch to you.
Hi. Hi. Okay, see the screen? Hear me okay? Hear okay, yeah?
Yes.
You can, yeah. I just caught the end of that last question there. In fact, was asked this morning, wasn't it? But we had to move on. The difference between recurrence and chronic thromboembolic disease or chronic thromboembolic pulmonary hypertension, but obviously have quite different radiological features. And usually we can be confident about the diagnosis of chronic thromboembolic disease as opposed to a recurrent acute PE. But unfortunately, there aren't any shortcuts. There's not one single test, one single radiological sign which allows us to have a pathognomonic diagnosis. But usually when we put the combination of signs together, we can make a reliable diagnosis. And one of the most signs that we use that I think people have the most difficulty with is mosaicism. So I thought we could look at a case here and then maybe discuss mosaicism and maybe have a bit of fun with the Westermarck sign while we're at it. So this was a 28-year-old female policewoman, no history of PE, history of PE, anticoagulated but persistent breathlessness, pulmonary artery pressure was modestly elevated. The chest radiograph is, within normal limits, and there was no evidence of central filling defects in the pulmonary arterial tree. So that's sort of classic, probably most recognized sign, but in fact not all that common. However, there was an abnormality at the bifurcation of the left lower lobe pulmonary artery, which on the coronal reconstructions we can be confident is not a vessel branch point, is in fact a web. and that was on the angio. So this is central type CTEPH, central type chronic thromboembolic pulmonary hypertension, but without the very characteristic central filling defect, which is probably the most recognized sign. Helping with the diagnosis was the fact they had a positive VQ scan, or high probability VQ scan, and also with the visualization where we interrogated the CT on lung parenchymal setting. So I hope you can all see that well. I don't know how well it projects, but there is heterogeneous lung density there, which we call mosaicism. In fact, our registrars are about to sit their fellowship examination next week. And when I'm doing the practice viva with them, when you mention the word mosaicism, you can almost feel them getting shifty and agitated because it causes difficulty with radiologists, not just with clinicians. So mosaicism is visible regional differences in lung density, and you have to be a believer or not a believer. You basically just have to see it. There's nothing that you can measure that allows you to say above a certain density, this is mosaicism, below it's not. You basically just have to see it. And the reason why there's nothing to measure is just because there's so much variation between people, their age and coexisting disease and state of development. But essentially what you need to be able to do is just see these visible regional differences in density, which is what she has here, which is a very characteristic finding in acute pulmonary embolism. She also has that enlarged, in chronic pulmonary embolism, sorry. She also has that enlarged segmental pulmonary artery in relation to the accompanying bronchus, which is another characteristic sign of pulmonary hypertension, and particularly chronic thromboembolic pulmonary hypertension. So why does mosaicism cause problems? Well, it is a very, very useful sign in the context of investigating somebody with pulmonary hypertension, because it is commonly seen in patients with CTEPH and only rarely seen in other forms of pulmonary hypertension. However, it is occasionally seen. This is pretty subtle, doesn't project all that well, but this is a patient with idiopathic pulmonary arterial hypertension, and there is regional variation in lung density. So that is mosaicism in that case there, which is not due to CTEPH. The real reason that it causes such problems is because this mosaic pattern of attenuation is seen in other disease processes. Basically, there's 3 disease processes in which it's seen in, and they're overlapping and causes a bit of confusion, but in fact, there's not really any real need for it. One of them is just simply patchy inflammatory lung disease. So instead of it affecting the lungs uniformly, it affects parts of the lungs and spares other parts of the lungs. And then the other 2 are related. One of them is chronic thromboembolic pulmonary hypertension, and the other is small airways disease, constricted bronchiolitis or obliterative bronchiolitis. And in both of those cases, the reason you have mosaicism is because parts of the vascular bed are obliterated or hypoperfused. So obviously with chronic thromboembolic disease, parts of the vascular bed are obliterated. With constricted bronchiolitis, what happens is that because parts of the lung are underventilated or poorly ventilated, there's reflex vasoconstriction. So it amounts to the same thing. Parts of the lungs are not perfused. And because of that, you have what's called mosaic oligemia. So some parts of the lungs are better perfused than others. The parts that are better perfused have more density because there's more soft tissue in them. There's the blood, basically the blood makes it look lighter grey. And you can tell the difference between chronic thromboembolic pulmonary hypertension and small airways disease by doing an expiratory study. Because obviously with small airways disease, you have air trapping, and on expiration, the conspicuity of the mosaicism becomes more apparent. We won't go into why that happens, but there are very, very logical reasons why it should be. So this is a case of small airways disease, and if you look very, very closely, the right lung base is more lucent than the left lung base. Okay, there are actually other areas, if you had the original imaging, that you would see there's relatively increased density. So in the azygoesophageal recess here, there's relatively increased density as well. Now, if you look closely at the vessels, the relatively better perfused lung, or the relatively denser lung, the vessels are larger than the more lucent lung where the vessels are thready. And in addition, there's dilated airways in this in the right lower lobe there. So quite often small airways disease and large airways disease goes together. So you wouldn't be, it wouldn't be a wild guess to look at that single image on inspiration and think, well, there's mosaicism there, and the likely cause of this mosaicism is small airways disease. If you do an expiratory study, you would expect the conspicuity of the mosaicism to increase, which it duly does. This is a case of chronic thromboembolic disease where we've got inspiratory and expiratory studies. And again, we've got mosaicism, we've got regional differences in lung density, but obviously there's no difference in the conspicuity of the mosaicism because there's no air trapping, as you would expect. Okay, does that make sense? So I suppose linking into the question about recurrence versus chronic thromboembolic disease, I thought we could have a bit of fun with the Westermarck sign. I don't know if, have you all heard of the Westermarck sign? Anybody moderating? Anybody heard of the Westermarck sign? I'm not hearing a response.
I heard this morning of this sign.
Is that the first time?
Yes.
So it's much beloved by radiologists, much beloved in, I suppose, in radiology exams. But you'll find it quoted all over the literature. Something that's passed down from generation to generation. In fact, I've got a review paper in front of me just now talking about regional oligemia from acute PE, named the Westermarck sign, and talking about the sensitivity and specificity and so on. So this is something which is handed down from generation to generation. And there will be a point to this, honestly. So this is the X-ray which I showed you this morning, where we've got a relative paucity of vascular markings in the upper zone compared to the lower zones. Okay. This is the CT. So the patient has pulmonary hypertension. The main pulmonary artery is dilated. The right-sided, there's right ventricular hypertrophy and dilatation. Okay. The VQ scan is high probability. Okay. So we still can't say this is acute or chronic. And this is obviously the right lung, just as a close-up. I hope it's pretty obvious. Chest X-rays are we call them basic or fundamental. Doesn't mean that they're easy. They're actually the hardest thing I think that we look at. But if you look at the right lower lobe, the vessels there are relatively conspicuous, while as up here, there's really there's a real paucity of vascular markings. Okay, if we look at the angio. The image on your left is the upper zone, the image on your right is the lower zone. So the angio actually completely conforms with the plain film finding of the Westermarck sign of regional oligemia. But this is not acute PE, this is chronic PE, okay? And this is the lung settings, a bit more subtle than the obviously examinations I've shown you so far, but a very close interrogation, you will see the regional difference in density, obviously the big pulmonary artery there again. And if we look at the coronal MIPS of on soft tissue settings, you can see bronchial artery hypertrophy again, which is a sign of chronic pulmonary embolism, not of acute pulmonary embolism. So that all makes sense. Now this, to compare with it, is a CT that came in last weekend when I was on call. And there is extensive bilateral acute pulmonary embolism. This one is definitely, the features here are of acute pulmonary embolism. And looking at the axial sections there, obviously the soft tissue settings showing you this acute pulmonary embolism. But on lung settings, exactly the same level, lots of acute PE there, but the lungs have a uniform density. So there is no mosaicism. In fact, you don't see mosaicism in acute pulmonary embolism. And to go back to the question at the end of the last session there, the last presentation, this would be one way, only one way, because as I say, with the imaging findings in pulmonary, in a chronic thromboembolic disease, there's a number of imaging findings and you have to bear them all together really. But this would be one way of telling the difference between whether you're dealing with recurrent acute PE or chronic thromboembolic disease, because with recurrent acute PE, you don't get mosaicism. Okay, you only get mosaicism with chronic pulmonary embolism. So, I wondered about this for quite a long time. Why is that? If you do a VQ scan on both acute and chronic pulmonary embolism, you see perfusion defects, and they're obviously impossible to differentiate between them. So I wondered why it was that you get mosaicism with chronic pulmonary embolism, but not with acute pulmonary embolism. I don't know, does anybody in the audience have an answer to that one? Any takers? No takers? Well, don't worry, it took me years to work this out. And I guess the clue is in the slide there, which again I showed you this morning from my wife provided for me. So fresh thrombus in the lower lobe pulmonary artery and a large completely infarcted lobe. But looking at that, you just know, don't you, that the weight of that lung is not reduced. And in fact, any pathologist will tell you that when they've weighed the lungs in patients that have died, had a sudden demise from acute pulmonary embolism, that the weight of the lungs is not reduced. And that was the bit that got me thinking, well, if the weight of the lungs are not reduced, that's because they have the same amount of blood in them as you would expect. And of course, that therein lies the answer, isn't it? That with a VQ scan, you're imaging perfusion. So you're imaging where the blood's actually getting into the lungs. Whereas with the CT, you're not imaging perfusion, you're just imaging the vessels. And in acute pulmonary embolism, the vessels might be occluded, but distal to the occlusion, the vessels have not contracted. As we heard in the talk about chronic pulmonary embolism this morning, that the vessels, with chronic pulmonary embolism, they become tapered and narrowed, and it takes a few weeks to months for this to happen, but they become tapered and narrowed and disappear. And when that happens, the amount of blood in that portion of the lung is obviously reduced, which is why you get mosaicism and why you get these regional differences in lung density. Whereas with acute pulmonary embolism, basically the transthoracic pressure is holding the vessels open distal to the proximal occlusion. So that's why you don't get mosaicism in acute pulmonary embolism, but you do with chronic. And so the presence of mosaicism is very useful in telling you whether you're dealing with acute or chronic PE. That make sense?
Can I ask a question as
Please do.
Stupid cardiologist? So this makes sense, but there is one problem. If you tell me, for example, you have a kidney and it gets less blood, then I'll say the kidney has less blood. Okay, it's not good, but you can live with it. But if you have two lungs and they receive less blood, I mean, somehow this is the total cardiac output. So somehow the blood must circulate. So either this patient has a very bad cardiac output and is in a pre-final condition, or are there shunts somewhere else? I mean, somehow you have to maintain, and all the blood goes through the lungs. That's what I mean.
Yeah. Absolutely. Obviously, with patients with very severe chronic thromboembolic disease, their cardiac output can drop. Obviously, if they have very bad pulmonary hypertension, the cardiac output might drop, down to 2.5, 3 liters, whatever. So, but what blood is going through the system is going through the vascular bed that's able to take it. That's why, obviously with mosaicism, it's not the entire lung is not obliterated, otherwise the patient would be dead. It's parts of the lung are obliterated, and those parts where the vascular bed is obliterated are loosened. The other parts are having increased perfusion. And of course, that's probably adding to the small vessel vasculopathy, isn't it? That if all the blood is going through, let's say half the vascular bed is obliterated because of pulmonary embolism, obviously in a patchy fashion, the entire cardiac output is going through the remainder of the lung, and over time, that's going to cause a small vessel vasculopathy. But yeah, it's all going through the lung, but just the part that can take it.
Yes, I totally agree. I mean, that's the problem also when you remove the big clots, that we still have residual pulmonary hypertension because we didn't solve the microvascular disease. And if the other parts had a large amount of flow going through it, and at the end, there also is the endothelium, you get the cascade, and you get microvascular disease at that point. So we didn't solve that yet, and that's the issue I want to raise still. Like, if you have residual pulmonary hypertension, and we're going to do BPA again at the residual lesions, yeah, does it make sense? Because the microvascular disease in the normal regions are not addressed.
Absolutely, yeah. Do you want to, we didn't get much time to look at bronchial artery hypertrophy this morning. Do you want to finish off with a few minutes on that?
How are we? I don't know how we are with time.
Whatever. What does the moderator want to do?
We have 3 minutes.
Okay.
We have to bill it.
Okay, well,
I think the people want a little water break.
They want a break? That's fine.
Let's drink
That's
water.
fine.
Yeah. Okay. Thank you very much that you were joining us. And hope everything is going well with your daughter and your whole family.
Yeah, they're on good form. They're fine. That's fine. That's great. Okay, enjoy your break. Enjoy the rest of the day.
Okay, thank you.
Bye, Michael. Thank
Bye,
you very
Michael.
much. Bye.
Bye, Stavros. Cheers. Bye-bye. Bye.
Someone else question still, or we no? Thank you very much for coming, and enjoy your day.
Okay, good afternoon, everybody, and welcome back to the second workshop of the afternoon. I hope you're all still awake. My name is Fionnuala Nioinle. I'm a haematologist from University College Dublin, Ireland, and it's a great pleasure also to introduce Dr. Elena Campello, who is an assistant professor at the University Hospital Padua. And together we're going to address, we've the very dubious honour of having to tackle some of the most challenging cases in terms of, first of all, the fragile patient, which will be presented by Dr. Campello, followed by selection of patients for long-term anticoagulation. Thank you, Dr. Campello.
Hello, everyone. I can do it. Okay, perfect. Thank you so much. Thank you. So I would like to share two cases with you we faced recently about the management of fragile patients. So the first case is an 88-year-old male with a clinical history of atrial fibrillation undergoing anticoagulation with rivaroxaban 15 milligram, hypertension and chronic kidney disease. He was admitted to the emergency department for acute dysarthria and left hemiparesis, and a cerebral CT showed a right thalamic hematoma and the left shift of the ventricle. As he was taking rivaroxaban, he was treated with reversal therapy with 4-factor prothrombin complex concentrate. And enoxaparin 40 milligram was started as soon as the hematoma was stable. At this stage, there was also a partial absorption of the right thalamic hematoma. The patient remained under thromboprophylaxis with enoxaparin 40 milligram, even after a 30-day CT scan showed a further absorption of the hematoma. Unfortunately, 2 months later, he was readmitted to the emergency department for acute chest pain, and a pulmonary CT scan showed the presence of a thromboembolic defect in the right main pulmonary artery, and the compressive ultrasound confirmed the presence of a left popliteal vein thrombosis. So, which anticoagulant therapy do you suggest or do you recommend, considering that the his body weight is 85 kilograms and the creatinine clearance is 47 milliliter per minute? Any idea or a suggestion? Yes, please.
I think I would start on unfractionated heparin because it's easier to stop with something with capsule.
Okay, but after the initial decision, what kind of anticoagulation do you suggest after heparin? Okay. 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 We performed a cerebral CT scan, and the hematoma was further absorbed. So, and the hemodynamic of the patient was very perfect. So we didn't have the idea that there will be a possible deterioration. Okay. So. Do you have any, or any of you have any other idea? Okay. You don't have the perception that the dogs will be safe in this patient? Okay, the last questions, according to you, how long do the anticoagulant therapy should be for this patient? Yeah? Okay, long term, with the same compound? Yes.
Since you had the hemorrhage with rivaroxaban, but you still use a reduced dose of one of the others.
Okay, which one?
Well, that's a really difficult question. I think. I mean, yeah, I wouldn't have any direct preference for any of them. Except not rivaroxaban.
Okay, thank you. That's very okay, very okay. So as after the cerebral CT scan showing that the hematoma was stable, we decided to start with low molecular weight heparin according to body weight, and after seeing that the neurologic there was not a neurological impairment, we switched to apixaban 5 mg twice. Because apixaban showed a better profile in patients with atrial fibrillation, okay, and so we decided to use this drug for 3 months with a full dose because this was a provoked event, okay, and then after 3 months of anticoagulation we started apixaban 2.5 mg twice long term because this is a patient with atrial fibrillation with that is older than 80 and he has impaired renal function. And the patient is doing well. There was not VTE recurrence at the moment, and there was no recurrence of the hemorrhage. Oh, yes, please.
Just one comment, because the CT scan of the patient shows that you have a deep cerebral involvement. So, did you consider this cerebral bleeding as typical site?
No, this is not a typical site.
Bleeding that is in an if this cerebral bleeding by the CT scan features I'm talking about that suggests signs of amyloid angiopathy, then the decision is completely different.
I agree with you. Thank you. We also performed the MRI, and we didn't have signs of microangiopathy or microbleeds or signs of possible recurrence of the hemorrhage. So we felt confident to put the patient on long-term therapy. Thank you for the comment. Any other comment? Okay, so shall we move on to the second case? That is an 84-year-old female with a clinical history of Alzheimer's disease with bed rest syndrome, Graves' disease, heterozygous factor V Leiden, previous superficial vein thrombosis, and in 2019 she was hospitalized for bilateral femoral veins thrombosis and was treated with rivaroxaban 20 milligram for 6 months, followed by rivaroxaban 10 milligram that was still ongoing. And she was admitted to the emergency department for acute edema and pain to the left leg. A comprehensive ultrasound confirmed and showed the presence of a right popliteal vein thrombosis with no residual signs of the previous thrombosis in the left veins. So again, another tricky decision to take. Which anticoagulant do you recommend, considering the body weight that is 65 kilogram and the creatinine clearance that is quite normal, 58 milliliter per minute? So we have a recurrence during rivaroxaban 10. What do you do? Any idea? Maybe we can restart rivaroxaban. How many of you, full dose, how many of you will take this decision? Okay. How many of you will change anticoagulation? Okay. With DOACs or with enoxaparin?
Well, first I would put her on approximately 60 milligrams of enoxaparin therapeutical dosage.
Okay. Why?
Well, she's in the hospital, right? So we'll start with enoxaparin, and after discharge, I will switch to apixaban. But of course, because she has Alzheimer's, so I will remind the nursing to give her regularly every day, because thrombosis might appear because she forgot, for instance, to take some medications, and we know that it works for 12 hours. So
yeah, it's correct. It's your idea is good, and we decided to start enoxaparin according to body weight for the first days in order to understand why there was a recurrence, and with the idea to keep the patient with a full dose DOAC, and our idea was for edoxaban 60 in order to change anticoagulation, because the previous one was with the recurrence was during the rivaroxaban, but also because edoxaban is once a day, and so we prefer this drug for this patient with Alzheimer's disease. And probably in these patients with multiple permanent risk factors, such as the presence of factor V Leiden, the history of previous superficial vein thrombosis, and for sure the presence of a bed rest syndrome, there was an increased risk of recurrence during EDOACs at a reduced dose. Okay, any comment? Yes, please.
That rivaroxaban would not be appropriate for her in this situation?
Yeah, we decided to change it. Well, I know that probably the problem was the dosage, for sure, the reduced dosage, but since the recurrence occurred during this drug, we decided to change the type of compound. Okay. So we'll take the next 5 minutes just to give you a short update on what we know about fragile patients with VTE. And first of all, the definition of fragility in patients taking anticoagulation is the presence of creatinine clearance below 50 milliliter per minute, or an age older than 75, or a body weight less than 50 kilograms. And as you can see, our first patient had 2 of these characteristics, and the second one has 1 of these characteristics. However, the definition of fragility is more complex and includes many other characteristics, such as, for example, the presence of recent major bleeding as the first patient, or the presence of dementia as the second patient, or, for example, the presence of anemia, dysphagia, and so on. And we don't know much about fragility, because the proportion of patients with fragility was low in the clinical trials, and their outcomes haven't been deeply evaluated yet. From this study, from the VIII registry, we have the information that the proportion of fragile patients among patients with VTE are as high as 42%, and that these patients tend to have more bleeding complications than VTE recurrence while on anticoagulation. In this second study from the VIII registry as well, we see that fragile patients that initially received DOACs for a VTE had a lower rate of the composite outcome, recurrence and bleeding compared to fragile patients receiving low molecular weight heparin as initial therapy. But you can see from the odds ratio that the difference was not statistically different, while patients receiving DOACs as long-term therapy had a significantly lower rate of the composite outcome compared to patients taking vitamin K antagonist. And lastly, we can see from this more recent study, again from the VIII registry, that now clinicians feel confident to start DOACs as an initial therapy also for fragile patients, and they tend to choose rivaroxaban and apixaban. However, there was a substantial amount of patients in both subgroups that received non-recommended doses of DOACs. So clinicians tend to reduce the dose of DOACs because of the fragility of the patients. So in conclusion, what we know about fragile patients is that the proportion of fragility is high, up to 40% among patients with VTE, and that fragility has a comprehensive meaning and needs to be evaluated in a case-by-case basis. There is a consistent risk of bleeding, even more than maybe the recurrence, but the DOACs appear to be effective and safe in this category of patients, but they should be used at appropriate dose, and we don't have to reduce the dose if not recommended. Finally, long-term therapy with full dose should be considered in fragile patients with the presence of multiple permanent risk factors, as the second case we saw. Okay, any comment or? Okay, maybe we can move on to the second part of the presentation. No, it's okay.
Thank you so much, Dr. Campello, and thank you all for your interaction. Okay, so we're going to discuss tough causing anticoagulation, how to select patients, or who do we select for extended anticoagulation. So I'll start with a case. A 65-year-old man was diagnosed with an unprovoked ESC low risk lobar pulmonary embolism, and he attends your clinic after 3 months of anticoagulation. He's had no bleeding complications and no risk factors for bleeding. So at this point, I'd love to take a show of hands. So how many people would stop his anticoagulation at this time? How many people would, oh, no. How many people would continue indefinitely? And by indefinitely, we of course mean at least annual review with very careful assessment of bleeding and thrombotic risk factors. How many people would continue indefinitely? And everybody else would do something in between. Out of interest, anybody stop at 6 months, at 1 year? Is there any other practice? Okay, very, very interesting. And this is such a seemingly straightforward case, but extremely challenging and a huge part of our practice. So about 50% of VT patients will have had an unprovoked event. They require a lot of care. And as one of your colleagues from the very beginning pointed out yesterday, shared decision-making with your patient is crucial. I think that's the take-home message today, even if you want to fall asleep at this point. So this patient, this man, is right now at this point in decision-making. So he is completed primary therapy, 3 to 6 months, in this case 3 months, and is now moving on to consideration or being assessed for secondary prevention. And today we're going to go through as many cases as we have time for, kind of anchoring to this decision point, this crucial point. So when we make decisions on duration of anticoagulation, what do we, this is not a trick question, what do we think about? What are the major decision-making influencers? Thank you. Dr. Baumgartner.
So the first question is whether it is a provoked or unprovoked VTE.
Excellent, yeah. And what about, so what are we weighing up? Why is that important? Why is it important to know what the risk factors are? And thank you for pointing that out.
So it's a risk of recurrence.
Yeah, exactly. So you've got the risk of recurrence versus what? Bleeding, perfect. Okay. And I know that sounds straightforward, but you'd be surprised how often it's forgotten. And of course, we're not just talking about case fatality, because there are, of course, long-term health complications associated with a recurrent VTE. Does anybody want to tell me about these complications? So we have a lot, so shout very quickly. We think about the last workshop. So after pulmonary embolism?
The CTEF.
Excellent. Yeah, CTEF. And even before CTEF?
Yeah, of course.
Chronic thromboembolic disease, yeah. What about psychological consequences?
Of course.
Yeah. So and of course after a deep vein thrombosis there will be post-thrombotic syndrome, and these complications have huge health implications for your patients and are more common than had previously been realised, as elegantly outlined by many colleagues here today. So this gentleman has had an unprovoked venous thromboembolic event. So is his risk of recurrence higher or lower than that associated with, say, an event in the context of a major provoking factor? Higher or lower? If it's a transient provoking factor, apologies. Higher, yeah. And what about in the setting of a persistent major provoking factor such as cancer? It's going to be lower, isn't it? So and that was beautifully demonstrated in this figure by the late Dr. Clive Kieran and colleagues, published a couple of years ago. So those patients whose VTE occurred in the context of a transient major risk factor appear to have the lowest predicted recurrence risk, followed by those with unprovoked VTE, followed by those with a persistent factor. So here's maybe a slightly more difficult question. Can you estimate, when you're counselling this patient, so we said that one of the most important things we're going to be doing is shared decision-making with our patient and listening to what our patient thinks. So how are you going to counsel him on what you think his risk of recurrence is over the coming 1, 3, and 5 years? Do we have any data? So what about at 5 years, what do you think his predicted risk of recurrence might be?
So in general, I think it's about 30% for patients with unprovoked VTE.
Yeah. So a recently published, a very nice systematic review by the Convector Network and meta-analysis, of course, estimated that the risk of recurrent VTE in people whose initial event was unprovoked was 10, 25 and 36% at 1, 5 and 10 years respectively. So you're spot on. Thank you. So I made it very clear that this was a man with an unprovoked PE. So is the recurrence risk, if we were to discontinue anticoagulation, higher in men than in women? Or is it higher in women than in men?
It is higher in men.
Very good. So this has been shown time and time again in a number of studies, including this one. Well done. So the answer is, so not all people with an unprovoked VT have the same recurrence risk, and in this study it was shown to be about 3 times more common in men than in women. And that has led many groups internationally to seek to characterize prediction scores that might help us to identify a group of, say, women who have a sufficiently low risk of recurrence to be able to discontinue anticoagulation. We probably don't have time to explore these in detail today, but one of them is, for example, the MEN HER2 score that has been derived and validated by the CanVector network led by Dr. Roger. Are you familiar with it? Yeah, but isn't that, you know, it's important to say that the most recently published International Society guidelines, you know, urge caution when applying them because of an uncertainty around the, I suppose, the accuracy of being able to identify women who are at sufficiently low risk to discontinue anticoagulation. And of course, when we're talking to this patient, we have excellent quality data to inform him that while anticoagulation will reduce his risk of recurrence while he's on it, as the PADIS PE investigators demonstrated, when anticoagulation is discontinued, this benefit will not persist. So, closing off this case, what do the guidelines say? So the 2020 American Society of Hematology guidelines on treatment of DVT and PE suggest indefinite antithrombotic therapy. And by that, we don't mean lifelong therapy. We mean that a patient should be risk assessed and reviewed carefully, at least on an annual basis, evaluating competing thrombotic, so recurrent thrombotic, risks and also bleeding risks while on anticoagulation. We need to look at identify and address reversible, potentially reversible bleeding risk factors. And this was given a conditional recommendation based on moderate certainty in the evidence of effects. But of course, as quite rightly highlighted, this recommendation doesn't apply to patients who have a high risk for bleeding complications, which our patient did not. The European Society of Cardiology guidelines on acute PE make similar recommendations, and most recently the ACCP guidelines, which were most recently updated a month ago, noted that this is the most common and difficult decision that we sometimes face. In making, I suppose, a similar recommendation to ASH, the authors performed a new pooled analysis which included 15 randomized trials and concluded that the balance of effects probably favoured continuation of anticoagulation with a moderate certainty of evidence. So moving on then to the second case, unless there are any remaining questions following the first case. Okay, so now we have a 31-year-old woman with ephemeral DVT provoked by combined oral contraceptives. How would you counsel her regarding duration of anticoagulation? It's not a straightforward scenario. So anybody like to comment? Okay.
Maybe I can try. I think it's not straightforward because
yeah.
the guideline will put this category in intermediate risk. So
yes.
you would not really feel that safe in not saying that she's not going to have a high risk of recurrence, but she's a 31-year-old woman, and I wouldn't feel comfortable in putting her on lifelong anticoagulation.
Yeah. Thank you. You have elegantly summarised the dilemma that we face in counselling and managing these women. And when you've, I think, hinted at personalised risk assessment, and what might you try to explore when you're counselling or meeting this woman?
I think it also depends. Yeah, you say femoral DVT.
Yeah.
So that's proximal DVT. But yeah, of course you should. You should, of course, discuss to stop oral contraceptive and not start again.
Very good. Well, does that apply to the time that she's on anticoagulation?
Yes, but also I wouldn't suggest to restart with is it estrogen contraceptive?
Yes, yeah.
So I wouldn't suggest to restart.
Okay, we'll go through that now in a second.
Yeah.
And what about her? I purposely chose a deep vein thrombosis on this occasion. So what are you going to, when you're examining her at follow-up, is there anything you're going to be looking out for?
Yeah. Yeah, PTS.
Yeah, absolutely. And maybe looking at her body mass index.
Yeah,
so, yeah, it's a tricky question. And as elegantly again outlined by Dr. Baumgartner earlier on, do all risk factors predict the same recurrence risk? And the answer seems to be no. And several society guidelines have proposed various strategies to help us to evaluate the impact of risk factors on a person's individualized VTE recurrence risk. And as you're probably all very aware, a recent one is that proposed by ESC. And here, risk factors are categorized as low, intermediate, or high, with estimated VTE recurrence risks of less than 3%, 3 to 8%, and greater than 8% per annum. And of course, estrogen therapy or contraception falls broadly into the intermediate category. But of course, the situation isn't always clear, as you quite rightly pointed out, and guideline recommendations aren't always crystal clear on this topic. And this is probably not surprising because studies evaluating the impact of hormone use on VTE recurrence risk have been heterogeneous in design and have reported conflicting results depending on the population, and the absolute risks of thrombosis are highly variable, and that is, I suppose, a very important consideration. And recently, a large UK retrospective population-based study reported that hormone users had about a third lower VTE recurrence risk compared with non-users. Okay? But you quite rightly pointed out that personalised assessment is always going to be important. So we are going to be interested in whether she has personal additional risk factors that might push her recurrence risk up. And one of those was addressed very recently in a study by Dr. Aziz, led by Dr. Gregor Legal and colleagues. So you can see here that this was a sub-study of the reverse cohort study. So this was the reverse cohort study validated the men HER2 rule derived by Dr. Roger and Canadian colleagues. And this particular cohort study included 322 women who had had a first VTE, of whom 15.5% were combined oral contraceptive pill users. And that means estrogen and progesterone. And yes, of course, these women were younger than the general female population. Interestingly, the risk of recurrent VTE was 1.1% with an upper bound of 2.9 in pill users, compared to 3.2% with an upper bound of 4.3 in non-pill users, with a hazard ratio of 0.37. And before you ask, yes, a sub-analysis was done, including women who are under the age of 50, and the effect size was similar, but of course the confidence intervals were much wider. So that is interesting, and again reflects a similar message to the UK data that I've just proposed, that I've just shown you. But intriguingly, in this study, women who had what's called a high HER2 score, does anybody know what that is? We'll go through it, who were pill users, had a higher predicted recurrence risk than those who didn't, with an estimated risk of recurrence of 3.5%, very wide confidence intervals, but of course the numbers were small. So that is why I was asking you about what we might look for in this woman. The HER2 score consists of parameters: hyperpigmentation, erythema, redness of the affected lower limb, obesity, a high D-dimer, and the last one, older age, over 65. So women who have a HER2 score of 2 or more are considered to have a higher, higher chance of recurrence. So it's, I suppose, the message is not conclusive, but I think this is useful for patient counselling and useful for consideration of individual risk when combined with other factors. And of course, it is interesting that there are also women who have potentially a much lower risk of recurrence, a very low risk of recurrence. And in this study, the Dodds study led by the late Dr. Clive Kieran, women who had an estrogen-provoked VT event, who had had a negative D-dimer after discontinuing anticoagulation, had a particularly low risk of recurrence. So I guess the message is that, yes, overall, we do suggest a limited duration of anticoagulation, but we must not forget the importance of personalised risk assessment for these women, and as one of you pointed out earlier, the importance of shared decision-making with your patient. You hinted on a very important topic, which is that cessation of hormone use after anticoagulation appears to reduce the risk of recurrent VTE, and this is really important for patient counselling. So in this study, women who had hormonal risk factors at their first event were analysed according to exposure to risk factors during follow-up, and the recurrence risk was 4.6-fold higher in women who continued versus discontinued anticoagulation. So yes, after discontinuation of anticoagulation, we'll be exploring other suitable contraceptive options that still provide adequate contraception and that they're compatible with her quality of life. And many of my patients elect to use a progesterone-releasing intrauterine device at that point. However, what about during the phase of anticoagulation? Sorry, I shouldn't have shown you that. Can she keep taking combined oral? Can she keep taking estrogen during the phase that she's on anticoagulation? Yes. Hands up for yes. Hands. I was about to say hands down for no. Hands up for no. You're right. So, very elegant data by Dr. Martinelli et al., which was a post hoc analysis of the Einstein cohort. In this study, VTE recurrence rate was similar in women who were and were not exposed to hormonal therapy during the phase of anticoagulation. And of course, yes, the confidence intervals are wide, but the competing risk of stopping hormonal therapy, as Dr. Schreiber pointed out earlier, can be an increased risk of anticoagulant-associated abnormal uterine bleeding. And of course, that's a major impact on quality of life for women. So I was delighted that she pointed that out. So the key message there is that it is safe to continue hormone use during the phase of anticoagulation in general. Okay. So just coming soon will be an ESC position paper that we wrote under the leadership of Dr. Gluck, in which for this particular issue we nail our colours to the mast and say that we propose a limited duration of anticoagulation after hormonal contraception is discontinued, particularly if the bleeding risk is high, and of course women have a lot to lose by being on long-term anticoagulation, or if no risk factors associated with an increased recurrence risk are present. Will we move on to another case? Do we have time? Oh, sorry, Dr. Baumgartner.
Can I ask a question?
Yeah.
I think the VT risk is highest right at the beginning of contraceptive use.
Yes.
So would you consider the recurrence risk to be different, whether the initial event occurred at the start of contraceptive use or just during the course?
It's a very good point. And yes, there does seem to be, we don't have very high quality data, but it does seem to be that there is a spike in the first few months after starting a combined oral contraceptive pill. And I think that's really important when we counsel women at the point of decision making. So if she had been on the pill for a very long time, as opposed to having started it recently, well, yes, that's a consideration. I'm seeing a strange message here, but I'm just going to click away. Thank you. Yeah. Yes.
Another question on this. Yes, but we also wanted to say that in the supplement of the guidelines, there is a table in which at that time under Cecilia's leadership, this was also clearly said as the Hereditary was involved. So the guidelines did not put the younger women on hormonal treatment in that yellow, red, green tables, but they were seen, of course, saying that there is no evidence, no hard evidence of this, but this was what was proposed. My question is, there are some women who cannot stop hormonal treatment for medical reasons or for whatever reasons, whether they are 30 or 25, or sometimes there are women who are 60 and need hormonal treatment. So now the question would be, okay, then we would continue. And my question is, with what dose after 6 months? Would we go for the full dose, for example, if we use Xarelto or liquids, and say the studies, the data we have from the Einstein studies that you mentioned, they were done with a 20 milligram dose, they were not done with a half dose. So shall we continue with full dose, or shall we say, well, okay, look, your HER2 score is otherwise fine, so you can go on with 10 milligrams. What do you do in such cases?
Yeah, it's an excellent question, and of course we face that too in trans women for whom we have no data, but who do. No, it's an important. It's a very, very important, topic. So, and I think we of course don't have long-term data for women who choose to, high-quality data to predict VIII recurrence rate for these women. However, we do know that they will have a high risk of abnormal uterine bleeding on anticoagulation. Personally, I counsel these women on the risks and the benefits, and that we're going off-label, but I would use a low-dose regimen, so say apixaban 2.5 milligrams twice daily with, of course, they're on contraception, but it's important that they're counselled about, regular pregnancy tests. What do you do, Stavros?
Yes, I think so too. I mean, the problem is that so principally, I would have thought that, we tell them that formally we would prefer for the data we have to continue with full dose, but then comes the practical issue. Well, if it is after hysterectomy, I mean, it's not so much an issue, but if it is with normal menstruation, then you're often, you have to reduce.
Yeah.
You have to reduce. So practically, this is what.
Anyway, I think that contraceptive associated venous thromboembolism was included in the AMPLIFY extension.
Yes.
We don't have a dedicated trial, but anyway, the data on the efficacy and safety of
That's a good point.
probably apply to this patient.
And what do you do?
I have some concern on extending therapy lifelong in a 31-year-old woman, because it means she cannot have pregnancy. Anyway, let's say the audience was really, let's say, uniformly recommended to continue long life.
Oh no, not for this case. Oh, the previous case. Okay.
Yeah.
Okay. So that was
in my opinion, young people, that means young women or also young men, have the potential to receive 60, 70 years of anticoagulation. And we don't have any data on that. So my perception is, first of all, that as soon as it is possible, as soon as we are confident, I usually reduce the dose. Because we don't have so many data on extended treatment. We, let's say, derive this data from atrial fibrillation, where we are using anticoagulants from some, let's say, 2 years earlier. But I want that young doctors know that this is an issue in clinical practice. So we don't know what to do, and our recommendations are 2A, and many of these recommendations are C level. So this means that you have lots of things to do in your future, in your, let's say, research future, because still we don't know what is the best things to do. Yeah. And so when we face with very young people, we know that a recurrent event would have struggling effect on their life, but overall, I think that we also should care about the uncertainty that we have.
Yeah. And actually that raises a political issue as well, which is that resources need to be put in place to facilitate counselling of these patients on at least an annual basis, which it isn't. I thought it was done very nicely, I see Dr. Husman is there, who's a co-author of the ACCP guidelines, and the point was made that really we have very few data, very few patients were followed up in trials beyond 4 years. So for me, it's probably the most difficult question that we face, and yet such a huge part of our practice. It's fascinating to me to hear what other centres do. So I think for the trainees, it's useful to anchor to the guidelines, and what I think that it's very clear that the 3 major society guidelines are unanimous with conditional recommendations. Do you have any? So Dr. Stavros, the first case was an middle-aged man with an unprovoked ESC low-risk pulmonary embolism. So, he had no bleeding risk and no, it's difficult.
Lower intermediate or high
Yeah, it doesn't matter.
And
Yeah.
no one knows what the next risk will be, right?
Yeah.
You will only know. Yeah.
So the vote.
We do have a program where, and I would say most German clinics, meanwhile, or major hospitals, not all of them, have an annual follow-up program.
Yeah.
So we follow them and this will also be published shortly. We follow them for 2 years, so at 3 months, 12 months, 24, and then we hand them over to their general practitioners. In most cases, they want to continue to be followed by us, so we do that in many other centers. So it's, as you said, there's no lifelong anticoagulation, because in 70 years from now, Cecilia, who knows what will be, right?
Yeah.
So as you said.
Yeah. We do very similarly, and I completely agree that this advocating for that annual review, anchoring to the best data that we have at each time, is going to be crucial, and that's our safety net. So if we do have better data down the line, and I suppose being aware and conscious of individual risk factors for bleeding and recurrence. Now, I think, do we have time for another case, or will we?
So I think we can, because there was some delay, I think we can have another, let's say, 10 minutes for the workshop. So
Okay, we can.
Is that okay with you?
Okay, all right. So
12 minutes.
and thank you for the intro. So case 3 is even more challenging potentially. So it is a 61-year-old male who has been confined to bed at home for 4 days with pneumonia. 3 weeks later, he is diagnosed with a lower, for the sake of interest, ESC low risk pulmonary embolism. So how would you counsel him on, and he has no bleeding risk factors and no bleeding events at 3 months. Does anybody, so what do people vote for? Who votes for indefinite? And by that I mean, of course, not lifelong, but with a regular scheduled follow-up visit and assessment of risks, at least annually. Do you vote for that? Okay. And who votes for a limited duration anticoagulation? Okay. So the first option was indefinite. Okay. And the second is limited duration, so we're going to stop at 3 months. Okay. Who isn't certain? Okay. So, yeah, I know, I'd agree. Dr. Baumgartner earlier on told us that risk factors are crucial when we estimate recurrence risk, and it's really important to remember to pay attention to risk factors that are present at the time of the initial event. And crucially, recurrence risk is lower when the VT event was provoked by a transient major risk factor compared with unprovoked VTE, as for example reported in this NICE 2010 systematic review. So, how would you define this gentleman's risk factor as, how would you define it? And it depends on the guidelines you read most frequently, but if following the ACCP definition, is it a major or a minor? Minor, yeah. So according to the most recent, to the ACCP definition, which is of a VTE provoked by a minor transient risk factor, which is present within 2 months prior to the VTE diagnosis, an event provoked by confinement to bed out of hospital for at least 3 days with acute illness qualifies as a minor transient risk factor. And according to the ESC definition, this risk factor is also within the intermediate risk. So it's a similar category to our pill-provoked event, but very different. It's fascinating. So here is where there is some discrepancy in guideline recommendations. So the most recently published ACCP guidelines in 2021 considered this very carefully and noted that patients with a minor transient risk factor represented a group with the closest balance between the risk of recurrent thrombosis without extended anticoagulation and the risk of bleeding if receiving extended anticoagulation. And the panel favoured a suggestion against offering extended anticoagulation, but said that this decision was highly informed by the values and preferences of the patient, as we said earlier, and noted that other guidelines, as you'll hear, ASH and ESC had made weak recommendations for the opposite, but anchoring back to the importance of advocating for personalised decision-making. In contrast, the European Society of Cardiology guidelines on acute PE made a 2A recommendation should be considered for extended anticoagulation for patients with a minor transient or reversible risk factor for the index PE event. So I think what this shows us is that these patients require particular attention. Do you have any comments, Stavros? Yes.
Yes, I have a comment.
Yeah.
I do not think there is a contradiction. I think it is very important, and I try to explain it all the time, what the should be considered means. And I mean, when you get older, you try to tell people to pay attention to each word. Should be considered does not mean it should be done.
Yeah.
Right? Should be considered means it should be discussed. So there are three categories. It is recommended. Okay, you should do it. That's it. There is one category that says may be considered, which in my opinion is totally useless, because may consider means you may think of it, that's okay. You may not think of it, it's also okay, so it doesn't matter really what you do.
Yeah.
And should be considered means in any case you should list the arguments in favor or against anticoagulation. You should then inform the patient and have the patient's opinion, and then you must document your decision. Yeah. And this is also very important in cases of litigation where there is some fatal recurrence. Yeah. But so that is, I believe, the importance of should be considered. And when this is, that's interesting, because when this is translated into other languages, then it is well translated into French, where people say should be envisaged, which is quite similar. But when you translate it into German, they said, so the Germans have between must and should, so soll and sollte, so that means the second is weaker. It's not a weaker form of must. It is that you should consider it. So in my opinion, the ESC language, it was not only for this guideline, it's for all guidelines of the ESC, it is a correct one. So this is a case where you must definitely, and in most cases, or let's say in the majority, you will probably decide in favor of it. But it's okay if you decide against it, but you must have documented your decision. And in the may be considered category, it means it doesn't matter. If you don't document anything, then it was not so important anyway.
Thank you. That was a beautiful comment, and I think the importance of documentation and explaining the counselling that has been done is it's something I do with all my patients, and it is crucial. Does anybody have any other comments on that challenging case? What, Julia?
Between minor and major transient risk factors, the evidence on anticoagulation mainly derives from the Einstein choice, that is a single study, single randomized study, and these are subgroups inside a single randomized study. So this is another, let's say, issue that should be considered when in your clinical practice, because we know we have many data on oral contraceptives, so okay, this is not only the Einstein choice, but for the majority, as this case of a patient that has a short bed rest, I don't think we have too many data to get a decision. So the guidelines are a support to our clinical decision, but not always the evidence is still there for each subcategory. So this is important to know, in my opinion.
So counselling is crucial.
A second point, sorry, that we know that the risk of recurrence for PE and DVT is the same, but the type of recurrence is different. So this is another issue that we should take care in our decision making, in my view, because obviously to have a recurrent DVT is different from the risk of the event respect to having a recurrent PE.
Completely agree. And this gentleman had a PE, not a DVT. So, we'll skip on to the very end. So just in summary, here is how we plan our care for patients with their first VT event. We first discuss our initial plan with the patient at the time of the diagnosis. After a limited period of anticoagulation, we discuss whether extended anticoagulation is warranted based on initial and ongoing risk factors, bleeding risk, gender-specific considerations, and patient preferences. particularly in these really challenging scenarios where the duration, the optimal duration of anticoagulation is unclear. And this discussion guides our shared decision making. So for most patients with a VTE, for most patients with a VTE provoked by major transient provoking factors, we advise limited duration anticoagulation, represented by the red light. In contrast, for people with an unprovoked major VT event and others with a high predicted recurrence risk, we consider indefinite duration anticoagulation, consider being the optimal way of putting it, if they have a low bleeding risk. We plan regular visits going forward to repeat a risk assessment. And then there are scenarios where personalized shared decision making is going to be crucial. And for these for these cases, planning that counselling session and bearing in mind individual risk factors is crucial. So thank you very much for your attention and enjoy the coffee break. Okay, thank you.
I think we can reconvene at 7, right? Let's have 25 minutes of break.
The notes, it shows the notes in Greek. No, it doesn't. Oh, fantastic. Thank you so much. Sounds like I can't read Greek. So good evening, everyone. I'm not sure. Is it okay not to use a microphone, or shall I use a microphone? Can you hear me without a microphone? Yeah, sure. But in terms of recording, maybe because of this, they should be recording. Thank you. This is very serious suddenly. So let's start again. My name is Karen Schreiber. Thank you everyone for attending. I'm a rheumatologist and I work in Denmark, partially in London. And I'm very pleased to have this session together with Christina.
So I'm Christine Baumgartner. I'm a general internist from Bern in Switzerland. My research is mainly on prevention of VT in hospitalized patients, so not too much about immunothrombosis, but I've been working on COVID wards the last 1.5 years, quite on a regular basis, like probably many of you. So, and this is when I really became increasingly aware of this clinical phenomenon resulting from immunothrombosis.
Yeah, and exactly. And for me, immunothrombosis or hyperinflammatory syndromes, hyperinflammation is something that we as rheumatologists quite often see. So we see it in patients with connective tissue diseases, with lupus, who get really ill. And I must say, I don't want to say I'm glad that COVID shed a bit light on the underlying mechanisms of hyperinflammation, but it really did do something to the awareness of the immune system and its involvement in the development of thrombosis. So let's start off. Today's aim is really to give an overview of the term immunothrombosis and also to demonstrate 3 cases of immune thrombosis in relation to clinical cases. And we will be outlining the immunological approach to treat immune-mediated thrombosis. And hopefully at the end of the talk you'll be able to describe the connection between inflammation and thrombosis and consider the role of immunosuppression in this setting. So today's content, we will try and make it really interactive because we appreciate it at the end of the day and we are all a bit overwhelmed by all the information we have been given. So we will start off with a brief introduction of the term immune thrombosis. Afterwards we have 2 cases, which hopefully you will find interesting, and then we'll be discussing these cases and the treatment and wrap up and show you the take-home messages. So I thought, how are we going to start this? Because this is immune thrombosis is a really, really broad term. And if you ask scientists, they will probably give you a different answer to what it means to them as opposed to clinicians. And again, if you ask clinicians, well, it means something different to a nephrologist, or if you ask a rheumatologist or an internal medic. So just briefly, is there any rheumatologist in here? Or any immunologist? Okay. Good. What does it mean to you, Christine? You work in internal medicine.
Yes, so first I was confused with the term, and to me it just means something that is a kind of thrombosis that is related with dysregulation of an immune system, of an immune response.
Yeah, exactly.
But I have to be honest, so I had to Google it too to realize what manifestations we can describe with this term of immunothrombosis.
Yeah, and if you, for example, ask a nephrologist, I'm sure they will tell you it's thrombotic microangiopathy. If you ask a pediatrician, it might be hyperinflammatory syndromes. I don't know, what does it mean to you? Go ahead. Stefano, what does it mean to you?
So, it's a thrombosis for which the primary trigger are immunological changes.
Yeah.
Primarily immunologically driven.
Yeah, Yeah. Or at least a part of the process is based on the immunological response. Yeah, very good. So for me as a rheumatologist, rheumatologists are very simple people. We need to make a diagnosis. We always need classification criteria. We treat every disease with corticosteroids, and that's what we can do. So, but equally for me, everything is inflammation until proven otherwise. So it really is, it's like the spectrum of internal medicine you see here. I did ask PubMed, and it's not surprising that you see a spike of the publications in 2019 and 20, or 21 and 20, and that is basically because of COVID, thanks to COVID, I shall say. Because really what happened in the early reports that came from Wuhan at the time, and Marcel Louis was mentioning this, there were indicators showing that these patients exhibit a hyperinflammatory syndrome. So these patients had massively high ferritins, and a lot sometimes are raised, so the liver enzymes are raised, and this is something that we commonly see in patients with hyperinflammatory syndromes. And as research continued across the world, it became very soon apparent that immunosuppression may play a role in reducing the mortality in these patients, because, as you all have heard, the mortality is largely driven by hyperinflammation and ARDS, and then which leads to death in the end. This is when suddenly it became incredibly trendy to be a rheumatologist. You know, we received calls, colleagues asking us, how do you use tocilizumab? How does baricitinib work? What about steroids? When can we use it? When can we not use it? What about IVIG? So there was a huge interest, and obviously for us rheumatologists it meant that we had a lot of sleepless nights. If you look at, this is a work done by a colleague of mine, and it was a very, very nicely done review in the Lancet Rheumatology, and it really shows or outlines the theoretical reason why anti-rheumatics or immunosuppression work in hyperinflammation, or especially related to COVID. So, for example, steroids, they suppress basically your whole immune system. Baricitinib, anakinra, this is an IL-1 antagonist. We have tocilizumab, so that's anti-IL-6. It's a hugely pro-inflammatory cytokine. And eculizumab is basically inhibiting your complement system. So it's all within the stage of, in some patients, in the stage where hyperinflammation is the main driver of their poor clinical state. So again, then I also sat down and thought about how do I actually define immune thrombosis? And I don't think there is a clear wrong or right answer. But really, thrombosis and inflammation are separate but interdependent physiological processes. And the innate immune cells, so your neutrophils, your macrophages, they really talk to the platelets, and they activate the coagulation system, and that is the term which covers immune thrombosis. And once that system is out of order, so usually you have a nicely balanced, but usually when you have excessive activation of your immune thrombosis, then it's very likely that you will need to treat that process with other than anticoagulation, because you will need to inhibit the underlying driver. So just a reminder, I need to remind myself all the time, innate immune cells, so these are the neutrophils and macrophages, and they all communicate nicely with each other. They've got lots of cytokines they secrete, and then you have your adaptive immunity, and that is what gives you the immune response in the end. There are a few, or at least 3 overarching principles I thought I'm going to line out here. The first of all is, if we remember that coagulation actually evolved as an effector pathway of the immune response, which then leads to a fibrin trap to prevent bacteria from disseminating. Because really, if you brush your teeth in the morning, and I said this the other day as well, if you brush your teeth, you will almost certainly end up with a little bit of bacteremia. And the reason that you don't die of sepsis is because you are actually able to build a fibrin trap. It's clever, it's fascinating. And this is this is work. This is a review done by a cardiologist, clever people. So this group is in Munich. It's Konstantin Stark. I haven't heard of them before, but I was quite impressed by their beautiful illustrations in the Nature Review. So this is a nice illustration of bacteria entering your vessel wall. And what happens is actually your neutrophils kick off and they activate your coagulation and you end up with a fibrin trap. And luckily, so the fibrin trap is here, but luckily you have a system in place which makes your thrombus to resolve, because otherwise you would probably die very shortly after you've got a bacteria entering your system. So this is all in balance. Inflammation and thrombosis are intertwined. What does that mean? So again, I'm going to cite his work because I was quite fascinated by the beautiful illustrations here. So your platelets orchestrate the prothrombotic immune response in venous thrombosis. And we heard about this yesterday. Usually a venous thrombosis is kicked off because you have a reduction in your blood flow. But what happens is you've got these amazing mast cells in your vessel walls, and they secrete histamine, and basically your innate immune system is on fire. Then you have your macrophages and your monocytes. They all, they start secreting IL-6, IL-1, TNF-alpha, and they really, really recruit to that place. And you end up having you end up building up thrombosis. So this is what happens. And by listening to the talks we've heard so far, we've always been discussing what happens here, because in the VTE world, we're trying to resolve the clot, and we're trying to prevent this from happening again. But shouldn't we be looking more uphill to actually prevent a recurrent thrombosis from happening? I'm just asking a question. I don't know the answer, but I believe so. Because actually our cardiology colleagues, they are already doing that. If you look at the arterial vessel wall, and again, here, this is something you may remember from your textbooks, at least this was something that stick to my mind. So the reason that we build the arterial clots is that we have an exposure of the subendothelial matrix. You activate your platelets, and the system kicks off. You've got your neutrophils and a lot of other your innate immune cells, and you end up having your thrombosis. So in the world of cardiology, they have realized, well, actually, there might be a role for immunosuppression or for immune modulation in the prevention of recurrent arterial thrombosis. For example, they've been trialing canakinumab. They've been looking at colchicine. Colchicine is an old anti-rheumatic. It was a study that was published from Amsterdam, or I think from the Netherlands somewhere. Very impressive, and I was really glad to see that people are thinking in alternative ways. So thirdly, treatment of immunothrombosis may require treatment of the inflammatory process. And I'm not going to bore you with any more pictures, but because right now here we've actually brought some cases, and I hope that we can get kicked off a discussion. Over to you.
So I'll start with first. So I'll start with case one. The most prominent recent example of immunothrombosis, as you've already heard, is COVID, which is really a good example for these severe consequences of this interplay between inflammation and thrombosis. So this case may sound familiar to many of you. It was a 51-year-old, otherwise wealthy man who had some initial symptoms. On August 22nd, he complained of mild dyspnea, some diarrhea, and 4 days after that, he tested positive for SARS-CoV-2. Then at day 10, after a start of his symptoms, he had progressive dyspnea, and he presented to our ED. He was hypoxemic. He had an increased CRP of almost 200. He had mild leukocytopenia with lymphopenia. He had an elevated D-dimer, which was about more than twice the upper normal. The phases of COVID-19. The disease is usually or is characterized with an initial phase of a viral replication. In this phase, patients are either asymptomatic or just complaining of mild symptoms, constitutional symptoms, fever, dry cough, and they are usually managed as outpatients. And then about 15 to 20% of the patients, they have a worse course, and they experience shortness of breath with or without hypoxemia. They present to the ED, they need to be hospitalized. This is when really the inflammatory response, host response, starts to kick off, and then about 5% of all patients, they really progress to severe COVID. They require ICU admission, and this third phase is characterized by really a hyperinflammatory host response where people develop ARDS and organ dysfunction. So if we look at our patient, he is probably about in this second phase with moderate disease. He does not require organ support yet, but he already shows signs of hyperinflammation. So immunothrombosis plays a key role in the pathophysiology of severe COVID. This is why I show you this graph again. I will not go into details because Karen already pointed out the mechanisms that lead to immunothrombosis, but just briefly, the SARS-CoV-2 virus can infect any cell that expresses a AC2 receptor. This internalization of the receptor already leads downstream to a procoagulatory state. Then also the virus is reported to be cytopathic. It can lead to apoptosis, and these processes, along just with the pure presence of the viral proteins, they lead to inflammatory state with release of cytokines, with infiltration of innate immune cells, which all downstream lead to a disruption of or activation of the coagulation, and then finally to immunothrombosis. So this is this overall phase of this hyperinflammatory host response eventually leads to an exaggerated immunothrombosis and to thromboinflammation, to microthrombi in the vascular system, which in turn leads to organ dysfunction. And this immunothrombosis, it plays a key role also in the development of ARDS, of multi-organ dysfunction. It leads to a systemic prothrombotic state, which eventually can also lead to avert thromboembolism, as we have also heard this morning and yesterday. And early autopsy studies from China also showed that the vast majority of patients who were undergoing autopsy, they showed these pulmonary microvascular thrombi, and also many of them showed thromboembolic events. So this really highlights the key role of thrombosis in the contribution to death of patients with COVID-19. So if we look at these pathways, there are several components that can be targeted by immunomodulatory treatment. So as you all know, steroids have been the first agents that have been shown to reduce mortality in COVID patients, and steroids really have a pleiotropic action on all of these immune pathways. And then as Karen already pointed out, tocilizumab has also been shown to reduce mortality in patients with severe COVID-19. It is a IL-6 inhibitor, and it is now recommended by most international societies as well as the WHO for the treatment of patients with severe COVID-19 requiring ICU admission, as well as moderately ill patients who do not improve with usual care. Then there are several other agents that are being tested in clinical trials, such as eculizumab, which is an inhibitor of the terminal complement pathway. Infliximab, this is a TNF-alpha inhibitor, which is being tested currently in the Solidarity trial, the WHO-sponsored multinational trial that you may have heard of as well. Then anakinra is an IL-1 inhibitor, as well as other agents that I'm not showing here, but I would like to briefly touch also on baricitinib. It is a JAK inhibitor, which has anti-cytokine effects as well as antiviral effects. It can inhibit the entry of the virus into the cell as well as the intracellular replication. And we just, or it was just a study published a few weeks ago in beginning of September showing effect of baricitinib on mortality in a randomized trial, including moderately ill patients. And the good thing about baricitinib, it's an oral agent. So, but however, this was not a primary outcome of this trial. It was a secondary outcome. The primary outcome of clinical deterioration was not met in this trial. However, it was actually the first agent that was approved by the Swiss FDA pendant as a treatment for COVID. I'm pretty surprised because I think we have better evidence for other agents. But anyways, also colchicine is an interesting agent, as you already heard from Karen. It has several effects, anti-cytokine effects. It also inhibits formation of the neutrophil extracellular traps. And it has also been tested in ambulatory patients in a very large trial in ambulatory patients with suspected COVID, and it didn't meet the primary endpoint of a reduction in hospitalizations or death. But when doing a sensitivity analysis, just including patients with confirmed COVID-19, it did significantly reduce hospitalization or death. So an interesting agent too, and there are other trials going on. So except for steroids and tocilizumab, are any of you using any of these other agents already in your hospital, or do you participate in trials using these agents? So no experience with these agents either. So we are participating in the Solidarity trial, so I'll be interested to see what comes out. So back to our case, the patient at admission, he received an initial treatment of oxygen as well as dexamethasone and prophylactic low molecular weight heparin. On day 13, he was given tocilizumab because he didn't improve, and he further deteriorated on day 14. After start of symptoms, he was put on high flow oxygen. Then 1 day later, he was transferred to ICU and he required mechanical ventilation. And eventually, because we are VIII spring school, he also developed segmental pulmonary embolism. So even with the provision of these anti-inflammatory agents, we could not stop this, his clinical deterioration. So we have already seen this slide. When considering immunomodulatory agents for the treatment of patients with COVID, we really have to take into account this window of opportunity. And most of these agents really play a role in patients with moderate to severe disease here. And we have to keep in mind that maybe in patients who have already developed multi-organ failure, it may be too late to initiate these agents. It may be too late for them to have a beneficial effect because the effects of immunothrombosis, of organ failure, of hyperinflammation may not be reversible at that point. But as we heard yesterday and this morning, and as you have certainly also read, there is new evidence from randomized trials suggesting a benefit of therapeutic anticoagulation in patients with moderate COVID, patients who are treated on the wards, while there is no benefit of anticoagulation in patients with severe COVID in the ICU, and these patients even showed an increased risk of bleeding. So maybe, who knows, what would have happened if we had put this patient already on therapeutic anticoagulation from the beginning. And I'm also wondering what you guys are doing in your centers. Do you already treat moderately ill COVID patients with therapeutic anticoagulation?
In Italy, yes, we change our practice according to the recent trials.
Yes, it's interesting. So we had this discussion internally, and I think people are afraid to do this. People are afraid of bleeding complications, even though we really have this this evidence now. And I think, or I don't know what your opinions are, but it may be that we have maybe initially expected otherwise. We have observed these high rates of VTE in ICU patients, so at least I have expected that these patients may be the one that benefit from anticoagulation, and now these results came out and were a bit counterintuitive. I don't know if people had other impressions. Did someone expect to see this?
Hypothesis underlying the multi-platform trial and the rapid trial and others that low molecular heparin would actually impact on disease course. Oh, apologies, yeah. So for me it wasn't counterintuitive, and yes, we participated in the rapid trial, and we haven't yet changed our institutional policy, but yeah, it's an interesting discussion. I wouldn't have thought that the benefit would be in the severe patients, because if you are aiming to impact on disease course, then perhaps the optimal time to intervene is early. What do you think, Chris?
So I think you're completely right. I mean, your opinion was now shown with evidence from randomized trials. Any other thoughts? Is anyone still using prophylactic anticoagulation in moderately ill patients, or are we the only one? Okay, so, yeah, Dr. Huisman. I hope good.
Yeah, this is asterisk again, but I'm not the only asterisk. Yesterday we had a discussion, and I have great hesitations towards the platform design. This is a black box which cannot be explained by even the highest quality statistician, and they say this is simple because it is this black box. And that's the end of at least a discussion I had. They're very selective patients. If you look at what they have done, they are very proud, but 1,000 patients, a bit more, all these countries, all these centers. I know they've been busy, but multi-platform. So I'm not convinced of these studies, and the outcome is counterintuitive. We have discussed this before. So based on that, we have said, and I'm not the only one, I know, I can tell you, it will soon be published, the ASH guidelines. They will not be changed on the basis of these studies. So will stay the same, the advice, in not therapeutic anticoagulation in the ward. So, and we stick to the what we did before without evidence. And I know we have to move on, but to give therapeutic anticoagulation on the basis of these trials is too much for me.
Thank you very much for.
I'm wondering what other people say, because the field is moving fast, and we will continue to see these patients coming on. So, and they will be different, by the way, because talking immunothrombosis, thing you didn't touch was we see a lot of transplant patients now coming in with COVID, patients with autoimmune diseases, and they get COVID because they either not been vaccinated or they don't have a qualified vaccination reaction. I don't know if you've touched on that, Karen, but this is so the population dramatically changed, at least in our academic environment. New challenges.
Yes, so I'm happy to hear these insights. So yes, we decided to wait for guideline recommendations to support whatever decision we will take. So I will be looking forward to seeing what different guidelines say. Good, but just as a last comment, so also for antithrombotic medications, studies have shown anti-inflammatory effects. So for heparin has been shown to disrupt these neutrophil extracellular traps. It has also been shown to neutralize histones. I'm not going to go into the anti-platelet agents, but also for DOACs, it has been suggested that they inhibit protease-activated receptors and thus have an anti-inflammatory effect. So what I have heard as a hypothesis also that for the fact that heparin had this positive effect in patients with moderate COVID is that it does exhibit this anti-inflammatory effect, which targets components which really play an important role in this mechanism of immunothrombosis. All right. Take a deep breath again. I will hand over to Karen.
Yeah. Very good. Thank you, Christine. Are you ready for another case? Or do you need a coffee and some dinner? So the second case we've brought is a case from my clinic. And as you know, we are very simple rheumatologists. We need classification criteria, we need, and then we've got all these weird diagnoses, and we treat with immunosuppression. So this is a case, I've taken it because you may or may not ever come across it. But sometimes when you hear something, it rings a bell, and that certainly happened to that doctor who saved the patient's life. So this is a 45-year-old gentleman. He lives in London. He is white Caucasian, and he has been known to have a Bechet, and he had that disease diagnosed when he was around his 20s. So Bechet is, I'll be briefly mentioning that later, it's a chronic inflammatory disease. It's not antibody-mediated. It's a disease that's related to the HLA-B51 tissue type. So usually what we do with these patients is we immunosuppress them because they will otherwise continue to develop ulcers, mouth ulcers, genital ulcers, sometimes brain lesions. It can be a pretty nasty disease, and it's not a disease that is very easily diagnosed. Anyway, so he was a patient who was stable on his azathioprine, a small dose. And for that reason, we discontinued the therapy a few years after he was diagnosed. And that's something common we do in rheumatology practice. When people are in remission, which means that the disease is under control, we would taper immunosuppression and we would see how it goes. We usually don't discharge them. We would follow them up once a year and see how they're doing. But that's what we did with him. So he was discontinued in 2016 and was actually stable. In January 17, he was admitted to the ED department because he had an increased swelling and pain of his left leg, and that was following a period of immobility after he had broken his leg. He was diagnosed with a DVT, and he was treated at that time with lumaliquid heparin, and then afterwards with DOACs with a rivaroxaban actually for 3 months. This is the slide on Bechet, so you can see here it can actually be pretty nasty disease. So usually what these patients have are painful ulcers. And I'm saying painful because lupus patients, for example, usually these ulcers are not painful, but in Bechet they are very painful because these are ischemic lesions. They have usually, well, some of the patients have recurrent iridocyclitis, and then on the skin you sometimes see what people think could be acne. So in his case, he was discharged after the treatment the DOAC was stopped after he completed the 3 months course. And in February 2017, he developed what was suggestive of post-thrombotic syndrome in his left leg and worsening of the swelling. He again presented to the ED department, and there was a suspicion of recurrent thrombosis. And he was started on warfarin at that time with a target INR of 2 to 3. He wasn't seen by us in that period. So later that year, he again developed swelling of his left leg, and again an ultrasound did show thrombosis actually going from his groin down to his knee. And again, the radiologist who did the ultrasound thought that was a new clot, and the doctor in the ED department at the time took a very thorough history, and actually the patient also reported new painful mouth ulcers. So what he did, he called us. And he called the on-call. I was actually on-call at that time, and I thought, well, this is something we need to find an underlying cause why he continues to clot despite anticoagulation, and also now he exhibits signs of disease activity of his Bechet's disease. So we took his case to the multidisciplinary team in the next week. Oh, it doesn't work. There we go. And we sat together, and usually when we make decisions upon escalating or restarting immunosuppression, we would do that as a team. In his case, I thought, well, azathioprine is not standard of care at the moment, and we probably need to start him on the biologic. But starting a biologic usually requires that you do a careful workup. So they get a TB screen, they get a hepatitis screen, and you need to be sure that there's no infection on board, because otherwise you will end up in trouble. And we at this stage decided to start him on adalimumab, 40 milligrams every 2 weeks. That's the standard dose we usually use for patients with rheumatoid arthritis. We also continued the VKA therapy, and shortly after, he was actually in what we call disease remission, and he's actually, until now, very well. So in the future, a few years ahead, we will probably be thinking of trying to taper his immunosuppression, but for now, he remains on a little bit of, I think he's on probably 1 milligram per kilo immunosuppression at the moment, and then we will probably discuss whether we ever dare to take him off the anticoagulation. I do not know. But this is just to show you that sometimes if things don't add up, and if you have patients who have an underlying disease, use Google or use UpToDate and just read up on things, because people don't necessarily link Bechet with a prothrombotic or with a disease that may cause thrombosis. And for him, it might have well happened that he would have been discharged and never got started onto biologics, and this could be detrimental for this patient. So he was lucky, and he had a very good doctor taking a thorough history and actually getting into contact with his rheumatology team. Again, this is roughly the same slide we've seen before, but this is not specific to COVID. This is just to show you the action of adalimumab here. It's one of the TNF inhibitors we've known for the longest. I think we even use TNF alpha blockade in pregnant women, not particularly adalimumab, but certolizumab. So it's a drug where we have good and long safety data. So it inhibits or it modulates your innate immune response and thereby inhibits your autoimmune disease. I think we'll hop over that. Do you have any comments or any questions? Have you ever seen a Bechet? Oh, there you go.
Yeah, I was just wondering, how often do you see this kind of thrombosis with Bechet, but also with the other auto-inflammatory and autoimmune
disease? I think this is a very good question, and the simple answer is I don't know, because obviously you may be biased if you work in tertiary centers where you see a lot of the very sickest population of that disease. So I don't have any incidence rates, so I simply do not know. But what I do know is that there was a recent publication on in the Lancet. That was on Swedish population-based data showing that the incidence of thrombosis in patients with, I think it was rheumatoid arthritis and spondyloarthropathies, is actually rising, and it's definitely there. It's something we do not routinely think about, I think. So again, it highlights that talking to each other is actually sometimes can give a bit of a different angle if you talk disease management or yeah. So
maybe just to also comment on this, I'm not a rheumatologist, I don't see these patients on a regular basis, but I can recall at least 2 patients who presented with recurrent VTE. One really had several recurrences, catastrophic thromboembolic events, and until someone really took a good history to diagnose also in his case Behçet's disease, and this really underlines the importance of really taking a good history and looking at the patient and thinking about other underlying causes if a patient presents with recurrent VT using full dose anticoagulation. It's not always cancer.
So as an angiologist, probably the automatism would be if a patient comes and has a recurrent proximal left side DVT, just to think of May Turner, because in that case the right common iliac artery is compressing the left one, so after the first thrombosis you have scars, and in that point basically there is no flow, so it probably would be enough that the patient doesn't take the pill for 1 day and then forms new thrombus there where the compression is. So, but it's nice to see that basically there are different automatisms which are depending basically on the experience that you have. And would you test these patients routinely for antiphospholipid antibodies?
Probably I would, but I might be biased. So yeah, I mean, I would. I mean, I've got a very low threshold for doing that, but again, it's. I think it depends where you work. It depends what population you see. So yeah. I would test them for antiphospholipid antibodies. Yes.
Good. Any other questions or comments?
Oh. Yes. Do you want?
So last question.
Oh yeah, thank you. I would like to get back to the topic of COVID-19 and anticoagulation. And in the clinical settings, I work in the intensive care unit as an anesthesiologist. And despite the therapeutic dosage of anticoagulation, we do see constant events of thrombotic complications. I mean, PEs especially, and people are dying from these complications. And for these 2 years, we haven't seen any major bleeding with a life-threatening as a life-threatening complication. Is it not too early to advise for the intensive care unit doctors to get back to the prophylactic dosage of the anticoagulation? Maybe we are giving too little anticoagulation for these people. I mean, maybe this dosage do not show any effect because of it's too little for these patients, because of the prothrombotic state. I mean, because the takeaway message from this spring school, I have to say that it's quite contraindicated. I mean, it's very, very complicated to wrap the head around. I mean, to give the treatment therapeutic dosage to the ward patients and prophylaxis only for the ICU patients. It's kind of counterintuitive. Thank you.
Yes, so this is also what we thought, but looking at the evidence that we have from randomized trial, looking at therapeutic dose anticoagulation in ICU patients, we have as the multi-platform trial as well as the inspiration trial, which do not show a better outcome in patients with higher dose anticoagulation in a randomized trial clinical setting. I think this is the evidence we have at the moment.
But what to do then? Because all our patients in our intensive care were on dexamethasone, so on some sort of immune suppression.
The dexamethasone is very, very efficient immunosuppressant.
But we had quite many prothrombotic events, including PE, but also thrombosis in all beds, vascular beds, including arterial ones, all over, during the treatment with dexamethasone. So maybe we don't do something what we could do, and considering the immune mechanisms you just showed us.
Yes, so I think we have to come to an end. We can discuss afterwards, but as you have, or as maybe I haven't pointed out in detail enough, that tocilizumab is added onto treatment of dexamethasone, and this is also recommended now for ICU patients and severely ill patients. But in the end, it remains a disease with a high morbidity and mortality, that's correct. So thank you very much. Our take-home messages are inflammations and thrombosis are intertwined. Treatment of immunothrombosis may require treatment of the underlying immune process, and think about a potential underlying cause of thrombosis if you have a patient with recurrent thromboembolic events. Thank you very much.
Say very few things, and then Cecile will say all what is important, right, Cecile?
Thank you.
So we have one presentation. So we will talk about the red side of anticoagulation, which is bleeding and bleeding risk, and what this means for you and for us. And we have prepared 2 cases. Right. We have one presentation with 2 cases. Thank you, Cecile.
Okay.
So Cecile Trommer from Brest, professor of pulmonology, very soon. And me, old professor at the University of Mainz. And so we have prepared 2 cases to discuss with you. The first case is on whether you would anticoagulate the patient considering the bleed risk, or if the bleed risk is indeed as serious and as high as one might think. And the second case is, of course, what is more important and more acute, so what you do when a patient who is on anticoagulation bleeds, indeed, and this is some serious bleeding. So Cecile will be doing the bleeding, I will be doing the risk of bleeding. So, that's on my side. So, this is a true case. This is to be very honest, it's a relative of mine. So this is an elderly gentleman, 83-year-old. He is retired. He was very intelligent until a few days or weeks ago. He had no previous illness, was taking no medication, was riding his bike to go to work. I mean, he did some mathematical calculations for a bureau until 3 weeks ago. So now things went down relatively rapidly. He was referred by his family physician to the hospital with suspected senile dementia and or cancer. So I don't know if there is acute dementia. I'm not a neurologist. Is there acute dementia? I don't know what you think. Well, anyway, so what happened is that that was really quite strange. He was feeling very weak over a period of 2 weeks, exhausted, okay. Difficulty climbing the stairs, that was alarming. Then he fell off his bike twice, so twice he fell off his bicycle. He had no major injury, at least he has no, so that went relatively well. 3 days ago, he tried to take his car to go to work, and he did not know how to start the engine. And then, on top of that, he said that he had lost 4 kilograms over the past 4 months, although he assures that he has a lot of appetite and everything is, I mean, he eats a lot. Well, he has no specific cardiac, respiratory, gastrointestinal, genitourinary symptoms whatsoever. He had a PSA recently, and it was okay, he said. So, excuse me. So we examined him. At that time, the patient was quite oriented, so he did not know why he's here. So he apparently, he said everything is okay. He had some period of dizziness, but now he's doing fine. He is a gentleman who is quite tall for his age, but he's very, well, he has a very low BMI, as you can see. He only weighs 58 kilograms. The examination of carotids, hearts, and lungs and abdomen is normal. He has he does have an he has an irregular pulse of 58 per minute, and his blood pressure is 110/70. Come to this. And then there was some initial examination, chest X-ray, ultrasound of the abdomen, because everyone thought he must have cancer and has lost so much weight. But to make it short, we found nothing. The CT of the head also showed nothing really. So no ischemia, no hemorrhagic infarcts, no space-occupying lesions, and no just a slight diffuse cerebral atrophy. So this is this patient's original lab and the original ECG. You can see, what does the patient have? Does it say it up there? No. So many thrombosis specialists cannot read an ECG. Just want one thing? Yes, right, absolute arrhythmia, atrial fibrillation. Okay, so otherwise this is not really, he has an alpha axis, so he has a far left axis. He has an alpha axis of, I think, -30 or something. So this is, okay, but this is an elderly gentleman. But what is true, he has atrial fibrillation. Okay, and, excuse me. And so this is his original, so it is in German, but I think most things are quite easy to understand. So Cecile was asking me what is Eiweiß, so this is the white of the egg, that is the protein in German, right? So I don't know if you have it in other languages. So that's the total protein, because we were afraid he was malnourished. Well, anyway, the only thing that is here, I do not know, I put it in a presentation I gave you this afternoon, but I think, yeah, no, it is here, very good. So the only thing that is here, so his eGFR was very good. You see he has a creatinine that is only 0.89, but do not forget he only weighs 58 kilograms, right? So he's not someone who's 120. And the thing was that indeed for a couple of days he was dehydrated. His eGFR fell to 38, then it went up again to about 60. So he is now normal, right, or almost normal, but he's labile. He's going up and down. Okay, otherwise there's nothing really so impressive. So he has a very, very mild thrombocytopenia, which, however, has been described, and otherwise there's nothing particular. Okay? Okay. Well. And this is his EKG. This is echo, excuse me. should be able to distinguish an ECG from an echo, right? And this is this patient's echo. So what do you think that this, is there something that you don't like? Right heart enlargement. That was indeed 42, the right ventricle, the D1. Hmm? Yes, yes. What do you think about his atria? 28. Big. This one is smaller. This is, oops, excuse me. That's right. This is the left ventricle, the cross section. Is this a patient with pulmonary embolism? It doesn't have to be one just because I'm showing it, right? I mean, I can also show. And this was the measurement of his pulmonary systolic pressure, right? So we only have a gradient of a tricuspid valve of 28 millimeters mercury. So this is not a patient with pulmonary hypertension. This is not a patient with acute pulmonary embolism. Why does he have big atria, especially the right one in this case? But it's a little bit late to find out. There have been some patients with ASD who were found at the age of 8. I did my doctoral thesis on PhD and on ASD, and the oldest patient I found was 82, but that was some time ago. So nowadays I cannot think you will find an 82-year-old with an ASD. He does not have a shunt disease. So this is a patient, well, let's say, so the end of the line, I did not do this to show you the echo, but the end of the story is that this is an echocardiogram which is, well, let's say more or less acceptable for an elderly person. The large atria should be attributable rather to the atrial fibrillation. I mean, we do have this situation, right? But we certainly have no right ventricular dysfunction, no pulmonary hypertension. Okay, so now comes the question. We should do now for this patient. Shall we, who is, this is 83-year-old man? Oh, sorry, yeah, you can hear me? That's better, huh? So, 83-year-old man, now we found atrial fibrillation. He had some strange neurological symptoms for which we have no explanation so far. So what will you recommend now as thrombosis specialists, right? I mean, you're not a neurologist. I mean, if we have a neurologist, we can have your ideas because we have not fully resolved the case yet, to be honest, neurologically. But, so, give anticoagulation. This is a patient with a high risk of stroke. He has atrial fibrillation. B, well, I mean, he's a 58-year-old gentleman. He has a BMI of 17. No risk factors other than his age. Well, 2 recent falls from the bike. No. Anticoagulation, yes, but in this age group, I would not give a DOAC because there is too little experience with people who are 83, and I need further tests to decide. And if you say yes here, then what test? So who is for option 1? You want to anticoagulate? 1. Oh, what? 1, 2, 3, 4, 5, 6, 7, 8. Okay, 8 people want to anticoagulate this 83-year-old gentleman with atrial fibrillation. B, no way. He has fallen twice in a week. It's 58 kilograms. 1. Yes, no. C, yes, but I mean, what is the experience with DOACs or NOACs in 83-year-olds? No, no one likes this, okay? And D, it's always a good solution. I need further tests to decide. You save some time, right? So, okay, but then you must say what test you need to decide. I mean, just...
First, I would probably do a bleeding score.
Okay. Very good. So this will take us to the next slide. So, okay, so what do you think, Cecile?
So I totally agree with Lina, of course. But do you think the bleeding score are really efficient, and do you use it in daily practice?
Yeah, we use the has-bled for duration.
Okay.
And we use the VTB for...
Also, okay. Okay.
It's just
Yeah.
estimation of the risk, but it's a tool.
Yeah, it's a good answer.
And in any case, that's a very good idea to go to the next. So do not worry, the theoretical slides will be very few. So, okay, old gentleman and renal function which fluctuates, and he has fallen twice. And so the problem with bleeding scores, be it has bled or be it VTE bleed or whatever other score, it's not the problem of the scores. It's the problem that many of the factors that come into the bleeding score are factors which are also, thank you, which are also factors for thrombosis. So we have overlapping factors. If we look, so this is the patient with AF, right? Not everyone has to have VTE here. So he has AF, but you can see, so age is here, but age is also, of course, in the Hesbled score, right? So it affects both. So hypertension affects thrombosis, stroke and hemorrhage. And previous stroke affects stroke, yes, thank you, but it also affects hemorrhage. So there was a very nice Swedish study, sorry, Sigrid, and that was a study which which was done in the VKA era. So they did it in the time where they had the Chatzvas, but also the Hesbled score. To make the long story short, the only patients who did not benefit from VKA anticoagulation were the patients with the maximum Hesbled score, which was 6. All the others benefited. So overall, the thromboembolic risk was the predominant, and it was 0.7% with the Hesbled score of 6. You must have a lot of bad luck to have a Hesbled score of 6. So that is the idea, right? That was the problem, and so you can see here whether it is Hesbled at least 3 or higher, clearly in